Shall we start? Okay. Bismillah wa salatu wassalam ala Rasulullah. Again, it's great to have you here, gathering again for another event, and that is the fourth Ssbmt and SSH combined annual conference. Again, this is the fourth year that the two societies hold such a combined meeting, focusing on the various updates in the various disciplines of hematology. And as you are all aware of the fast advancement that takes place almost every month in the field of hematology and the various disciplines that cannot be covered by one event or two events or even three events a year. And that's why the importance of having you here, networking, getting engaged with peers, discussing the latest updates. Thank you for the support of the two societies, and thank you again for being part of the members of the two societies. And we shall continue and advance again our setup and our progress, inshallah. So this event is not only covering or organized by two societies, but also covers various events that we combined in one event, and that is the annual meeting of the Saudi Society of Hematology, the annual meeting of the Pan-Arab Hematology Association, and the Hematology Year Review of the Ssbmt, and the Saudi Group of Hematology Research annual meeting. And I wanted to focus on the Saudi Group of Hematology Research a bit. So this group, again, stems out of the two societies, and we wanted to advance it and encourage, again, the research locally in the field. We try to invite and enrich our program always with local experiences based on local research that's conducted in our region. Less than 2 months ago, we held the annual meeting of the Saudi Group of Hematology Research in Orlando at the American Society of Hematology, where we had, again, abstracts that submitted to the ASH, presented in this group and discussed. And again, the aim is to focus on the region and to see, again, the progress. We have seen more numbers of abstracts shared at international meetings, and that's a good sign, and we wanted to encourage this. At the same time, we have created the Hematology Research Award, again, to award those winners who contributed in abstracts or research from the region and participated at international events. So keep in mind, those who are planning to submit abstracts at international meetings or papers to be published in 2026, to submit your name and submissions, again, to the award website, again, for a chance of winning the awards. Tomorrow we will witness the awarding of the winners for the 2025 Research Award. In addition, there is the Hematology Career Award, which is granted to those who have exerted, again, their lifetime serving hematology, whether in education or research or making impact locally and internationally. So make sure you submit your nominees again to the award, the Hematology Career Award website. Today we're supposed to have Dr. Ahmed Absi, who is the chair of the scientific committee, and I would like to thank the scientific committee for putting the program, a great program we'll see today and tomorrow, inshallah. Ahmed Absi sent his apology. He wasn't able to join us because of medical reason. However, again, we thank him. The program will cover various disciplines in hematology. We have great speakers. Thank you, our speakers, again, for being a part of this event and for your support. And also, I would like to thank the attendees again for being here and getting engaged with us and your support. And thank the sponsors of the event. Our main sponsor is JSK, and our platinum sponsor is Vertex and J&J. Again, thank you for your support. Without the support, we will not be able to be here. Also, I would like to thank the JZAN group again for hosting us and for being supportive and facilitating again the efforts to be here today among, again, our colleagues in JZAN. So without further ado, I would like to invite Dr. Ahmed Barifah, who is the president of the Saudi Society of Hematology, for his remarks. Thank you.
بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. الأساتذة والزملاء الكرام، رؤساء الجلسات، المتحدثين، الحضور الكرام، صباح الخير وجمعة مباركة جميعا إن شاء الله. أرحب بكم جميعا باسم الجمعية السعودية لأمراض الدم في المؤتمر المشترك الرابع بين الجمعية السعودية لأمراض الدم والجمعية السعودية لزراعة النخاع العظمي والخلايا الجذعية. هذه الشراكة غالية علينا يعني جدا، ونشكر سعادة البروف أحمد العسكر وبروف محمد قاري على بدء هذه الشراكة والاستمرار فيها، يعني في هذه المبادرة التي تهدف إلى توحيد الجهود وتركيز الأهداف، بحيث أنه نجتمع جميعا بهدف واحد: نشر المعرفة والتعلم من بعض ومشاركة الحالات. فجدا فخورين وسعيدين بهذه الشراكة المستمرة. شكرا جزيلا لحضوركم، وإن شاء الله تكون يومين مليئة بالعلم والتعلم. وشكرا أيضا على الاستضافة من المجموعة في جيزان، دكتور بكار، دكتور حافظ ملحان، وعلى الاستقبال الرحب. Dear distinguished speakers, attendees, moderators, thank you for being here in this fourth conference of the combined SSH and Ssbmt. And we wish you, inshallah, very fruitful meeting and enjoyable stay in Jazan. Thank you. Okay. So we'll start with the first session titled Acute Leukemia. And I would like to invite the moderators, Prof. Rafat Abdel Fattah from Egypt. Prof. Rafat is well known in the field of leukemia, and always very collaborative work between us, inshallah, will continue. So we're very glad to have you, Prof. Rafat, with us. And the second moderator is Dr. Wala Raj Khan from National Guard Hospital in Jeddah. Welcome, Doctor.
Assalamu alaikum. First, I would like to thank the organizing committee for inviting me for this meeting. And we can start our meeting today as the first session by Dr. Mutab Al Ahmadi. Dr. Mutab will speak about the update of acute myeloid leukemia in 2026.
Okay, thank you. Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everybody. Thank you, Scientific Committee, for invitation, and thank you, Dr. Rafat, for nice introduction. My talk today will be focused on AML in 26, mainly the integration of menin inhibitors in therapy of AML. As you know, the risk of relapse and overall survival in AML patient improved over the last 3 and 4 decades. This data shown from SWAG Cancer Network improving the relapse rate over the last 3 decades until 2010 and reflected in overall survival, mainly due to intensification of the chemotherapy and good supportive care. And the majority of the patient in this graph was receiving the intensive chemotherapy 7+3 as an induction for AML therapy. Also, as you know, the low CR rate, it's correlated with the poor outcome and poor overall survival, especially if we have treatment-related AML. If they have CR rate around 61, it's reflecting in poor overall survival. As you know, the ALN risk stratification in 2022 was updated with some of the main changes, mainly the MBM1 now considered to be adverse risk factor if they are associated with the poor or adverse cytogenetics. Since 2017, we have the KMT2A as adverse risk factor. Also, it's done multiple study for validation of this ALN risk stratification, which showing the 3 category with reflected in the overall survival. But to consider this risk stratification was done in intensive chemotherapy patient, MRD analysis post-induction was not included, which might change the risk stratification post the induction. This is the MRD in AML patient. This is the meta-analysis including 81 publication, more than 11,000 patients, showing the overall survival 5 years, 68% for MRD negative patient compared with the 34% only in MRD positive post-induction. Since 2017 until today, over the last 8 years, we have almost 15 approval for new therapy for AML, including target therapy, BCL2 inhibitors, different type of FLT3 inhibitors, IDH1, IDH2 inhibitors, GO, and also the oral hypomethylating agent. And finally, in 24 and 25, we have the menin inhibitors. We have 2 agents now, revumenib and ziftomenib. MBM1 always associated with good prognosis at diagnosis, but if it's the patient relapse, doesn't matter and have no impact. If you see the left side of the slide, the overall survival doesn't matter at time of relapse if the patient have MBM1 mutation or not. On the right side, venetoclax have good activity against MBM1 mutation in relapse refractory AML with around overall survival in 12 months, 59%. KMT2, it's around 5 to 10% in AML patient, always associated with poor outcome, especially in relapse, with the overall survival at 5 years less than 25%. Also, the incidence of relapse in the first line for the patient with KMT2A, it's around 66% in 5 years, with the overall survival less than 20% at 5 years. This is the NCCN recommendation for the genetic and genomic mutational testing in AML patient. At baseline, patient should have the karyotype, FISH, and NGS panel, and should be repeated in each relapse or progression, and should be done before the starting of the treatment. KMT2, it's linked always to adverse prognosis as ALN risk stratification. Co-mutation with KRAS and TP53, it's worsening the outcome. Mutation analysis, as you know, it's help us to decide for treatment intensity and eligibility for target therapy and transplant decision. AML, it's not a static condition. Each time of relapse or progression, we have different mutation and different driver mutation. KMT2 should be done by cytogenetics or FISH. NPM1 can be done by BCR or NGS. From the reported in menin inhibitor studies, high incidence of KMT2 in therapy-related AML. Prior venetoclax and FLT3 inhibitors have low CR rate in revumenib trial. Also, the co-mutation with IDH1, IDH2 showing improve the CR in the revumenib monotherapy in relapse refractory AML patient. This is algorithm suggested by Dana-Farber group for treatment of AML in 25 for patient with less than 60 years. We have core binding factor in NPM1, intensive chemotherapy plus GO, as multiple studies showing the overall survival improved with the addition of GO for core binding factor. For FLT3, upfront we have 2 approval for midostaurin and quizartinib, improving the CR and overall survival. Patient without target therapy usually go for intensive chemotherapy. Therapy-related AML going with the CBX 351 or intensive chemotherapy. TP53, it's suggested to have hypomethylating agent plus minus venetoclax, which came from the trial of aza-venetoclax showing the subgroup analysis for TP53 patient have improved the CR rate with using the venetoclax. After the induction, we'll have morphological assessment and MRD assessment. If the patient have still MRD, suggest to have hypomethylating agent plus the venetoclax. If the patient achieve remission, can proceed for the consolidation based on the ALN risk stratification, either to have chemotherapy or bone marrow transplant. Patient from 60 to 75, almost the same with more hypomethylating agent and venetoclax, but still we have the core binding factor and FLT3 have the same as fit patient. Patient more than 75, we have, if they have IDH1, it's approved to use IDH1 inhibitors. IDH2 is still using hypomethylating and venetoclax. And the decision for the consolidation depend on the virility of the patient and eligibility to have the consolidation therapy. For relapse refractory, which is have nowadays the addition of KMT2A as a category to use the revumenib. Also, the NPM1 now approved to have ziftomenib and revumenib as relapse refractory. The same IDH1, IDH2, if they have at relapse refractory, have the same IDH1, IDH2 inhibitors. FLT3, we have gilteritinib, it's approved for relapse refractory FLT3 mutation. Now we'll talk about the menin inhibitors in AML therapy. As you know, KMT2 and NPM1, when they combined with the menin as a transcriptor factor, it's transcription factor with the HOX A9 and MIS1 program, which is lead to the keep the leukemic cells have self-renewal without differentiated or apoptosis. If we have menin inhibitors, we block this complex of KMT2 with proceed to the differentiation and apoptosis of leukemic cells. Almost the same, but we have the different NPM1 and KMT2 complex, and that site of the menin inhibitors when they down-regulate the HOX A9 and MIS1. This is the menin inhibitors in the pipeline, we have the first two, rifaminib and ziftomenib, already approved by FDA. The next is still under study, waiting for approval with the promising efficacy and safety. Rifaminib approved now for KMT2A and NPM1 in patients with age more than 1. And ziftomenib approved for relapsed refractory NPM1 AML. NCCN guideline now incorporate all the target therapy, including the menin inhibitors. As shown in this slide, with the last update 2026, with the rifaminib and ziftomenib now approved for relapsed refractory. Menin inhibitors as a monotherapy for relapsed refractory. This trial, Augment trial 101, it's having relapsed refractory monotherapy rifaminib. The cohort of KMT2A having patient with AML, ALL, relapse, refractory, untreated relapse, with the median number of previous regimens 2 regimen, with the prior transplant around 44%. This is the overall response rate, around 67%, with the MRD negativity 64%, and 19 patients proceeded to transplant. This is the side effect for the cohort of KMT2A, mainly QT prolongation in 29%, and differentiation syndrome in 28% with all grades. If we have the NPM1 cohort showing the overall response rate 47%, with the median overall survival 4 months. If we have subgroup analysis for the NPM1 in rifaminib trial, we have the response based on the prior venetoclax exposure, 19%, with prior FLT3 inhibitors, 13%, with higher response with IDH1, IDH2 exposure before. And also prior transplant have 28 response rate. Also, we have the co-mutation. Rifaminib have activity against all the co-mutation, including the RAS mutation. The second menin inhibitors is ziftomenib as a monotherapy in COMET-001 trial. It's having in relapsed refractory AML. It's having the CR and CRh around 23%, and median overall survival 6.1 months, and have MRD negativity around 63%. The same overall survival, but in the responder patient with NPM1 in ziftomenib trial, showing the overall survival of 16 months, compared with the all the patient 6.1 months. The same, all the co-mutation have effect and efficacy with the ziftomenib trial. Also, the having showing prior venetoclax showing response in 14% for ziftomenib. Regarding the safety profile, differentiation syndrome around 24% in all grade, with no significant or clinical significant QT prolongation with the ziftomenib as a monotherapy. This is based on the initial waves of the innovation, have the 2 approval for rifaminib and ziftomenib. It's active in heavy-treated KMT2 NPM1 population. As a single agent, we have overall response rate around 47%, CR/CRh 20 to 30%. Also in KMT2, around 67% overall response rate. MRD negativity ranging from 60 to 64%, with the patient have proceeded to stem cell transplant if they achieve remission. Combination strategy for the menin inhibitors, it's increasing, assessing the combination with the trial, especially with the approval rifaminib, ziftomenib. Also the non-approval, the baloxamine. It's combined with the other target therapy like BCL2 inhibitors. It's combined with our intensive chemotherapy induction, and also the new menin inhibitors in Ssbmt, which is the last one now still in the process for clinical trial to prove the efficacy. Encouraging if this is the safe trial, which is combination, have all oral medication, oral decitabine, venetoclax, rifampicin. Overall response rate in relapse refractory, it's 41%. Also, they tested in newly diagnosed AML with 86% overall response rate. MRD negativity, it's 93% in relapse refractory and 86% in newly diagnosed. Also, the beat AML, which is combined rifampicin with azafin in older patient, either newly diagnosed, with overall response rate around 88%. Even the patient achieve remission and have no refractory after 1 to 2 cycle. 84 of the patient achieve remission after the first therapy. This is the overall survival. The median follow-up is 6.9 in azafin rifampicin combination, with 1 year overall survival 63%. If we subgroup to KMT2, it's 83 as overall survival for 1 year, and NBM1 for 55 overall survival. Also, combination of ziftomenib with venetoclax azacitidine in relapse refractory and newly diagnosed AML. 83 patients in relapse refractory and 40 patients in newly diagnosed, with overall survival 65% in relapse refractory and 89% in newly diagnosed AML. This is bluxeminib, which is part of the combination but still not approved, have good overall survival in relapse refractory and newly diagnosed. In relapse refractory, it's around 81% and newly diagnosed in 90% overall response rate. Also, if we have the newly diagnosed with a dose of 100 for bluxeminib, if we see the newly diagnosed having overall response 75, all of them having CR, but was a small number of patients, only 40 patients in this cohort of newly diagnosed AML. This is also combination, which is combined of doublet, bluxeminib plus venetoclax in relapse refractory KMT2 and NBM1 AML patient, showing promising efficacy with overall response rate 69% and composite CR is 38%. Also ongoing combination with other induction chemotherapy, which showing early efficacy of rifampicin with our intensive chemotherapy for induction newly diagnosed AML, but still immature data to have judgment about the safety and especially the toxicity. Also, combination of ziftomenib with induction newly diagnosed AML patient, either to have NBM1 or KMT2. This is the dose escalation for ziftomenib. Also, the overall for median follow-up, it's 24 weeks, with the median duration of response not reached, median overall survival also not reached. The last one in the menin inhibitors, Ssbmt, which is have showing activity in relapse refractory setting with patient with KMT2 or NBM1. Still waiting for the final result and updated data. Overall response initially it's 73%. Regarding the menin inhibitors combined with the chemotherapy for patient, it's reporting high response rate, especially with FIN-AZA. Still unanswered question about the correct combination, dosing strategy, safety profile. Menin inhibitor can be safely added to our induction or intensive chemotherapy, but the combination, it's better, or more intensive chemotherapy, it's better, still we don't know. Also, the menin inhibitors, especially bluxeminib and Ssbmt, proving more safer or low profile of toxicity compared with the previous two, but still waiting for the mature data, even the durability of the response. Regarding the safety of menin inhibitors, mainly the class effect for menin, it's differentiation syndrome across all the menin inhibitors, but with different grade, but around 15% all over the menin inhibitors. QT prolongation, especially with the rifampicin. Half-life for rifampicin, it's 6.4 hours, which sometimes help us to hold the medication if we have toxicity. If you see the ziftomenib half-life, it's 93 hours, but the last one, enzomenib, which is short half-life, 2 to 4 hours, which is having a limited toxicity due to early washout for the medication. Also, the ziftomenib have reported of pruritus as a side effect. Regarding the differentiation syndrome, as I said, it's ranging from 15 to 25. Grade 3, it's lower, less than 5, and usually it's manageable. Cytopenia, especially with the combination, mainly due to the part of the chemotherapy or venetoclax. Febrile neutropenia, also the same, it's mainly due to the combination chemotherapy. QT prolongation, it's always manageable, but should assess for drug-drug interaction and especially the antifungal and antiemetic, and correct the electrolyte disturbance to avoid it. GI toxicity, usually it's rare, but it's low grade. Mortality less than 3% for all, especially with intensive chemotherapy. Pattern of menin inhibitor safety experience. As I mentioned, the differentiation syndrome is class effect all over the menin inhibitors. QT, it's manageable. Pruritus specific reported to ziftomenib. Combination insights, it's ongoing assessment to additive toxicity, especially with the myelosuppression with the chemotherapy. And cytopenia mainly in induction or intensive chemotherapy related to our 7+3 or venetoclax. Potential challenge with increased risk of infection and cytopenia, especially with ongoing therapy and relapse refractory if we choose to continue on the menin inhibitors. This is just a principle how to do the baseline, normalize the WBC by cytoreductive or hydroxyurea to decrease risk of differentiation syndrome. We need baseline ECG to measure the QT interval, correct the electrolytes, drug-drug interaction. In early monitoring, in the initial 3 weeks, should have weight and renal function for the patient, frequent CBC and metabolic panel. But if the patient have worsening or new hypoxia, rapid weight gain, or sudden increase in WBC, should assess for differentiation syndrome and other febrile neutropenia and chest infection immediately. Ongoing monitoring after the 3 weeks, should do monthly ECG, CBC weekly if stable count, and watch for differentiation syndrome recurrence, especially if we reintroduce the medication or taper down the steroid. Just finally, 1 minute regarding the update of the paradigm trial, which is the azafin in young patient. This is their design of the study. They randomized 1-to-1 to receive azafin versus 7+3 or CBX-35. Primary endpoint, event-free survival, and secondary endpoint, overall survival, toxicity and MRD, and hospitalization index and quality of life. This is characteristic of the patient. They include 172 patients. The median age is 64, but the range is 23 to 79. Around 70% of the patients have adverse categorization by ALN 2022. This is their response, showing the overall response favoring the azafin. Also the sub or composite CR favoring the azafin over the 7+3. But if we see the CR, almost the same, no difference or no significant difference between the azafin and 7+3. Regarding the event-free survival, it's showing 14.6 versus 6.1 month, and 1 year event-free survival 53% versus 63% for intensive chemotherapy. Transplant, around 34 patients went for transplant intensive chemotherapy, compared with more patients, 52 patients in azafin arm. And thank you.
Thank you very much. Due to the next two session is about acute lymphoblastic leukemia. So we'll take 5 minutes for asking Dr. Meta in this session of acute leukemia. I starting by my questions. It's the first part of the session about 7+3. I ask you about the mortality in Saudi Arabia. In my center, I published data 2022 that I have a mortality of 5% at the age of from 18 years to 35, and about 7% from 35 to 45, and 37% above the age of 45. So from the 2022, I don't using 7.3 in a patient above the age of 45. I using venetoclax as a cytidine, as the data from Amir Fathi. He's one of my friend. So what about your result in your center? I know you are an expert in acute myeloid leukemia.
Actually, it depends on the multiple factor, including the setup of the hospital, the ICU support, the infectious disease support, and the patient itself factor. But it's ranging around 10%, especially with the 7+3, if you have good support. Some of the centers, they don't have good support, especially for the ICU support. We have higher mortality rate.
Any questions for Dr. Mete? The next two sessions will be about acute lymphoblastic leukemia. So there is no any question for acute myeloid leukemia again. Okay? Okay.
Thank you very much.
يعطيك العافية. Thank you, Dr. Matay. So the next speaker is Dr. Nahla Shhata. She's our colleague, consultant adult hematology from King Faisal Specialist Hospital, Jeddah. She's also going to present about Philadelphia positive ALL first line therapy.
Okay. Assalamu alaikum. Good morning, everyone. Thank you, Dr. Ola, for introduction, and it's my pleasure to be here today. So today, my presentation focuses on Philadelphia positive ALL, best first-line treatment. And throughout my presentation, I'll walk you through how the treatment of Philadelphia positive ALL has evolved from chemotherapy with intensive chemotherapy with poor survival to targeted TKI and now highly effective chemotherapy-free regimen. But first, I briefly I'll review with you the history of Philadelphia positive ALL. So as you know, Philadelphia positive ALL is defined by BCR-ABL fusion from translocation 922 leading to continuous tyrosine kinase activity. It accounts 25% of adult ALL, and the incidence increased with age. And there's different breakpoint protein B210. It's seen in 25% of those patients and might be associated with inferior event-free survival, and P190, which is seen in 75% of those patients. Now, historically, Philadelphia positive ALL was considered the worst prognosis ALL subtype. And pre-TKI era, the response rate was modest, short, and the majority of patients don't reach transplant. The 5 years overall survival without transplant was 20%, and even with transplant, it's even not reached 40%. However, this picture dramatically improved after the administration of TKI with chemotherapy, and the first breakthrough was with imatinib. After the combination of imatinib with chemotherapy, the response rate pushed to 90%, and there was significantly improvement in all outcomes, including overall survival, event-free survival, and relapse-free survival. However, the allogeneic stem cell transplant was still considered critical for cure. Now, next was moving to the second generation TKI like the dasatinib, looking for deeper response. And in combination of dasatinib with hyper-CVAD, yes, we reach response rate of 96, majority of the patients reach a major molecular response, and this reflected in a very good overall survival with and without allogeneic stem cell transplant. And after a long-term follow-up with hypacibad and dasatinib, the 5 years overall survival was 46%, event-free survival 42%, and disease-free survival 44%. This raised a concern that relapse is still significant, and this likely highlighting the importance of, because among those patients, notably CNS relapse was significant, and part of it because the number of IT administered with this protocol was the standard IT of 8. And also the resistant mutation like T315I was noted among those populations. So in order to overcome this limitation, MD Anderson come up with this potent protocol combination of ponatinib and hypacibad. The ponatinib dose was 30 milligram during induction, and once a patient achieved complete molecular response, it decreased to 15 milligram and continue with maintenance after that at least for 24 months. And with this protocol, we witnessed the best overall response rate. The complete molecular response reached 83%, and this was translated to the best overall survival with 6 years overall survival reached 75% with and without transplant. Despite all of this success with chemotherapy, TKI, ponatinib, dasatinib, the CNS relapse was still a concern because in the prior 2 studies, the total number of ITs given was 8. However, this study conducted by MD Anderson confirmed that increasing the number of IT from 8 to 12 significantly improved the risk of CNS relapse. And those patients who receive more than 8 ITs, they experience 100% CNS relapse-free survival. And from this study, the 12 ITs become the standard dose in combination with hypacibad and TKI. Now, beyond remission, what's really predict the long-term overall survival is how quickly we eradicate the disease at the molecular level. And Andy Anderson and this group confirmed that, first of all, they defined the complete molecular response by using the quantitative PCR with the sensitivity of the level 10 to the power minus 4 for P210 and 4 log reduction for P190. And among the TKI, the ponatinib was the best with the deepest complete molecular response reach 87%. And this reflected in better survival. And as a conclusion, the complete molecular response achieving complete molecular response at 3 months is considered an independent predictor factor of survival. Now, despite all of this success we achieve with chemotherapy remain a problem, especially for elderly patients because of the tolerance, toxicity, and in presence of highly effective treatment like blinatumomab, which proven its efficacy in MRD, relapse refractory, and consolidation treatment. This led to shift in treatment toward the chemotherapy-free regimen. And this slide summarizes the evolution of the chemotherapy-free regimen, starting with TKI steroid only. However, this was not sufficient because the complete molecular response was only 20%, moving towards sequential approach, and currently the concurrent approach. This is the D-ALBA, the first key trial following the sequential chemotherapy-free approach, means patients started with dasatinib steroid and an induction, followed by consolidation with the blinatumomab. Patient received minimum 2 cycles of blina, maximum 5 cycles of blinatumomab, and then continue with the dasatinib as a maintenance. It's an open-label study, single-arm, multi-center, phase 2 trial. And 25% of the patient witnessed to have Ikaros deletion. And the molecular response achieved by the end of induction was 29%. However, after 2 cycles of blina, improved to 60%. And the disease-free survival and overall survival outcomes, according to the molecular response, after 2 cycles of blinatumomab was 82 and 89%. And on the long-term follow-up of 53 months, this finding was persistently observed, with overall survival of 80% and disease-free survival of 75%. And this overall survival and disease-free survival improvement was witnessed independent of allogeneic stem cell transplant. The incidence of relapse with this protocol, it's around 10%, and still CNS relapse was a concern. Total number of ITs given with this protocol was 12. And the median time to relapse was 4.4 months. Another study that studied the dasatinib combination with blinatumomab done by Southwest Group, and it's phase 2 study, and again, it's confirmed the efficacy of this protocol with patient achieved complete molecular response of 71%. And this reflected in a good overall survival and disease-free survival. Now, moving to the concurrent approach by MD Anderson, combination of blinatumomab and ponatinib. Blina was introduced during the induction along with ponatinib with 30 milligram. And again, once the patient achieved complete molecular response, the dose of ponatinib decreased from 30 to 15. And they received total dose of additional 4 cycles of blinatumomab, and then they continue with maintenance ponatinib single agent. The median age was 50, and at least 50% of this population, they have at least one cardiovascular risk factor. And again, we witnessed the highest complete molecular response with this protocol reach up to 80%. And this reflected to a very good event-free survival and overall survival at 3 years reach up to 90%. Andy Anderson, from this study, they predict, or they considered the Y plus L more than 70 as the most predictive factor for relapse, which account for 23% of this study. In terms of safety, despite the use of concurrently the blinatumomab and ponatinib from induction was considered safe, and the CRS were manageable. None of the patients developed grade 3 or 4 CRS. However, the issue related to this chemotherapy free regimen protocol, ponatinib, blinatumomab, was the CNS relapse still was a concern with a 6%. And there's a number of patients with CML lymphoid blast crisis involved in this study. And complete molecular response was only 33%, not like the newly diagnosed Philadelphia positive ALL. This drove MD Anderson group to study, to address this issue through the adding the many hyper-CVAD to ponatinib blina. So patient receive, in order to intensify the CNS-directed therapy, and also they increase the number of IT from 12 to 15. The range was between 12 to 20. In this protocol, the patient received 4 cycles of mini hyper-CVAD followed by consolidation of blina along with ponatinib, followed by maintenance with incubation of cycles of blinatumomab during the maintenance. And interestingly, the response rate for new patient was almost the same, 78%. However, for CML with lymphoid blast crisis, it improved to 75%. The total number of patients is 4. However, all of these patients proceed with allogeneic stem cell transplant. And this was again reflected in better overall survival, reach up to 3 years overall survival among the new patient was 71%, event-free survival 63%. The same was observed in the CML with lymphoid blast crisis. And it was fairly tolerated protocol. This is the first Ssbmt trial, the first phase 3 randomized trial that confirmed the efficacy of chemotherapy-free regimen. It randomized patient to the control arm was chemotherapy imatinib versus blina ponatinib. And the result was favoring the chemotherapy-free regimen with better event-free survival and overall survival. And this is, we're waiting for the result of this study, expected to release in 2026, ECOG 9181 study, randomized open label multicenter phase 3 for newly diagnosed Philadelphia positive ALL. They randomized the patient to chemotherapy plus TKI ponatinib versus dasatinib, and the other arm blina plus TKI ponatinib versus dasatinib. And the key feature of this study is CNS intensification included. The patient who achieve MRD negative, they have the option to proceed with allogeneic stem cell transplant or to continue with the chemotherapy. And the results still pending. And when it comes to the role of allogeneic stem cell transplant nowadays, historically, yes, allogeneic stem cell transplant was a critical for cure. However, after incubation or introduction of ponatinib-based regimen, the need of allogeneic stem cell transplant significantly reduced. And even with hyper-CVAD ponatinib, the overall survival was observed better among patients who did not proceed with allogeneic stem cell transplant. And this observation also witnessed in the patient who received a chemotherapy-free regimen, ponatinib, dasatinib base. The patient who proceeded with allogeneic stem cell transplant was only 1%. From this slide, you can see how the survival of Philadelphia positive LL improved over the last 2 decades across the treatment protocols, and how, I don't know how to, and you can see how we achieved the best 3-year overall survival with chemotherapy-free regimen blinatumomab ponatinib. So as a conclusion, now ponatinib-based regimen achieve highest complete molecular rate. The chemotherapy-free combination are highly effective. Complete molecular response after 3 months identify the favorable risk patient. And the role of allogeneic stem cell transplant is continue to evolve. However, it is maybe considered for patients mainly with persistent MRD disease, or and relapse cases. Thank you.
Thank you, Dr. Nahla, for your presentation. خلاص, we'll ask Dr. Salim. The next speaker is actually Dr. Salim Dadah, our colleague, consultant adult hematology and bone marrow transplant in Princess Noura Oncology Center, King Abdulaziz Medical City, Jeddah. He's going to talk about the future of ALL treatment.
Thank you, Dr. Wala. Assalamu alaikum. Good morning, everyone. And I would like to thank the organizing committee for inviting me to speak to you today. So I'm going to discuss the future look of ALL therapy with the incorporation of novel agents and CAR T cells. So stop moving. Which one? Flags behind. Okay. So the outcomes of ALL have improved over the last 4 decades, and the improvement was more pronounced in younger patients with ALL. Older patients with ALL, still the outcomes lags behind, and patients above the age of 40 have an overall survival at 5 years of less than 50%. The hyper-CVAD regimen, a common regimen in our area used for adult ALL, the outcomes at 5 years published by the MD Anderson showed an overall survival of 38%. And when they looked at the outcomes according to age, patients who are older than 40 had a 5-year overall survival of 30%, and patients above 60 had a 5-year overall survival of less than 20%. So first, I'm going to discuss how outcomes are improving in BALL and what's the future look like. So the addition of immunotherapy has actually improved the outcomes of adult Ph-negative ALL. First, with the addition of the anti-CD20 antibody agent rituximab ofatumumab, the antibody drug conjugate against CD22 inotuzumab, and the bispecific antibody against CD19 blinatumomab. So this paper in JCO more than 15 years ago by the MD Anderson showed that the addition of rituximab to CD20 positive Ph-negative ALL improved outcomes. That was a retrospective analysis. Subsequently, the French group did a randomized clinical trial with rituximab in CD20 positive patients, showed that the outcomes are improved with improvement in event-free survival, mainly because of the reduction of the cumulative incidence of relapse, 25% for rituximab versus 41% for the control arm. The bispecific T-cell engager, blinatumomab against CD19, have shown to improve overall survival in BLL. You are all aware about the E1910 trial. So the E1910 randomized patient who are MRD negative to receive blinatumomab 4 cycles with chemotherapy versus chemotherapy alone. And they added asparaginase for patients who are less than 55 years of age, and rituximab was also added in CD20 positive patients. So they showed that the 3-year overall survival was improved 85% versus 68%, mainly because of the reduction in the relapse death. This is the relapse-free survival for the E1910, showing a reduction, 50% reduction, relative risk reduction of relapse. And what was striking in that trial, that patients less than 55 years of age had a pronounced improvement in survival. You can look at survival exceeding 80% in those patients. So what about the addition of the antibody-drug conjugate inotuzumab to the upfront therapy? This was studied in the phase 3 Alliance trial that was presented in ASH 2024. So in that trial, they used a modified pediatric regimen, the 10403, and they randomized patients to receive either 2 cycles of ENO versus no ENO, followed by consolidation, interim maintenance, DI, and maintenance. That trial was actually negative. The 3-year event-free survival for ENO was similar to chemotherapy. The ENO arm had less progression and relapse. However, there were excess toxic death in the ENO arm, and that led to a similar overall survival between ENO versus control. So subsequently, they are doing a modification, the Alliance, on that trial. They're using 1 cycle only of inotuzumab, and they're adding 2 cycles of blinatumomab in between consolidation and interim maintenance. So 1 cycle after consolidation and the other cycle after interim maintenance. So the MD Anderson are actually studying the modification of hyper-CVAD with the addition of blinatumomab with or without ENO in younger patient with Ph negative ALL. And this is the original protocol. So 4 cycles of hyper-CVAD with rituximab or ofatumumab in CD20 positive patient, followed by 4 cycles of blinatumomab consolidation, followed by shortened maintenance for 15 months with 12 months of bomb in between 3 cycles of blinatumomab. So the updated protocol, they have added also inotuzumab in cycle 2 and 4 of hyper-CVAD and cycle 2 and 4 of the consolidation blinatumomab. And inotuzumab is giving an fractionated dose 0.3 milligram per meter square on day 1 and day 8. So they had 75 patients treated, the initial cohort 38 patients, and the subsequent cohort 2 with inotuzumab 37 patients. So if you look at the responses, CR after induction, overall 84%, and MRD negativity after induction 66%. However, MRD negativity at any time approached 95%. with 0 early death. This is looking at the overall survival at 3 years in those 75 patients were 90%, and the outcomes were actually better with the addition of inotuzumab with relapse-free survival of 100%. However, longer follow-up is needed to see the sustainability of these outcomes. So the Golden Gate is a phase 3 clinical trial of blinatumomab with low-intensity chemotherapy versus chemotherapy, hyper-CVAD or GMAL-based chemotherapy. This is a phase 3 clinical trial, including patients above the age of 40 with Ph-negative ALL, and they had the safety run-in with 10 patients, median age 69, and the CR was actually 100%. Now, the phase 3 clinical trial is ongoing, so blina with low-intensity chemotherapy versus chemotherapy. We expect the result in the upcoming years. So inotuzumab, in combination with lower intensity chemotherapy mini-hyper CVD, have been studied in older patients with ALL in this phase 2 trial by the MD Anderson. So they looked at the outcomes. 3-year overall survival was 56%. And the updated result, I'll show you the protocol first, then I'll show you the results. So the protocol is mini-hyper CVD with inotuzumab fractionated, followed by, again, 4 cycles of blina, followed by shortened maintenance with blina and BAM. And this is the outcomes, long-term outcomes, 4-year overall survival, 50% in a median age of 68, so quite older population cohort. And in their subgroup analysis, they showed that patients with high-risk cytogenetics had inferior outcomes. So when they did a propensity score analysis, they showed that the combination of mini-hyper CVD, ENO plus minus blina is actually superior to chemotherapy alone. The Alliance trial looked at chemo-free regimen in Ph-negative ALL with combination of inotuzumab and blinatumomab without chemopherapy. So patients above 60 years of age with CD20 positive BALL will receive 2 cycles of inotuzumab, followed by 4 to 5 cycles of blinatumomab with intrathecal CNS prophylaxis. And the primary endpoint was 1-year event-free survival. So they had a total of 33 patients, and 8 of these 33 patients had prior cancer, and 6 patients of those had actually prior multiple myeloma. So they get inotuzumab induction followed by blinatumomab consolidation. And this is the outcomes. Composite CR after induction was 85%, and after blina was 97%. And if you look at the Kaplan-Meier curves for event-free survival, 74%, and overall survival of 84% at 1 year. They updated their data in the last ASH in oral presentation, and they looked at the 3-year event-free survival was 48%. They had some relapses. Some of them were CD19 negative, and some of them were CD19 positive. And they had no isolated CNS relapse, which is interesting for me. And this is the overall survival with blina-eno without chemotherapy at 3 years was 59% in this old population of patients with ALL. They showed that the CD22 expression impacted the outcome, so patients with less than 90% CD22 expression had lower event-free survival. And the best outcomes were patients who achieve MRD negativity after induction. So when they compared their data to the data from the MD Anderson, you can see that the overall survival is almost similar to the MD Anderson data. They had more relapses. However, the non-relapse mortality was lower with this approach. So something that is coming soon is the subcut blinatumomab, and it was tested in relapse refractory setting. In this data in 2 doses, 250, 500, and 500, 1,000. And this phase 1 trial looked at the CR/CRh, and they included patients with more than 50% blast. If you look at the CR/CRh, 86% for the 250, 500 dose, and 92% for the 500, 1,000 dose. So the toxicities are as expected in the relapse refractory setting with blinatumomab, including neurotoxicities and CRS. And patients were bridged to allogeneic bone marrow transplant after achieving remission. They expanded the data with this paper in the Lancet published last year, and they looked at the outcomes. If you compare the outcomes with the old Tower trial in the relapse refractory setting, it seems that the outcomes could be better actually the subcut blinatumomab. So there is a trial will start soon, and 5 centers from the kingdom are included in this trial. This is the subcut blinatumomab, newly diagnosed Ph-negative ALL. We expect the study to start this year. in the upfront therapy. So shifting gears to CAR T-cell, now we have 3 approved CAR T-cell products in relapsed refractory ALL. We have the T-cell, obe-cel, and the Brexu-cel. And we expect the outcomes would improve with those agents. There is studies about optimization of lymphodepletion, studies about improving the manufacturer, and there are currently studies on bispecific CAR T-cell against CD19 and CD22. So there is a trial of using CAR T-cell in the upfront therapy, phase 2 trial called Cassiopeia. They looked at the use of T-cell in high-risk BLL who are end of consolidation MRD positive. So patients who had MRD more than 1% at the end of induction, they had leukapheresis. And if they are MRD positive at the end of consolidation, they received subsequent T-cell infusion. This is a trial by the COG, and the trial finished recruiting, and we expect the result in the near future. The group by the City of Hope and Dr. Ibrahim Dos presented in ASH last year the CD19 CAR T-cell, their own product from City of Hope, as consolidation in older patient with BALL in CR1. So they had a patient who are more than 55 years of age with a CD19 positive BALL. They had 22 patients consented and actually 18 patients infused. So those patients, they got CAR T-cell therapy in the upfront setting. So a median age was 64 of the enrolled 18 patients. And you can see that there were no dose-limiting toxicity was observed. Only one patient had grade 1 CRS, no grade 2 CRS, and no any grade ICANN. And this is different from the relapse refractory setting. And with a median follow-up of 18 months, so 1.5 years, the median, the 1-year event-free survival was 94%, and the overall survival was 100%. So an interesting strategy for older patients with ALL is to avoid subsequent chemotherapy and give single CAR T-cell infusion. The MD Anderson is studying the obe-cel as consolidation in newly diagnosed patients with high-risk BLL, and this trial is currently recruiting. What about TLL, shifting gear to T-cell ALL? We know that the 0434 trial by the COG showed that nelarabine improves the outcome in T-cell ALL, and currently is standard of care in pediatric T-cell ALL. The subsequent COG trial studied the addition of bortezomib in TALL, and what they shown that in more than 800 patients, that the addition of bortezomib improved the outcome in T lymphoplastic lymphoma, not in T-ALL. So the MD Anderson studied the addition of 3 agents to hyper-CVAD in TLL. So, and initially, the first 2 cohort, they added nelarabine. Then in the 3rd cohort, they added asparaginase. And in the 4th and 5th cohort, they added venetoclax. So they're studying the outcomes according to protocol amendment over the years. So this is the final protocol they have. So this is regimen 5, the most updated one for TALL. So they had hyper-CVAD together with venetoclax in induction 4 cycles, followed by nelarabine with asparaginase, followed by 1 cycle of hyper-CVAD venetoclax, followed by 1 cycle of nelarabine asparaginase, and then 6 total of 8 cycles of hyper-CVAD with venetoclax. And this is followed by maintenance. It's a bit complicated protocol. So what they did with the venetoclax in the last regimen, they actually give less days in in post-remission from cycle 2 to cycle 8, 3 days rather than 7 days. And this is the full cohort, so they had 145 patients. The original cohort, 96 patients, and the protocol with venetoclax had 49 patients. And if you look at the outcomes of the overall cohort, 5-year overall survival, 65% for 145 patients, and overall survival, 66%. And they have shown that the addition of venetoclax actually improved the outcomes in terms of progression-free survival. And there was a trend toward improvement of overall survival. However, this did not reach statistical significance. So daratumumab also is studied in pediatric relapsed refractory ALL in the Delphinus trial. And in this trial, they showed that the overall response rate in the pooled T-cell ALL in a 29 patient was 83%, more than 80%. And the upcoming COG trial is actually adding daratumumab to the therapy BFM nelarabine backbone. So we expect the results also in the upcoming years. So probably heard about this breakthrough therapy designation for a product called Sofi-cel. So what is this Sofi-cel? So this is a phase 1/2 trial of anti-CD7 allogenic CAR T cell called 007 for patients with relapsed refractory T-cell malignancies. So what's this product? This is an allogenic CAR T cell. So they get T cell from healthy patients, and then they do CRISPR-Cas9 technology to delete CD7, so that to prevent killing from other T cells, and to delete the TCR alpha constant gene, so they prevent significant GVHD. And then this product is expanded and infused to the patient. And in the phase 2 recommended dosing of 900 million, they had 13 patients, and the overall response in the 11 patients available was more than 90%. And 6 of those patients were bridged to allogeneic bone marrow transplant. So we expect probably the approval of this product in these patients. So in conclusion, I would like to say that ALL outcomes have significantly improved over the last few decades. Immunotherapy is an important component of the current upfront therapy of BALL. CD19 CAR T cell may soon be used in the upfront therapy of high-risk BALL, especially those who are MRD positive. Nelarabine, daratumumab, and venetoclax have all shown potentials to improve outcome in T-cell ALL patients, and we may soon see the first allogeneic CAR T-cell product approved in T-ALL. Thank you.
Thank you very much, Dr. Wala. Dr. Wala, can you come here? We're now having a time for discussion. Dr. Hanan Hamid.
Thank you very much for your the 3 excellent presentation. I will start by you, Dr. Nahla. A couple of questions, actually. In ALBA study, as you mentioned, the only non-beautifully responding are those with Ikaros aberration. Do you suggest that we estimate that or check for that prior to therapy, or should we wait for a while till we have not expecting response and to check for Ikaros? My second question is the use of olverembatinib, which is a Chinese product, proved itself to be excellent, not only in CML, but in ALL Philadelphia positive, and it is now approved both EMA and FDA according to Polaris study. Do you think it stands a chance to be used in our area, especially if it is price-wise comparable or competing with ponatinib or other drugs? Thank you very much.
طيب, regarding the first question, now ECRS is considered a negative predictor factor for prognosis. However, I don't think it's gonna change the treatment plan if we check ECRS from the beginning. But if you have the facility to do it, why not? I would do it, but since patient who achieve a complete molecular response at 3 months still with ECRS status, with positive ECRS status, will experience a good survival with the chemotherapy regimen, maybe I would, it depends on the practice in your center, but it wouldn't change the treatment plan. For the second one, I'm not aware about this drug, yes. We're not using it. As long as we have the ponatinib with the potent effect, we continue with this product.
So, can I ask Dr. Salam another
I
couple?
just have a comment regarding this. Yeah. So, for the Icarus Plus, it's actual indication for allo in the Ssbmt trial. At the MD Anderson, they don't use it as a sole agent for allogeneic. They did subgroup analysis that, or the multivariate analysis, that the Icarus Plus did not impact the outcomes. However, in the Ssbmt trial, it's an indication for allogeneic bone marrow transplant.
Maybe because they are using ponatinib and not dasatinib. This could be the key for the difference between ALBA and using ponatinib.
No,
and
I'm talking about the new.
Yes.
The one with ponatinib. So plina ponatinib, the new trial of the Ssbmt, they presented in last ASH. Still Icarus Plus would be an indication for allogeneic bone marrow transplant. The one with ponatinib. Yeah. Yes.
Okay. My couple of questions for you. The first one, why we are not talking about Philadelphia-like over the last couple of years? Did we ignore the Abelson or BCR aberration or other fusion genes, or we are not going to treat them in a special way like before or previous suggestions of using JAK inhibitors or something like that? And my second question concerning CAR T7, which is Wu CAR. I think this is originally Chinese as well.
Yeah. So for the first question, one of the problem with pH-like ALL is the identification. So different group have different identification criteria and testing criteria, and the therapy is not standardized for those patients. And we know that the TKIs, especially the imatinib, dasatinib, and ponatinib, they're active in around 10% of those cases. So the other, they have the JAK-like inhibitors that been tested in them, and it did not show significant improvement in the outcomes. Additionally, in the E1910, the subgroup analysis of the pH-like ALL, if they achieve MRD negativity, they had excellent outcomes. So probably with blinatumomab, you are overcoming the poor outcomes in pH-like ALL. For regarding your second question regarding the Soficel, I presented the data from the 007, this product, and they had in the phase 2 recommended dosing, they had 90% available response, the overall response in the available patients. So it has a breakthrough designation by FDA, and maybe we will see an approval of this product in the coming future.
What I mean is it is approved in China years ago.
Is it approved? I'm not aware.
CD7, yes, in China. Yeah, that's why
maybe another product, not this one.
That's why I'm asking, is it Wu CAR T7, which have been used in the San Francisco study, the same, or they are making another version of it?
No, I'm not sure. I'm not sure if it's about
Dr.
approval in
Ahmed.
China.
Well, maybe I could comment in the Wujian CD7, and then I have a question as well.
Okay.
So the Wujian is American, it's not a Chinese. Yes, and we have discussion with the company actually, and hopefully we will be engaged in the phase 3 trial. So we will try to invite other centers in Saudi. That's if the company agrees. So there's ongoing discussion. Now, I just wanted to probably hear your opinion on the CNS relapse and prophylaxis in the chemo-free regimen, whether Philadelphia positive or negative, maybe for both. See,
So with the chemo-free regimen in Philadelphia positive, with ponatinib blina, when they used the 12 ITs, the CNS risk was around 6%. However, it improved with intensify the CNS IT to 15. So it depends on I believe, the presentation. If the patient presented with bulky disease, high white blood cells, then they deserve CNS-directed therapy along with 15 ITs to overcome the risk of CNS relapse. In patient with low risk, low count, I would proceed with chemotherapy regimen with 15 IT without chemotherapy.
So what type?
Many hypercephat, high-dose methotrexate. Yeah. MD Anderson, they use high-dose methotrexate 2 cycles for high-risk patient, along with blina, ponatinib, and 15 ITs.
Yeah, that's what I wanted to add. So the updated MD Anderson, they added 2 cycles of high-dose methotrexate in patient with high counts, so to overcome the CNS relapse in those patients. So for pH negative ALL in the plina trial, they used only intrathecal methotrexate. Interestingly, there were no CNS relapses in that cohort.
so how do you see the efficacy of the Lena and the CAR-T in the CNS?
So for Blina, there is no evidence that it may decrease the CNS relapses, even in they have shown this very well studied in the pediatric data. However, CAR T cell have excellent penetration to the CNS and probably would be a very good product in preventing CNS relapses if used upfront.
Okay, welcome.
So I go back to your comment, Dr.
For me?
Rafat. Yeah.
Okay.
So take you back to AML. Huh? Okay. It's about your comment about giving induction for age like 40 to 60.
In AML or ALL?
AML. About
AML.
You said in your center you are not giving any
Yeah.
7+3 or intensive induction for age around 40 to 60 because of increased toxicity.
Yeah.
And I would agree with you that we do see more toxicity in this group. We see patients going to ICU, we see patients dies. So I think nowadays, like what we do in our center, for those who have adverse risk in this, like less than 60 and age 45, 50, we go for easily to go for Ven-Aza because chemotherapy is not. And for those who are still have core binding factors or FLT3, we go for chemotherapy plus targeted treatment because we think this is associated with better outcome. For the intermediate risk group, I think the trends now, especially after the paradigm trial, is to go more for Ven-Aza.
As the first, I think my data is published 2022. This is some sort of old data. But we're having in my centers at this time, the supportive care is not well got enough for patient with 3 and 7 because when using 3 and 7, you need a HEPA filters in the room. I don't using until now. Don't use HEPA filter in room for managing the patient with acute leukemia. It is a regular room, not HEPA filter in transplant era only. I think the next 10 years, the era of in acute leukemia, ALL or AML, will using azacitidine with venetoclax, upfront CAR T cell. Now we're having a very data about CAR T cells in acute myeloid leukemia without any chemotherapy, and also azacitidine is used now in the United States for transplant high-risk patient in ALL patient, low dose therapy. But I think now we're changing the how to manage acute leukemia, and I was the first one changing this because still the data from Dr. Salim and Dr. Ala is still we're having about 50% only 5-year survivors. I think we need to change this as soon as possible.
Question for Dr. Nahal. Thank you for the speaker for the nice review. The question regarding Philadelphia positive, the number of the cycle of Blina, after the 2 cycle of Blina, if the patient MRD positive, you will again to continue with the 5 cycle Blina or just ponatinib consolidation?
Now, I would say the important point when you have to switch the treatment is the assessment of complete molecular response after 3 months of treatment. So you're talking about which protocol? Sorry.
Blina plus Bona.
Bona Blina.
Blina Bona, yeah.
And now
His mission minimum is 2 and maximum 5 cycle of Blina.
No, this is the D-Alba. The D-Alba with the dasatinib, they receive the consolidation Blina minimum 2, maximum 5. With Bona Blina, they receive total of 5 cycles of Blina to warm-up. The first cycle introduced an induction, and they continue with 4 during consolidation, and they're done. With Bona Blina, the expected complete molecular response rate up to 83% after 2 cycles. So this by 3 months, the complete molecular response. So this means if you didn't achieve this result, you have to switch the treatment protocol.
Thank you for the speaker for the outstanding presentation. I have a comment regarding IKFZ1 mutation, ICROS mutation. Actually, in the ALBA protocol, it has been reported that patients, they have IKFZ1 plus, their prognosis went down, the survival went down from 98% to 85%. So it's still the proposed indication for stem cell transplant for patients either Philadelphia-like and Philadelphia positive or Philadelphia negative. If they have ICROS mutation plus, they need transplant.
However, in D-Alba, yes, not all patients with ICROS proceed with allogeneic stem cell transplant.
But you mean they did not? In the D-Alba, 50% of patients proceed to
50% proceed with transplant.
So most of the patients,
yeah,
actually.
maybe eventually.
I wouldn't say most, half the patients, sorry. But in the new trial, also the Icarus Plus is an indication for allo in the Italian version.
Because they noticed that the most of the relapse was IKFZ1 plus and CNS. So in the next version with Puna, Blina, and European study, all patients with ICROS plus mutation, they want to transplant.
Yeah, it's an indication for transplant in the GMIMA 2820.
Thank you very much for the because I think it's like we just have 10 minutes for a short coffee break. Then thank you for the speakers, and thank you Dr. Abdel Fattah for your moderation. يعطيكم العافية.
طيب السلام عليكم ورحمة الله. Good morning. My name is Ahmed Said from National Guard Hospital, Jeddah. I would like to thank the Ssbmt and SSH for nice organization. So because of time, it's Friday and there is a Friday prayer. We would like to start the second session, which will be high-grade lymphomas. We will have 4 lectures, followed by a panel discussion and questions and answer. So I would like to introduce my co-chair for this session. Dr. Omar Raslan is a consultant and assistant professor of hematology and internal medicine at Jeddah University. And Dr. Omar, you can go with.
Thank you, Dr. Ahmed, for the kind introduction. Assalamu alaikum. Thank you, Ssbmt, for hosting this event today and for inviting me to moderate this session. So we will start. Allow me to introduce Dr. Samir Al-Amoudi, consultant adult hematology and oncology and section head of stem cell transplant cellular therapy at Princess Noor Oncology Center. He will be presenting today CAR-T versus bispecifics and aggressive lymphomas, selecting the right patient. Please welcome Dr. Samir.
Assalamu alaikum. It's clear. Thanks, Mr. Chairman, for the nice introduction, and thanks Ssbmt and SSH for the invitation. So in the next 20 minutes, I'm gonna talk about CAR T cell versus bispecific. We know CAR T cells available in Saudi Arabia, bispecific also available. So what are the data behind the outcome and the efficacy of this therapy, and which patient is fit which type of the therapy? So let's start by this case. So this is typical 33-year-old female actually diagnosed to have stage 4 diffuse large B-cell lymphoma, bulky. And this is actually was in 2018. So she received actually standard therapy R-CHOP 3 cycles. At that time, she achieved partial remission based on the CT criteria. And unfortunately, after cycle 5, she started to have some fever, short breath. CT showed increase in the mass, so it's labeled as primary refractory. At that time, we don't have CAR T cell, we didn't have CAR T cell, so she received the standard 2 cycle of RE-CHOP. She achieved partial response, and she was underwent autologous stem cell transplant. Unfortunately, before even day 100, actually, she presented fever, short breath, even before the disease assessment, and CT showed progressive disease. So she was admitted to ICU with sepsis and passed away secondary to her disease. So what we learned from this case, actually, we know that based on the scholar, that any primary refractory or early relapse actually carry poor prognosis with median overall survival around 7 months. So how can we improve that? So one of the solutions is to have CAR T cell. So there is a CD19 directed CAR T cell. As you know, this is actually, it's contain of CD19 binding domain and co-stimulatory domain. Basically, you collect the lymphocyte, insert viral vector, leads to the expansion of the lymphocyte and doing manufacturing, then reinfuse the cells again. So this is the journey of the CAR T cell. So you will do leukapheresis, collect the lymphocyte, do the insert the viral vector, and the manufacturing time usually takes around 3 to 5 weeks until the product ready, then reinfuse it to the patient again. So this is another case of 55-year-old female diagnosed to have marginal zone lymphoma 2019, then transformed to large B-cell lymphoma in 2021. She received 6 cycle R-CHOP, achieved remission, and actually after radiation showed complete metabolic response. Unfortunately, after that, she relapsed less than 2 years with you can see the BIT is positive. At that time, also, we didn't have the CAR T cells, so she received the salvage therapy 2 cycles, achieved CMR, so she underwent autologous stem cell transplant in July 2023, then day 100 BIT showed complete metabolic response. Later on, around 5 to 6 months, she presented hematuria and right flank pain. CT, as you can see, there is progression of her disease, actually. So she went for a cystoscopy, and biopsy confirmed relapse of her disease. So what the next? Actually, so at that time, actually, we were lucky, and the patient was lucky that we had the CAR T cell in our institution, so we decided to go for CAR T cell. So what the data behind like CAR T cell in case of as a third line? So actually in Saudi Arabia, we have 3 products of CAR T cell. We have the Axi-cell, Tisa-cell, and Liso-cell. I will mention here the Axi-cell, which is the Zuma one. Actually, as you can see, like the median follow-up around 63 months. And this is actually using CAR T cells as a third line in relapsed refractory diffuse B-cell lymphoma. And as you can see, overall response rate 83. Here we're talking about this is a third line. So usually these types of patients, we put them palliative. So overall response rate around 83 and median overall survival around 25 months. The second product, which is Liso-cell, unfortunately not available here in Saudi Arabia, also showed positive result around like with median follow-up almost 20 months. There is around overall response rate 23 months, with the median overall survival around 27 months. The third product, so this patient actually, she was admitted and underwent CAR T cell. She developed grade 1 actually CRS, no ICANS, and actually febrile neutropenia with multidrug resistant Pseudomonas bacteremia. After actually she was responding to antibiotics, then she was discharged from hospital after 3 weeks. So the aim of this actually graph, just to mention that you can see, so I mentioned about the Axi-cell is approved third line and the Liso-cell. So in the actually Tisa-cell, it's available. Actually, the first CAR T cell was in Saudi Arabia, was Tisa-cell. But as you can see here, actually, the overall response rate is less compared to the Axi-cell and Liso-cell. So that's why nobody will use now Tisa-cell in case of at the third line in case of relapse diffuse B-cell lymphoma. One thing also about, so we know Axi-cell and Liso-cell, where both of them are effective. What about toxicity? So you can see this is the Axi-cell. You can see here we're talking about grade 3 toxicity. So CRS grade 3 or more around 13, neurotoxicity around 28%. Tisa-cell also they have some toxicity, but as I mentioned, nobody will use it as a third line. Liso-cell, you can see here CRS grade 3 or more is around 2%, with neurotoxicity is around 10%, which is less compared to the Axi-cell. So this is just to show the bit day 30 for this patient. Here we're talking about third line CAR T cell, fourth line. So bit day 30, you can see complete metabolic response. Bit day 90 continue to be complete metabolic response, and nephrostomy tube was removed. After 6 months, she continued to be in complete metabolic response. So what about this other case? So this is around 70-year actually male. Here we're talking 70-year elderly with diffuse B-cell lymphoma stage 4B. It was negative CNS and bone marrow. Actually, he was fit, like ECOG around 1 to 2. So at that time, he received actually 3 cycles R-CHOP, and you can see interim bit around CMR. And end of therapy, unfortunately, you can see there is progressive disease. So 70-year-old male with primary refractory, usually these types of patients, they are not eligible with autologous transplant. So you used to give them just palliative chemotherapy. But can we, with the CAR T cell, can we improve that? So actually CAR T cell initially was approved a third line, but now we can use a second line. For Ssbmt, which is the Axi-cell product, actually they compare relapse refractory diffuse B-cell lymphoma to receive either Axi-cell or standard, which is transplant. You can see here that actually the progression-free survival for the Axi-cell is better compared to the standard, the CAR T cell. Even also the overall survival is better compared to the standard, which is the stem cell transplant. And not only that, there was subgroup analysis about elderly patients. So as you can see here, let's continue. Those who are more than 70 and receive 70 years old and receive CAR T cell, they do better compared to the standard autologous stem cell transplant, even improve in the actual progression-free survival. What about, so this is about Axi-cell. What about other 2 products, Tisa-cell and Liso-cell? So Liso-cell also, it was studied in Transform and showed as approved a second line actually in case of relapse refractory diffuse large B-cell lymphoma. T-cell, as mentioned, nobody will use a third line, and even the second line, the study was negative. So we have two products approved in the second line, Axicil and Lysocil in case of relapsed refractory diffuse large B-cell lymphoma. So we know most of the clinical trial, they is selective in the inclusion criteria. For example, they need a performance ECOG 1 to 2 with good cardiac function, good liver and kidney function. So what about like Axicil data in real world actually? So as a second line. So this actually was studied. So you can see here around like there are they include patients like in Zuma 7. Actually, they are not fit to be, not eligible to be for Zuma 7. So you can see actually they saw actually in this study same result as Zuma 7. So still it's case by case. So even if the patient not fit the inclusion criteria for the Zuma 7, you can use this. You can use CAR T-cell with the same excellent result. Also, this was a study actually in real-world outcome of Lysocil. In relapsed refractory diffuse B-cell lymphoma still showed excellent outcome in the patient actually not eligible to the transform study itself. This is, so here we're talking, this is actually pilot study, including patient Lysocil, they are transplant ineligible. So transplant ineligible regardless, is because cardiac function or renal function, and actually so they receive Lysocil and still showed excellent result with tolerance, they can tolerate it with they can tolerate the toxicity actually in form of CRS and ICANS. But we know CAR T-cell is available, but there are barriers actually to access CAR T-cell. So one of them is the availability. So it's, you know, CAR T-cells, to have CAR T-cell in the institutions need specific setting. So this is one of the barriers to have CAR T-cell. Other barriers also the cost. So it's not actually cheap. And the other barriers actually from referral hospital, like some of them, they delay the patient, they didn't refer the patient till he's sick, not fit for the CAR T-cell, and the awareness of the CAR T-cell, and other patients factor, you know, because need transportation, the availability of the caregiver. So any alternative? So actually we have like bispecific, which is like CD20, CD30 bispecific. We have two products, the Glofi and Ipco. And actually, both of them were actually approved the third line. So glofitamab approved third line, and even Ipco in case of relapse refractory diffuse large B-cell lymphoma. Can we use them as a second line? So this is actually the phase 3 STAR-GLO trial. So they actually compare Glofi-GMOX versus R-GMOX in transplant ineligible diffuse large B-cell lymphoma. So here we're talking about second line. So this is actually the study, and the result actually you can see there is improvement in overall survival in the glofitamab group compared to the chemo group in case of transplant ineligible patients. Ipco also, this is also phase 1/2 study actually, so it's also include Ipco with GMOX in transplant eligible diffuse B-cell lymphoma. It still shows benefit in case if the patient is not eligible to the transplant. So now so I showed the data about CAR T-cell and bispecific. So let's summarize. So CAR T-cell is living drug, so it uses autologous T-cell, targeted CD19, single infusion, and requirement of lymphodepletion before infusion. One of the issues is the manufacturing time. So once the product is collected, it needs 3 to 5 weeks the products to be ready. Bispecifics off the shelf and ready to be administered. Target bridge between CD20 and CD3 actually, and glofitamab is fixed duration. Ipco continuous until disease progression. No need for lymphodepletion, and it's available, so it doesn't need like high standard infrastructure. So there is no head-to-head comparison between the bispecific and CAR T-cell, but if you summarize the data, you can see here actually the overall response rate and CR rate with CAR T-cell actually is better if you compare it to the bispecifics, with better overall survival in case of CAR T-cell. So this is about efficacy. What about tolerance and toxicity? You can see here CAR T-cell actually, we're expecting more CRS, especially grade 3, more ICANS, prolonged cytopenia. Management, some cases, if they develop grade 3 or 4 CRS or ICANS, required ICU admission. Bispecific, you can see CRS grade 3 is less compared to CAR T cell. Even the ICANN cytopenia is transient. Infection, lower risk of infection, and usually this most of the time they're given as a outpatients, except in the step-up dosing. So one of the things usually it's important actually for the patients before the physician is the quality of life. Usually you can see a lot in the clinic that you treat the patient, he's in remission, but the patient still doesn't feel that he's back normal. So actually this was looked actually, so the patient who receive actually CAR T cell, you can see initially there is decrease in the quality of life, but with the time it's improved. While those who receive bispecific, it's the opposite actually. So initially quality of life is better, but with time, because there is evidence of chemotherapy, it will decrease. So this is one thing that we have to keep it in our mind. So how do we decide between, if you have a patient, this is for CAR T cell or bispecific actually in second line. So before that, we'll talk about some definitions. So we have triple eligible, double eligible, and single eligible. So triple eligible, these patients are eligible for transplant, CAR T cell, and bispecific. And what the definition of that? So the patient needs to be fit, age less than 70, and with good organ function. Double eligible, the eligible CAR T cell and bispecific. So they're not fit like the triple eligible, but they're not frail. And with intermediate actually organ function with good social support. Single eligible, they are actually frail and actually they have some organ dysfunction. You can see here in the double eligible and single eligible, the age is not factors, not like transplant eligible group. So if you have triple eligible group as a second line, relapsed refractory diffuse B-cell lymphoma. So the standard, if you have relapsed refractory diffuse B-cell lymphoma, is CAR T cell. If you have late relapse, you can consider salvage. If the patient achieves response, you can take them to transplant. But as I mentioned earlier, there's some group, even with their late relapse, they're still transplant ineligible, and we have data still we can use CAR T cell for this group of patients. What about double eligible? Still, if you have primary refractory or early relapse, CAR T cell is the standard of care. If the patient's not fit for the CAR T cell or for any reasons not available, you can use bispecific for this group of patients. Single eligible, so you have this actually glofitamab can be used with or without chemotherapy. So this is actually the NCC in guidelines. You can see actually in case of early relapse, less than 12 months, as I mentioned. So the standard is CAR T cell. If they're not candidate CAR T cell, you can use the bispecific. Late relapse, you can use salvage. Actually, if they achieve remission, you can go transplant. If they're not eligible for transplant, you can consider CAR T cell. Third line, still the standard is CAR T cell, and after that, bispecific. So this is the clinical scenario where the CAR T cell is preferred. So usually patient performance fit, echo up to 2 actually, not up to 1, up to 2 is good function. Disease manageable, so the patients is like, that can tolerate to be off therapy or minimum therapy until the product is ready. High risk feature, actually this prefer CAR T cell, and also access to the CAR T cell and patient preference in case if need only one-time therapy. Bispecific, mainly for frail elderly, rapid disease progression will not able to make it to the CAR T cell, barrier CAR T cell, and after failure of CAR T cell, and preference of the patient in case of the needs to be given as outpatients. So just I'll conclude my presentation about like sequencing of CAR T cell versus bispecific. So I mentioned primary refractory early relapse, standard CAR T cell. If the patient is not fit for CAR T cell, can use bispecific with chemotherapy. Third line, still the CAR T cell is the standard. But here actually in this is actually they looked at the analysis about ABC consortium about the sequence of CAR T cell. So they they look actually to 4 groups of patients. For group 1 and 2, they receive bispecific with or without CAR T cell. Third or fourth group, they receive CAR T cell with or without previous bispecific. And we look actually the first group, which is they receive the bispecific with or without previous exposure, there was a CAR T cell exposure. Actually, there was no difference in the survival. What about the group who received the CAR T cell actually with previous bispecific? Continue, there is no difference in the overall survival with the previous bispecific exposure, but it was noticed actually. The group actually who received CAR T cell with primary refractory, they do worse, even they have bispecific, they receive bispecific. So it's well known, primary refractory is the worst group in case of relapse refractory diffuse large B-cell lymphoma.
2 minutes.
Yeah, and by that actually conclude my presentation. Thank you.
Thank you so much, Dr. Samir, for the excellent presentation. For the sake of time, I will be presenting the second, introduce the second one. I will keep the questions till the end of the session. Thank you so much. For our next session, please welcome Dr. Mubarak Al-Mansour, consultant and chairman of Princess Noor Oncology Center, Jeddah. Please welcome Dr. Mubarak. Dr. Mubarak will be presenting presentation. Now is the time to improve outcomes in diffuse large B-cell lymphoma, optimization of the first-line therapy.
طيب بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله وعلى آله وصحبه وسلم. Thank you for the organizing and the scientific committee, and thank you for the chairperson for the kind introduction. So the talk is how to improve the outcome of the diffuse large B-cell lymphoma and optimization of the first-line treatment. I will start just with the background, just to understand what happened over the last 30 years. This is the first study was published by Fisher in New England Journal of Medicine in 1993, when the CHOP was tested against the three main backbone chemotherapy at that time, which is the MAC-COD and MAC-COB and the PROMIS. And this is a combination of the doxorubicin, cyclo, and bleomycin. In that study, it showed that CHOP is the treatment that was preferred based into the efficacy and less toxicities compared to the other protocols. And then in 2002, Covier from the French group showed that R-CHOP is superior to the CHOP chemotherapy in terms of the progression-free survival and overall survival. And then over the last maybe 23 years from the CHOP or R-CHOP in 2002 until 2022, almost like 20 years, we had the PULA R-CHOP was the first treatment combination showed a superiority to the R-CHOP. We've seen many clinical trials involved a lot of patients testing the, for example, the dose-adjusted R-EPOCH, the intensified R-CHOP 14, adding the ibrutinib, lenalidomide, everolimus, and all did not show any superiority over the R-CHOP every 3 weeks. So that's the POLARIX study, which showed a progression-free survival, and that was maintained after 5 years with the hazard ratio of 0.77, so 23% reduce in the risk of progression compared to the R-CHOP in those patients with IPI 225. So from that, we have just only the two chemotherapy now available for the diffuse large B-cell lymphoma, either R-CHOP or POLA R-CHOP, and probably the dose-adjusted R-EPOCH for a certain high-grade B-cell lymphomas or double or triple hit. So is there any way we can improve the outcome? One of them is maybe to improve the classification at the molecular level, so you can specify which patient might benefit from a certain treatment. Is there a way to identify a high-risk patient after receiving the R-CHOP or the POLA R-CHOP based into the interim PIT or the minimal residual disease, so you can intensify or de-escalate the treatment based onto the responses after 2 or 3 cycles, and then incorporation of the novel agent into the front line. We've seen the talk by Dr. Samira, but bispecific into the second and third lines, as well as the CAR T cells. So can we move them early into the induction part? So I will start with the molecular subtyping of the diffuse large B-cell lymphoma. Alizada in 2000 showed that gene expression profiling came up with the 3 subgroup of patient, either a GCP, non-GCP, or the activated, they call them the activated B-cell subtypes, based into that gene expression profiling. Despite the inferior outcome between the ABC and ABC, which is non-GCP, and the GCP, but we still treat them until 2026 the same, with the same protocol. So we are not differentiating between the 3 groups based into the gene expression profiling. We have 2 different pathways. The GCP, it works by the translocation or the mutation into the BCL2, into the MYC, into the ZDH. That's different from the ABC, the gene mutation, or and that group is MYD88 and the CD9-7B. And the ABC, it works through the signaling pathway, which is different from the GCP subtypes. That might explain why maybe we've seen the Polarix study showed a superiority in ABC compared to a GCP subtypes, because it induces that signaling pathway. So because the gene expression profile was not available in the practice, most of our practice was based into the HANS classification, which is the immunohistochemistry, using the 3 CD10, BCL6, and the MUM1, just to classify the patient to GCP or non-GCP. So we cannot see here, we cannot say APC because it's not a gene expression profile, so GCP or non-GCP profiling. A lot of studies done using that cell of origin based into the immunohistochemistry, including the Phoenix study, the Remodel, the Robust, adding ibrutinib or bortezomib and lenalidomide. It did not show any progression-free survival benefit based on that classification, except maybe the bortezomib showed a superiority into the ABC, but we know that bortezomib is not one that we use in a diffuse large B-cell lymphoma nowadays. So polatuzumab, it binds to the CD79, and the monomethyl is the payload, and this works on both the GCP and non-GCP. But because the ABC subtypes dependent pathway is into the signaling pathway, that way we see more effect maybe into the ABC subtypes compared to the GCP. And this is the subgroup analysis. You can see that into the ABC, if you look carefully, those who received the Pola-R-CHP as ABC, the progression-free survival was 85%, which is higher than those received R-CHOP in 56. This is even higher than the Pola-R-CHP into the GCP. So those ABC received Pola-R-CHP, they had a superior benefit compared to the other subgroup. However, this is a subgroup analysis. It was not powered to have that analysis. So what about the double hit lymphomas? We know that our diagnosis into the practice is based into the molecular, primarily into the FISH, to see if there is any c-MYC or BCL2 or BCL6, and we used to call the MYC rearrangement with the BCL2, that's a double hit, and we used to also say MYC with the BCL6 as a double hit, but this is not the scenario now. So the BCL6 categorized now as the diffuse large B-cell lymphoma, and just only the c-MYC rearrangement, BCT rearrangement, we call them a double hit. If you have the 3, this is a triple hit. Why is that important? Because those with the c-MYC and BCL6 rearrangement, they benefited from the Pola-R-CHP more than the dose-adjusted R-epoch, and they should be treated as a high-grade or diffuse large B-cell lymphoma in OS compared to the double-hit c-MYC and BCL2. This is the study by Dunleavy. It showed that dose-adjusted R-epoch into the double hit. So why we are talking here about the double hit? Because the molecular rearrangement, it just only showed a small number of that in less than 10%. But there is now a dark zone gene expression. That dark zone it discovers those high-grade lymphoma are arranged or arised from the germinal center. They have the same genetic mutation as the double or triple hit, but those are missed by the FISH compared to the dark zone. So how many patients in our practice, they have a dark zone, but they have a negative rearrangement into the FISH? We still treat them with the R-CHOP or polar R-CHOP. So maybe in the future, any improvement into the dark zone gene expression profiling will maybe have a more patient to be treated as a high-grade lymphomas. This has become presented in many conferences talking about the cluster. There are two now modules or models to classify the molecular from one from Harvard, one from NSI, based into the genetic mutation in each group. So we are not talking here about one group of diffuse large B-cell lymphoma. It's a heterogeneous disease. So based into the B-cell classifier, so what they do, they have the molecular, they do the gene expression, and then they classify it based on what are the gene mutated in that subgroup. For example, class 1 and 5, ABC subtypes, because the gene mutation are the BCL6, the notch 2, and into the C5 is MYD88 and the CD79. And if you see the name of the lymphogene, they call it MSD. So what is MSD? M coming from MY and the C from the CD. So based on those two mutations, they call it MSD. The same for the EZB. It comes from the EZH and BCL2. So that's how they call. This is equal into the other model to cluster 1, 2, 5. And they discovered that they don't have the same cell of origin. They are different, ABC versus GCP. And there may be a clinical association with the other group, like for the marginal zone lymphoma, they have the cluster 1. C5, you might see the extranodal example, those who presented with the testicular lymphoma with the CNS involvement. And you can see the 5-year survival based into that cluster. So for example, in cluster 5, the ABC subtype, the 5 years is 26, compared, for example, to the GCP subtypes in a cluster to 100%. So this will help in the future to prognose as well as to predict maybe the modality of treatment. This is just only the same. So what is the differences between the lymphogen and the diffuse large B-cell classifier models? Into the diffuse large B class gene expression, you can see they may be classified all the group within the C1, 2, 3, 4, 5. But into the lymphogen, there is still about a 37 to a 40% not classified by that model of gene expression technique. So this is one of the main differences. So to summarize, ABC subtypes, we have the cluster 1 and 5, and that's equal to BN2 and MCD into the other model. The GCP, we have the C cluster 3 and 4, equal to the EZP and the STAT. And this cluster 2 is between. So we have a group of patients, they might have ABC origin, or a group of patients with the GCP. Again, why is that important? Because this is a possible target therapy will be used in the future based on that molecular classification. And one of the example into the Phoenix study, we remember that ibrutinib was added to the R-CHOP. So when they did a retrospective analysis, they found those patients with MCD, which is the MYD or the CD79, when received ibrutinib plus R-CHOP, the progression-free survival was 100% and overall survival 100%. So maybe identifying those patients with that technique and giving them the ibrutinib, they will get the benefit compared to the R-CHOP. This is the same in the POLARIX study, but this is a small number. When they went back to see MCD and EZP, when they received the polar R-CHOP, had a superiority compared to the R-CHOP. The guidance study is a Chinese study, and we've seen it presented in conferences. they used the same model of the MCD and the BN2 and the N1 and EZP, and they added other novel agents based into the cluster. In that study, it showed those patients who received addition novel agent based in a molecular classification showed superiority to the R-CHOP, either in progression-free survival or overall survival. But they did not specify which one. They just lumped the whole group. They did not say those who MCD, when they randomized, for example, to pool R-CHOP or to the ibrutinib, what was their outcome. So they presented just only the whole group. And this is a study, they call it the lymphomatch. And this is the future, is they will classify the patient at the diagnosis. They will give one cycles, either R-CHOP or polar R-CHOP, and then based into the molecular classification using one of the C1, 2, 3, or 4 or 5, or the other mutation according to the lymphogen. The randomization will be either to polar R-CHOP or maybe adding EZH inhibitor or the JAK inhibitors or the BTK based on each classification. So microenvironment, also they identified now 2 microenvironment, either hot or cold. Mosunetuzumab was tested in a 32 patient. It showed that with the molecular hot microenvironment benefited from the mosunetuzumab. So a lot of things from the molecular background to be seen in the future based into the molecular classification. How can we assess the response? We are assessing the response to intensify or de-escalate based into the PET scan. PET scan into the Goya study, it showed that it was a prognostic, not something that you interim PET. So those who had a PET negative compared to the PET positive showed differences in terms of the progression-free survival into the Goya study. One of the studies also, it showed that the PET positivity as interim, the main concern with it is the false positive. And this is one of the study, for example, 38 patients, they had a PET scan which was interim and it was positive. But when the biopsy was taken, only 5 patients. So the bottom line, we cannot use the Duviel score nowadays as interim to guide treatment to intensify or to de-escalate. What about the delta mask, SUV? Delta, it means that the change into the SUV uptake from the baseline and into the interim. So they calculate the baseline minus the interim divided by the baseline. It will give you a ratio. Those who achieved a more than 77% reduction into the delta SUV, it showed to be a predictive of a response after 2 cycles. So if you're gonna use the PET scan to guide treatment, use the delta, not the Duviel score according to this data. This is one of the study where they used the delta SUV, and it showed a nice separation between the 2 groups that who had a response versus no response. But when the treatment was intensified according to that change, when they used the Burkitt protocol induced with the PET positive disease, it did not show, and that makes sense. If those are not responding to the chemoimmunotherapy, intensifying with the same chemoimmunotherapy will not give a more benefit. But that was different into the Zuma study. So they used the Duviel score and they used the CAR T-cell after R-CHOP or DOJ as the support. But this is just only a one study, and that's because of the maybe effect of the CAR T-cell compared to the intensified chemotherapy. So those are the prospective studies now using the delta SUV change to intensify the treatment as interim PET. What about the minimal residual disease? They have a different minimal technique. They have the IG sequencing, the CAP sequence, or the VASE sequence. Those are all to detect the minimal residual disease during the treatment as interim or the end of the therapy. And it showed that those patients who had circulating DNA at the day 1, cycle 3 was negative. You can see the differences into the progression-free survival, 80% compared to a 41% for those either MRD negative or positive using the clonoSEQ as minimal residual disease. This is also the retrospective study. Circulating DNA was assessed after 2 or 1 cycle. If they have a minimal residual disease negative after 1 cycle, they call it early molecular response. If it's after 2 cycles, they call it a major minimal residual disease, and it showed that using the minimal residual disease can be used as a modality to maybe intensify or maybe not or to de-escalate. Phase 2 MRD, this is the Glovy R-CHOP. So what they did in this study, they give 2 cycles of R-CHOP, and then they did the circulating DNA. If it is a high risk, and the high risk minimal residual was defined by less than 2 log decrease into the minimal residual disease, they consider it as positive and high risk. And they escalated to Glovy R-CHOP. So you can see the changes from the overall response rate after 2 cycles of R-CHOP. The CR was 60% and improved to 85% after adding the Glovy to the R-CHOP. So this is one of the modality that you can early detect which patients they might benefit from intensifying the treatment based into the interim or the minimal residual disease. The same data, sure, from the prospective frontline diffuse large B-cell lymphoma. Those are the ongoing studies incorporating the response adapted, so I will not go through these things. The ALVA study also, one of the study after the treatment was completed and achieved a complete metabolic response on a PET scan. If they have a minimal residual disease positive, they escalate to a CAR T cell, so waiting for the results. So the last part is selecting the best treatment. We've talked about the POLARIX study. We have a data from a phase 2 about the bispecific into the induction. We've seen the CAR T cell in the ZUMA 12 and bispecific epcoritamab, R-CHOP, and also the Glovy. And now those are the running ongoing phase 3 frontline study. So bispecific, we have the SkyGlow with the Glovy, Pula R-CHOP, the EPCOR, diffuse large B-cell lymphoma, epcoritamab, R-CHOP compared to R-CHOP, Olympia, which is the odrontuximab compared to R-CHOP, CAR T-cell is the ZUMA study, AXI, and then other targeted agent in the front line as the Tavalin or the acalabrutinib, and you can see the completion date beyond the 2027. So a lot of novel agents into the frontline treatment. So in conclusion, the cell of origin can guide the treatment, and we've seen the data from the POLARIX, the genetic subtypes, example, those with the cluster 5 and MSD, they might benefit from the novel agent as a BTK, and comprehensive use of a PIT plus the minimal residual disease will guide the treatment in the future to escalate or de-escalate. And we have to wait for a lot of the ongoing randomized trial incorporating the CART, bispecific, and other novel agents. Thank you.
Thank you, Dr. Mubarak, for excellent presentation. So we'll keep the question at the end, and we'll move to the third presentation, which will be presented by Prof. Riyad Dada, who's a senior consultant medical oncology at King Faisal Specialist Hospital and Research Center, Jeddah. And Prof. Riyad will present is there still a role for autologous stem cell transplant in mantle cell lymphoma? Prof.
Thank you, Dr. Ahmed. Thank you, Dr. Ahmed. Do anything? Yes. So, this is the topic of my talk. Is there still a role for auto transplant? يعني مش تعطوني شيء سهل يعني BTK, the role of BTK mantle cell lymphoma ولا bispecific ولا أي شيء زي كذا. This is an ongoing debate since more than 20 years. وأنا المسكين نحل لكم إياها. فأنا نشوف. بسم الله الرحمن الرحيم. So first of all, maybe some introduction about mantle cell lymphoma. And I understand here not only experts are sitting, but some trainees who want to learn something. So mantle cell lymphoma is accounting for 6% of all non-Hodgkin lymphoma, and I believe in Saudi Arabia this is not different. We have probably 40 to 50 cases, new cases per year in Saudi Arabia. Mantle cell lymphoma is more common in men, also 4 to 1, around 70 to 80% of cases are men. And the median age at diagnosis is 60 to 70. And mantle cell lymphoma has a leukemic presentation in up to 20 to 30% of the cases. And most of the cases to have advanced stages, which means if you have a referral, mantle cell lymphoma with a report stage 1 and 2, you have always to question mark this. You have to do all needed tests in order to prove or to exclude that the patient has an advanced stage, PET scan, endoscopy, whatever. So the driver for the development of mantle cell lymphoma relies in the translocation 11, 14, 11. The CCND1 gene is located in chromosome 11, which is encoding for the cyclin D1. And we know cyclin D1 is promoting the cell proliferation. It's usually inactive. On chromosome 14, it's encoding for the EG light change, and we know that there is hypermutation in order to produce many antibody directed against thousands and thousands of epitopes. And if the CCD1 gene translocated nearby the heavy chain gene, it will be automatically activated, and the overexpression of cyclin D1 will take place, and this will promote the B cell activation, leading to malignancy of this specific clone. Mantle cell lymphoma is divided to classical mantle cell lymphoma or leukemic, which is usually non-nodal mantle cell lymphoma. Again, this is not very frequent, around 20 to 30% of the cases, and usually in many cases you don't need to treat these patients. This is in the opposite and contrary to other lymphomas. Diffuse large B-cell lymphoma, as example, if you find malignant cells in peripheral blood, you have to treat. So in mantle cell lymphoma, you don't need necessarily to treat this patient. Don't panic. And we have also the blastoid variant of mantle cell lymphoma, which is an aggressive form and requires treatment always. We are categorizing mantle cell lymphoma in high risk and low risk according to these parameter. Low risk Ki67 less than 10%, high risk more than 10%, SOX11 negative, blastoid 611 positive, and so on. And just for completion, we have the MEPI score, we have the FLIPI in follicular lymphoma, the IPI in Hodgkin, and MEPI was developed. Why? Because it's important for anticipation, how long the patient will survive, how the patient will do with any treatment. You can see that patient with low MEPI, they have a better outcome than those with high MEPI score. But in fact, as in follicular lymphoma, we don't need to treat all newly diagnosed patients with follicular lymphoma. Specific, those patients with not blastoid morphology, normal LDH, low Ki67, and so on. So, as not all mantle cell lymphoma needed to be treated. Over the past years, decades, it has started, there was different advancement and approvals in mantle cell lymphoma management. Has started with the approval, as Mubarak mentioned, for rituximab in 22, and thereafter we have the MCL network study, autologous stem cell transplantation, Nordic. Then we have the era of PTKs, Broxycell, and lately pirtobrutinib, which has been approved in mantle cell lymphoma. We'll go to that one by one. But we learned here in mantle cell lymphoma that we have to differentiate between fit patient and unfit patient, those who are eligible for those intensive chemotherapy and those who are not fit for that. And this is important when we have NEU patients. But one by one. This slide I like the most. If we look to the left side, this cartoon by eras and treatment. And هنا سأصمت قليلا. Why? Anyone knows why? Anyone who wants to answer the question whether autologous stem cell transplantation has a major role in the management of mantle cell lymphoma? Anyone noticed anything? Look here. So, mantle cell lymphoma was investigated, well, has been investigated since 1996. You can see, look after 8 years. Mantle cell lymphoma followed by CHOP. And this is reflected the overall survival, by the way. The overall survival of the patient is in the range of 30%. Tamam? Then we have R-CHOP introduced. With auto-transplant, as a changing from CHOP to R-CHOP, but with auto-transplant. The overall survival improved to near 60%. Tamam? Then we have the addition of RDEHA. R-CHOP, RDEHA, and auto-transplant is still there. Overall survival was improved to 70%. And now we are in the era of PTK. With auto and without auto, the outcome, the overall survival has improved to above 80%. What does this tell us? مين يعرف? It is not only the auto transplant which is improving the overall survival, it's probably the induction, it's probably the treatment what we choose prior to auto transplant. And this is actually the answer of my talk. I can stop here, but let us go one by one. هذه الستدي اللي everything has started with it for auto transplant, and then after people they consider auto transplant as standard of care. So this is the MCL network study where patients were treated with CHOP 6 cycles. Thereafter, they reached partial remission or complete remission. The patient were randomized to 2 additional CHOP, and I think the older from us, they know that earlier we treated our patient with 8 cycles, not 6 cycles. As 2 cycles followed by interferon maintenance. And the other arm, the patients were consolidated with autologous stem cell transplantation. Tamam? And this is the data what were published in Blood in 2005. Auto transplant showed a better PFS than interferon. Everyone jumped on that. Auto transplant is now standard of care in mantle cell lymphoma in eligible patients. But the study was conducted, it has started 1996, and CHOP, rituximab was not approved yet. And many of the patients who were included in the study, they were treated with CHOP. The rituximab approval came later on in 2002, and the study was amended, and rituximab was added, but it was added just to 26% of the patients. If you look to the PFS of patients, the 61% of the patient who received CHOP, auto versus no auto, there was no significant difference, which means the main driver for the benefit was, by the end, rituximab. Again, we are coming back to the previous curves with better induction, better outcome, not the transplant. طيب, I have to be fair as well and looked after real-world data. And the real-world data from the same group, the Nordic group, they look to their data, and most of the patients, they received the Nordic regimen as a dose-intense chemotherapy, 97%. And they compare those who received auto versus who did not receive auto. Majority did not receive auto. And you can see here, there is even an overall survival benefit according to these retrospective data. But I know auto transplant in mantle cell lymphoma is not acknowledged as a curative option. So at that time, I said the data were published in 2005, and the paper which showed that there is no benefit between CHOP and auto transplant arm, it was published 2021. And between 2005 and 2001, everyone who was conducting clinical trials with the younger patient, he used the auto transplant as this is the case. Used the auto transplant as a standard of care. And this is the MCL younger study, which is a respected study. It compared basically two different regimens, 6-R-CHOP or 6-R-CHOP plus DHAP, and they found that the cytarabine containing regimen is the one which is the best, as that was taken as standard of care, R-CHOP, R-DHAP, followed by auto transplant. And thereafter we have the Lima or the LISA study, where they established rituximab maintenance for 3 years after autologous stem cell transplantation, of course, after R-CHOP and R-DHAP, leading not only to PFS, but only to OS. And this is probably the only study, to my knowledge, where maintenance rituximab in lymphoma showed an overall survival benefit. Really a good and straightforward study if you want to offer your patient auto transplant. The follow-up data confirming and maintaining benefit of auto transplant and rituximab maintenance in terms of PFS and OS. But wait a little bit. They used R-CHOP in both arms, in the LISA study and in the MCL younger study. We know that this is trivial, I think. Why are using R-CHOP? We know that R-CHOP in mantle cell lymphoma is inferior to bendamustine. And this we know from the STEEL trial and the BRIGHT trial. So it has to be here question marked. Bendamustine was studied against cytarabine-based regimen in this study, S1106 study. Despite premature termination of this study, I think some hint and some information we could win. There was no difference in PFS and OS between BR, as bendamustine rituximab as induction, and the intensive chemotherapy regimen containing cytarabine. So the British Columbia looked as well to their data. Patients who received R-CHOP, R-DHAP as an intensive chemotherapy followed by auto transplant were were retrospectively compared with their own data, and patients who received rituximab plus bendamustine followed by autotransplant, and there was no benefit from dose intensification if you go for autotransplant. No PFS, no overall survival benefit. This cartoon is from the US, looking at the change in pattern in first line, the trends, what physicians are doing. And you can see here that we are moving away slowly from cytarabine from around here 30-40% to probably here a little bit more than 25%. But we are in younger patients. I'm not speaking about older patients here. In younger patients, we are using more and more bendamustine and rituximab, acknowledging now that BR is a better partner in such cases. Now we are coming to this study, which is actually answering some of the questions. The triangle study, I will go very quick. All of us, we know the triangle study, a 3-arm study in patients younger than 65. Standard of care at that time versus standard of care plus ibrutinib versus R-CHOP alternating with RDHAB with ibrutinib followed by autotransplant and rituximab and ibrutinib maintenance. I will go through very quick through the study. So you can see here, autotransplant failed to show superiority over ibrutinib alone. And auto plus ibrutinib failed to show failure-free survival superiority over ibrutinib alone. In fact, there was a superiority of ibrutinib over autotransplant in terms of FFS and in terms of overall survival. The arm of the ibrutinib has a better overall survival than the arm of autotransplant.
3 minutes, Prof.
Inshallah, بنحاول نعجل. This is to answer the question, do we need autotransplant? No. What is this? Autotransplant has high-risk patients. Yeah, subgroup of patients might benefit according to the triangle data from autotransplant, especially those who have a KI 67, 50 and more. Autotransplant is not a best option. It is individualized decision, I think, because of the high toxicity. And we are coming now to this interesting study, and this is probably will give everyone the information he or she needs. The patient up to 70 were treated with treatment, with physician of choice treatment, any treatment. Then the patient had MRD tested. If the MRD is negative, the patient, and about 80% of the patients, they were MRD negative. This is very important information. If they are in complete remission, they are randomized to auto plus transplant plus rituximab or rituximab maintenance. MRD positive, auto transplant. These are the patient characteristics, and most of the patients, they received intensive regimens. And this is showing that in MRD patients, MRD negative or UMRD, undetected MRD, there was no benefit of autotransplant addition in MRD negative patients. And OS also, there was no OS benefit. So with that, the study concluded that MCL patient in first complete remission with undetected MRD did not benefit from consolidative auto. Some of the patients who have an MRD positive disease and went for transplant, they benefit in terms of PFS and OS. But how much is it? Just 3%. That's why I think it has to be individualized. Looking to the NCC guidelines, if patients reach complete remission, undetected MRD, maintenance rituximab, no auto-transplant. Based on the study before, if the patient has MRD positive, consider autologous stem cell transplantation. And please keep in mind, the benefit according to the study, the ACOG study, was just 3%. So I will jump very quick through the last slides because the time is over. We have new novel agents, which I think will displace the auto-transplant, like this combination, zanubrutinib with Arduhax, where some patients receive auto, but I can tell you here in this study, just five patients received transplant. And despite that, the overall survival in 2 years was 100%. So an era for improvement is here. We don't know what to do with these patients, the P53 patients. They have a less favorable outcome with even with dose intensification of chemo, with high-dose chemotherapy and transplantation. They don't benefit necessarily from that. And it has been investigated here in the Ssbmt trial, TP53 patients were included, and you can see this combination might be the magic for such bad risk patients. Zanubrutinib venetoclax delivers excellent outcome in all subgroups, regardless of TP53 mutated or not. We have also glofitamab, which interesting, complete and overall response rate. We have bolatuzumab with mosunetuzumab with an overall response rate of 75% and complete remission of 70%. And we have Bruxocel data already approved in mantle cell lymphoma. We have also Ssbmt data with encouraging overall response rate of 83% and complete remission rate of 72%. And if you look to the MCL network charter for the upcoming studies, you can see here in first line, they are still offering auto-transplant, but they are offering also upfront CART with no transplant. So with that, I would like to conclude. The triangle study showed that auto-transplant is not superior to ibrutinib without a transplant. Currently, there is no decision whether auto-transplant has benefit to ibrutinib, but for certain, there is more toxicity with the addition of auto-transplant. Patients with high-risk Ki-67 may benefit from adding of CART, but take care, the number of patients included in both arms was 47, 46, as not too many patients. The ER4151 study showed that MRD negative complete remission patients do not benefit from auto-transplant, and these numbers are 80% of all patients included. MRD positive patient after induction may benefit from auto-transplant, but the magnitude of benefit was just 3%. That has to be taken in account. Patients with TP53 do not benefit from intensification, and novel agents might be the gap. And I think with the advent of higher effective novel agent, CAR, bispecific, PTKs, I think these are challenging the auto-transplant, and auto-transplant hopefully will diminish too. Thank you very much.
Thank you so much, Professor Rihad, for this excellent presentation. For the sake of time, we'll keep the questions till the end of the session. Please welcome next Dr. Hafiz Malhan. He is the Medical Director at Jazan Specialist Hospital. He will be presenting to us lymphomas in HIV-infected patients.
السلام عليكم. حياكم الله جميعا. مبدئيا أحب أشكر الدكتور عسكر والدكتور باهر رفعت على استجابة الدعوة وإقامة المؤتمر في جازان نيابة عني وعن الزملاء والزميلات في هيماتولوجي جيزان. أتمنى لكم إقامة ممتعة إن شاء الله، تستمتعوا بأجواء جيزان وأكلة جيزان، المناطق السياحية. شكرا Mr. Chairman for the introduction, and thank you for the organizing committee for the accepting to participate in sharing our experience with HIV-associated lymphoma. Initially, we started in oncology service in Jizan since 2014. Thank you, Dr. Bakkar. He was with us before he left to Riyadh. Over 10 years, then we moved to new hospital in Jizan, مستشفى جيزان التخصصي, Jizan Specialist Hospital. Is a new hospital, 500 bed. We just started in 2025. In March, we started the first admission with first hematology patient. Inshallah, we have more advance, inshallah, in the next few years. So general overview, because of the time, I apologize to skip some slide for the time management. As you know, HIV-associated lymphoma still matters, yes, because the risk is increased up to 20 times in population affected with HIV as compared to general population. Is considered number one cancer mortality and leading cause of cancer-related mortality in patients living with HIV. It's considered as first presentation in around 20% of patients. And is it global burden? Yes, is around calculated or reported up to 338 million people living with HIV worldwide. This means more lymphoma associated with HIV it will raise. Again, the burden before the era of heart, it was around 463 per 100,000 person years before the medication of HIV. After that, for NHL, for non-Hodgkin lymphoma, the incidence increased up to 50%. That means good job of heart medication. For Hodgkin risk, maybe the opposite is there. There is increase in the cases, in the incidence of the cases, even with use of heart medication, the risk up to 26-fold increase the risk. Lifetime burden by age 75, non-Hodgkin lymphoma up to 4.5%, and Hodgkin lymphoma 0.9 in affected patient versus 0.1 in non-affected. Non-Hodgkin, as mentioned, is decreasing in the era of heart medication, and the Hodgkin increasing due to different mechanisms. The Hodgkin require moderate immunity to form tumor microenvironment and driven by persistent, mainly AB virus. Subtypes of HIV-associated lymphoma, we have diffuse large B-cell lymphoma up to 50%, Burkitt it happen up to 30%, Hodgkin up to 15%, and plasmablastic lymphoma 10%, and primary CNS lymphoma less than 5%. And this graph shows the incidence over the years. As you see, diffuse large B-cell lymphoma is decreasing in the incidence. Hodgkin is increasing, and other also like primary CNS lymphoma and primary plasmablastic lymphoma is decreasing in the incidence. Pathogenesis key concept is different mechanism for this disease. Immune dysregulation, oncogenic viruses, and HIV protein effects have a major role in mechanism of lymphoma in patients with HIV. Clinical feature, up to 80% of this patient presenting in an advanced stage from 3 to 4, extranodal up to 70%. Majority of patients will present with B symptom, and up to 20% they will present as first presentation for their HIV. The most common site is GIT, represent 30%, and bone marrow 25%, CNS and liver as well as spleen from 15 to 20%. Difference between HIV, acute lymphoma, and general population. As mentioned, the diagnosis, they are early, they mainly present in advanced stage, up to 7, as compared to the other patient, extranodal, and they are invasive, frequent extranodal unseen SN up to 80%, and highly frequent TB symptom presentation. Diagnosis as well as any patient, other patient with lymphoma, but CD4 count and viral load is very important, as well as other viruses like ABV virus. For the treatment, it's very important the curative intent therapy and continuous heart medication even before starting chemotherapy. No treatment delay, just to have good outcome, and supportive care is important for monitoring the febrile neutropenia and sepsis complication. The gold standard of the first line therapy for diffuse large B-cell lymphoma R-CHOP, and I didn't find any reported cases of the novel agent, Bola R-CHOP. I'm not sure about it. And alternative regimen, dose adjusted EPOC as well as R-Minichop according to the severity and managed by age specification. Also, RCEB is considered in patient with cardiac toxicity. For Hodgkin lymphoma, AVBD is still the standard of care, although brentuximab have been reported in some cases, and we have our own experience in this immunotherapy. Burkitt lymphoma intensive regimen is there. Codex M-IVAC or dose adjusted EPOC is very important in those patients, with a response rate up to 80% and 3-year overall survival up to 70%. Also, plasmablastic lymphoma and primary CNS lymphoma, also in those cases, are very aggressive with low incidence with after start of heart medication, R-CHOP or CHOP-like, as well as high-dose methotrexate in patient with primary CNS lymphoma has a major role in these cases. So what about the national data in our country for those patients with HIV lymphoma? I think in Riyadh they reported up to 22 cases. Nassakaf and his group in King Fahd Medical City, also Al-Yamani reported around 8 cases, 2 of them HIV positive. And also Saleh et al. in King Faisal Specialist Hospital also reported 1 case Hodgkin lymphoma with HIV who was also treated with CAR T-cell. This is more. This is for the data by King Fahd Medical City from March from 2017 to 2025. They reported 22 cases. B symptom was there in 86% with advanced stage up to 68%, and CR in around 60% with median overall survival 12 months. Our cases, we have number of HIV lymphoma attending our clinic in Jazan. We reported 10 cases since 2021 till 2020, beginning of 2026, with various type of presentation. We have brief presentation, description of the cases, and interesting cases will be presented, and most cases are referred from infectious disease department. Median age of presentation is around 40, the range from 30 to 67, and there is male predilection in around 8 cases. 2 cases are female. Most cases have good ECOG and performance of 1 and 2 upon presentation. CD4 count are mostly low, less than 100, indicating late stage of AIDS except among those who started the heart medication in 2 cases, and only 1 patient had concomitant hepatitis B and C. Type of lymphoma showed we have 5 cases with diffuse large B-cell lymphoma, 3 of them ABC, and 2 cases germinal center, another 2 cases with Hodgkin lymphoma, and 3 cases with plasmablastic diagnosis. Stage of disease, as mentioned, are usually 3 and 4, and extranodal involvement is seen in half of cases with CNS, nasopharyngeal, kidney, and liver. Chemotherapy we used in those cases, CHOP and R-CHOP in 3 patients with diffuse large B-cell lymphoma, EVOC in 3 patients, ABVD in 2 cases. 1 of them shifted to brentuximab AVD, and 2 cases received RCVB. The most common complication was febrile neutropenia. The response in those cases was 60% who achieved remission, and 40% either early mortality or progressive disease. I will share 1 case is around 40 years old female patient, non-cause of HIV, presented to ID team with huge hepatomegaly and pelvic inflammatory disease complicated by vaginal fistula. Her CD4 count was initially 14. She was started on heart medication, and biopsy was taken from her liver, showed high-grade B-cell lymphoma, positive for with confirming the diagnosis and of diffuse large B-cell lymphoma with Ki-67 up to 90%. BAP cervical smear, it was malignant cell identified consistent with squamous cell carcinoma. She was operated, underwent total abdominal hysterectomy and salpingectomy, ovarectomy also, and the histopathology came as pancreas precancerous, so it was agreed to start her on CHOP, and first cycle was R-CHOP because of eligibility issue. As soon as her surgical incision heals with no risk of being infected during the neutropenia, and she completed 6 cycles in December 2025, waiting for end of therapy BAN-CT. Another unfortunate case is 41 years old male patient in case of HIV diagnosed 1 year before presentation, started on heart and CD4 count was 600, stopped heart for 2 months before presentation, and he presented with huge jaw swelling attributing to dental issues, and he had huge cervical lymphadenopathy, so which biopsy was done in August 2024 and showed the diagnosis of plasmablastic lymphoma. He's agreed to start on ABOC, showed marked improvement after 2 cycles, yet he missed 3 weeks gap and came with again huge mass, and he was discussed again. A lymphoma board agreed to give DARA Velcade. ABOC and the cell disease was very aggressive. Again, another second opinion from our colleague in higher center, and they recommended DARA GMOX, and it still was progressive. Finally, another counseling with higher center, including patient himself, and finally agreed to take him with hyper CFAT, but the disease was very aggressive and patient was died due to mass compression effect. So in conclusion, we had in our center over 5 years, 10 cases of different types and presentation with late presentation. Young male patients predominate, 80% of them did not start heart medication for HIV. CD4 was very low in 80% of those patients, ABV positive in most of the patients, and response rate 60%, that's similar to national and international findings. Complication, mainly febrile neutropenia that need close monitoring. By this, thank you, and thank all my team, the nursing and medical in our department. Thank you very much.
Thank you so much, Dr. Hafiz, for this great presentation. Due to the short time, we're just going to have enough time to have 2 quick questions to our presenters. If you can, please welcome to stage. You can provide the few chairs. Dr. Samir, Dr. Mubarak, Dr. Riyad, and Dr. Hafiz. Any questions? Please, can we provide a mic, please, for...
Thank you for the excellent session. My first question is to Dr. Riyad. What about the CNS infiltration in mantle cell? In our institute, we used to see cases with CNS infiltration, especially elderly. Do you go for irradiation only or irradiation plus intrathecal chemo, triple chemo? Actually, that's what we use in my institution. And my second question is to Dr. Hafiz. Congratulations for your cases. In Egypt, I'm from Egypt. In Egypt, we used to see many cases of lymphoma with HIV among our refugees. We have more than 12 million refugees in Egypt, and we have some bunch of them from Africa, Equatorial and Sub-Saharan. Actually, I've seen many cases with different presentation, Burkitt nasopharyngeal CNS, but recently, in the last months, I saw a case with plasmablastoid affecting even the spleen, and I'm considering to add bortezomib with DARA. What's your opinion, and should we proceed for more aggressive chemo plus that, or because your case, which is very good illustrated, added DARA to chemo, which was not that much effective. What's your advice?
With regard to the first question, excellent question. So I'm giving this talk, I give this talk in many countries, and I got always the same questions. MTX for patients with CNS relapse, mantle cell lymphoma. Luckily, we don't have, at least in my institution, we don't see too many patients who have CNS relapse. I have currently one patient who just recently admitted a relapse case with histology, mantle cell lymphoma, Ki67 increasing from 60 to 85%. He's confused, and I am afraid he has CNS infiltration. We'll do an MRI. But what we do here, because most of the cases will be parenchymal, we will do MTX not intrathecal. We'll do MTX IV, 3.5 gram per meter square. I give usually 2 to 3 cycles if the patient can tolerate it. Combine it, because it's usually combined with a systemic disease, we will alternate it then with the treatment. So radiation would be an option for patients who are not eligible for such intensive chemo. Elderly patients is also legitimate.
Thank you, Doctor, for your question. Regarding the DARA and Velcade in our patient, the patient actually, also the CD4 count is around 600, but after that, the patient, he lost the treatment, the compliance to treatment of the HIV, and also the compliance to chemotherapy regimen or the schedule. He was not compliant to that, and the disease was very aggressive. For Velcade is approved, I think, with EPOC or other regimen for the patient with HIV. And now currently we have one patient, and he achieved good response with Velcade EPOC. DARA, we looked for it, is not, there is no clinical, there is no approval for till now, it's still in the clinical trial. Yeah, still. I think, but if you have patient resistant, I think you can try it in difficult cases.
Thank you very much. Any other questions?
Maybe the last quick question to Dr. Samir. So beyond the effectiveness and when to choose CAR T cell versus bispecific, is there any data about the different CAR T and the different bispecific? Quickly, if you don't mind.
Okay, so let's start with the CAR T cell. So for the CAR T cell itself, let's say you have all the products and the patient is eligible for the CAR T cell. So which product will you use? So to make it, for the third line, you have either Axicell, Lisocell. We not use Lisocell, but in some patients, we know, as I showed earlier, like with Lisocell, the toxicity is lower. So if you have some patients elderly with mild comorbidity, you can use Lysocell over Axicell. This is in the case of CAR T-cell. For bispecific, until now there is no comparison. So if which one you have it, you can use it. But the advantage of like Glofi over IPCO, Glofi is a fixed duration, so for 1 year. But the IPCO, you will continue until disease progression. So it's at that time, so it's patient preference.
Thank you. And last question for Prof. Mubarak. So when do you expect that for large B-cell lymphoma we start to do further testing beyond what we do now, like circulating cells and genetic studies, NGS and others? Because as you mentioned now, there is discrimination between types of patients based on their genetic basis. So when do you expect this will be part of standard of care?
I think this is very important, and I think the barrier or the challenges primarily now with the either the MRD techniques. One of them is generalizability of those techniques into the worldwide and to have it as a common practice. So this is a main challenge. The second is the work flow. The third is the cost and monitoring. We've seen the gene expression profiling in 2000s and now more than 25 years and still not available into the practice. So hopefully one of those commonly used wide will be applicable just into the future. But until now, it's not in the practice, just only clinical trials. When, I think this is difficult to question, but it depends on how those are going to be commercially available with a high validity and reliability to be used in the practice.
Okay, so at the end, I would like to thank all of you for your time and would like to thank our speakers for their excellent presentation. Now it's time for Jum'ah prayer and lunchtime. There is a nearby mosque around 10 to 15 minutes walk. And we'll see you back, inshallah, at 1:30. Thank you.
Hello, everyone. We'll wait for another few minutes just to gather more people. It's an important talk, so I think we should have more people inside. Thanks. Good afternoon, everyone. We'll start the session. It's my pleasure to present Dr. Ayman Hijazi. He's one of the known figures in the scientific hematology committee environment. He's an assistant professor of hematology oncology at King Saud bin Abdulaziz University, consultant at the Division of Hematology, Adult Hematology at King Abdulaziz Medical City. He has extensive training in malignant hematology and bone marrow transplantation. And he had made significant contributions to the field through his roles as consultant and director of the Saudi Hematology Fellowship. We look forward to his insights and expertise during today's conference. Please join me in welcoming Dr. Ayman Hijazi, please.
السلام عليكم. أيوة في هنا. السلام عليكم. Good afternoon. We were waiting for Dr. Asker, so he just arrived, so we can start. It's just after lunch, and it was given the task to talk about frontline management in multiple myeloma. Although I guess it's a huge topic, but I'll try to summarize it as much as possible. First of all, I'd like to thank Dr. Sultan for the introduction. So, traditionally speaking, multiple myeloma, when we start treatment, we stratify patients based on whether they are transplant eligible or transplant ineligible. And those who are transplant eligible get some form of induction, and then transplant, and then plus minus consolidation, then maintenance. Those who are not eligible, they get long-term treatment, more or less similar with downsizing of the treatment. As we know, myeloma is a relapsing disease. Now, let's talk about what are our goals of treating these patients. First of all, rapidly controlling the myeloma, trying to reverse disease-related complications, bone fractures sometimes, and kidney failure, and many others. Obtain the deepest possible response, and that is equivalent to the longest duration of remission. As you can see in the curves, the deeper the remission, the longer the duration of remission that you can achieve. And then achieve that with the minimal toxicity that is based on the treatment you choose. So let's start with the transplant eligible patients. I guess there are people here who can remember VAD. Maybe Dr. Asker, Dr. Ahmed Said, and many others, I would say. So transplant eligible patients, we used to give them VAD few cycles, 2 cycles, 3 cycles, and then transplant them. And the first regimen that has come after VAD is TAL-DEX, if you remember. And then we used TAL-DEX as a doublet. And then bortezomib came into play. And then BTD became our popular regimen as a triplet. And then once lenalidomide came in, replaced thalidomide. So TAL-DEX was okay, but we know 3 drugs are better than 2. I'm just showing you the SWOG trial to prove the concept. The SWOG 777 was done in all patients, and it has shown that VRD 8 cycles followed by RD is better than RD. So you can see median PFS 43 months versus 30 months. So BTD-BRD was the standard of care. In Europe, it took them a long time to replace thalidomide with lenalidomide. And many of the trials that we wanted to be done with lenalidomide has been done with thalidomide based on the approval process in Europe. So if three drugs is better, can 4 be better? So the first trial, which was done back where thalidomide was the standard of care and you cannot give lenalidomide as first line in Europe, so they were giving VTD in transplant-eligible patients. So they added DARA to VTD in the Cassiopeia trial. As you can see in the Cassiopeia trial, I mean, PFS is better with the DARA VTD as compared to VTD, but I don't know if I can point here. Oh, but you can see it? So if you look at these bars, see, this is DARA VTD followed by DARA, and this is VTD followed by DARA, because they have an arm with DARA maintenance, but there was no randomization. I mean, the difference here between these two bars is not huge. So that's why we had the notion, is DARA or anti-CD38 maintenance after induction and consolidation with an anti-CD38, is it very much beneficial or not? And this question is still ongoing. So DARA VTD is better than VTD. How about VRD? I mean, this is the Griffiths trial, which was a phase 2 trial, basically in small number of patients, 200 patients that were stratified DARA-BRD transplant, DARA-BRD consolidation, and DARA-R maintenance. But the primary endpoint was basically stringent CR. You can see here that patients, this is the clinical cutoff. I mean, comparing this bar to this bar, this is DARA-BRD versus BRD. Definitely better. And PFS is definitely better. But this was phase 2, small trial, and primary endpoint was not PFS. So we were waiting for the big trial to prove that DARA-BRD is better than BRD, which is the Perseus trial, which was presented not in this ASH, the last ASH, and was published. So Perseus trial is DARA, I mean, the investigational arm is DARA-BRD, followed by 4 cycles, consolidation 2 cycles, followed by maintenance DARA-R. And there was MRD testing done annually. And for those patients after 1 year of DARA-R maintenance, they are MRD negative, they continue, and if they have consistent MRD negativity at 2 years, then you can stop DARA. This was inherited was within the trial protocol. The primary endpoint was progression-free survival. So you can see clearly here that DARA-BRD is better than BRD in terms of progression-free survival and even MRD negativity. This is a forest plot. All subgroups benefited from DARA-BRD versus BRD, except the older patients, which we do not have an explanation. And this is an estimated median PFS. The median PFS is estimated to range between 158 and 255 months. But the best fit is 17 years of median PFS in an upfront trial, which, time only will tell, but this is an estimation, something that you can get a PFS of 17 years in multiple myeloma just based on the upfront line therapy. Now, that was the DARA-BRD, the Perseus. How about the other anti-CD38, which is isatuximab? Isatuximab was also tested in combination with VRD versus VRD in the HMMG HD7 trial. This trial, there was, you can say, 6 cycles of induction. It's written 3 every 6 weeks, but 3 weekly regimens. So more or less 6 cycles induction, no consolidation, and a randomization to either ISA-R or R. Unlike the Perseus trial, there was no randomization for the addition of anti-CD38 in the maintenance arm. So therefore, you get 4 arms. Those who had ESA-BRD group and had ESA-R maintenance or R, and BRD group who had R or ESA-R. Total number of patients, 662, and the primary endpoint was, in fact, MRD negativity. So a primary endpoint after induction was proven to be superior with isatuximab BRD versus VRD, as you can see here. And then even post-transplant, it was still consistently better. Now, we can see here the PFS is better with ISA-BRD versus VRD, but the table, this Kaplan-Meier curve is for patients who had ISA-BRD and then had maintenance R, and those who had VRD induction and maintenance R. You can see clearly here by adding isatuximab in the induction regimen only gives you about 10% increment in the PFS. So you can see here 84 versus 73 at 3 years estimated, and 4 years 74 versus 64. So it gives you a 10% extra just by including it in the induction. I just want to see if ISA-BRD followed by ISA-R, that was not published yet, is it going to be beneficial, the addition of isatuximab or an anti-CD38 to maintenance when you had an induction with an anti-CD38 therapy. Recently, we have published from the Saudi Myeloma Working Group our guidelines in the frontline management. This is a summary of transplant-eligible patients. So we stratified patients into whether they are standard risk or high risk. Standard risk induction 4 to 6 cycles of an anti-CD38 VRD, whether DARA VRD or ISA VRD, based on what I have just mentioned. And we have kept the option of delaying transplant by collecting the cells initially in these patients, and you have the option of going upfront transplant. In high-risk groups, again, an anti-CD38 VRD induction, but we have also kept the choice of adding anti-CD38 to KRD as an induction in those patients. And I will go over a little bit about the evidence. And then in the maintenance arm, in the standard risk patients, we kept lenalidomide alone. In the high-risk group, a doublet, either len-bortezomib or dara-len, as we have seen in the Perseus trial. Now the question is, which proteasome inhibitor to give an induction? We have bortezomib, carfilzomib. Do we select high risk? We give them all carfilzomib based. Do we have enough evidence to do that? The best way of doing it is to have head-to-head comparison between bortezomib-based regimen and carfilzomib-based regimen. Do we have such a study? We do, but unfortunately, in standard risk patients, which is the endurance trial, there was, and this was a negative trial, there was no difference in median PFS between KRD and VRD. Recently, in the last ASH, last month, this was presented, the COBRA trial, comparing KRD to VRD, and we thought we will get the answer. But unfortunately, this was not regimen to regimen, it was a protocol to protocol comparison. So they gave KRD for 2 years, followed by our maintenance, or VRD only 8 cycles, followed by RD, similar to the SWOG 777 protocol, compared to 2 years of KRD. Anyhow, they were able to prove that KRD is better than VRD in the standard risk and high risk, and mainly in transplant-eligible patients. And this was the conclusion of the authors. COBRA showed superior efficacy of KRD versus VRD, BFS benefit of KRD, but we know for a fact there was a huge difference in duration of treatment. 2 years of KRD versus 8 cycles of VRD. So this trial does not answer the question, whether KRD is better than VRD in these patients. But there are other studies that have tested the addition of carfilzomib upfront in patients with a high risk or myeloma. The ISKIA trial was presented not this ASH, last ASH again. ISKIA trial was ESA KRD versus KRD in transplant eligible patients aged less than 70 years with ESA KRD, showing excellent results in those patients. And you can see here that probably ESA KRD can overcome some of the risks of the high-risk group. See, you can see here, this is MRD negativity, 10 to the minus 5 by NGS. These are patients who had no high-risk feature. This is one high-risk feature, and these are two high-risk features. And you can see the ESA KRD arm is more or less similar in all groups, meaning probably the addition of carfilzomib or changing bortezomib to carfilzomib probably can overcome some of these high-risk features. The GMMG concept trial was done mainly only in high-risk group patients, whether transplant eligible or transplant ineligible, and we can see here decent MRD negativity in those patients. Median PFS was 72.8 months in transplant-eligible patients and 51 months in transplant-ineligible patients. Recently, the MEDAS just wanted to show something here. You can see this. The MEDAS is recently, published in the ASCO. And you can see here it's 4 groups, and they were challenging the same question that we have challenged many times, whether we need transplant or we don't in transplant-eligible patients. You can see here, and this was challenged in the standard risk arm, not in the high-risk arm. But in the standard risk arm, here they put ESA KRD 6 cycles followed by LEN 3 years, or auto-transplant ESA KRD 2 cycles followed by LEN. You can see here, this arm A and B, there isn't really much of a difference. Is this enough evidence to omit transplant in standard risk? Of course not. So until now, we have some evidence from different trials, but still, I remember the 40 trial also challenged the same concept, but in the 40 trial, also transplant did make a change and still standard of care. Still we are, كم باقي لي بالله؟ وينها هي؟ باقي 8 دقائق كويس. Pushing the boundaries. So after a quadruplet in the induction with the Perseus trial showing as a median, expected, I would say, median PFS of 17 years, do we really need something else? Or is there something else? We have the Majestic 5 utilizing teclistamab in the upfront line, 3 arms, arm A, arm A1, arm B. Arm A, teclistamab weekly plus dara-len. Arm A1 is teclistamab every 4 weeks, dara-len. And arm B, teclistamab Q4 weekly, PRD. Small number of patients, not yet final, but you can see how many 100 here? Everything is 100. 100 MRD negativity after 3 months. 100 MRD negativity after 6 months. MRD negativity, not CR. This is MRD negativity. Is this a future? Probably. Elranatamab is also being tested with dara-len, first line. Monumental 2, there is an arm which treats frontline patients with talquetamab dara-len. And this is replacing transplant with CAR-T frontline. Dara-BRD induction followed by transplant versus Dara-BRD induction followed by cell-to-cell with LEN maintenance. So there are things to come. We don't know where we're heading, but my own view in transplant-eligible patients, the question that we will ask in the near future is whether these patients, when they come up with myeloma, whether they are CAR-T eligible or not. So CAR-T eligible, go for CAR-T, and CAR-T ineligible, go for treatment with bispecific molecules. Transplant ineligible, we have 6 minutes to go over treatment of transplant ineligible patients. So again, back to the history. Melphalan and prednisone used to be our cornerstone treatment in these patients, MP. Then thalidomide came in, bortezomib came in, and we had the triplet MPT and VMP as our different choices. Again, some people remember those days. So until the first trial came out, the first trial is, Terifacone used to brag about this as the largest trial ever conducted in multiple myeloma, but there was some other trials which was larger after this. Anyway, so he randomized these patients to RD, 18 months, RD continuous, or MPT. And this trial has killed MPT. Both arms, you can see here the winning arm was RD continuous. So we have used RD continuous in these patients for years. Until Terifacone, as the PI of the Maya trial, challenged himself, DARA RD versus RD. And he was able to show better outcome in terms of progression-free survival with the DARA RD versus RD, with a median PFS of about 61 months. It's the best ever achieved PFS in transplant ineligible patients. The IFM study is recent, was conducted mainly to compare Daralin versus RD, omitting dexamethasone in the Daralin arm, mainly for frail patients. These are the patient characteristics. You can see better progression-free survival and even overall survival in patients who were given Daralin versus RD. Again, if 3 drugs are good, can we use 4 drugs in transplant ineligible patients? Let's see. The EMROSE trial was recently again published that has a complex protocol, but combining isatuximab with VRD in transplant ineligible patients in this complex schedule, lots of dexamethasone here. I'll not go over this in details, but definitely ISA-VRD is better than VRD. So VRD was given the same way the SWOG 777 trial has been conducted, 8 cycles of VRD followed by RD. And even here, the PFS of VRD was better than what it was in the SWOG trial. 2 different eras, but the median PFS here is a VRD. You remember the Maya trial, the best we had, which is DARA RD, 61 months, median PFS. But here, at 60 months, still 63.2% are progression-free, meaning the median PFS is going to be definitely better than DARA RD.
3 minutes.
3 minutes. Benefit is just a change in the protocol, which is more palatable, I would say, omitting some of the drugs down the way. But again, ISA-VRD compared to ISA-RD and showing better outcome in the ISA-VRD arm. How about DARA in the CFIUS trial? Again, VRD was compared, similar to the SWOG again, similar to the EMROSE, but with a different schedule, utilizing daratumumab as an anti-CD38, DARA-VRD versus VRD, showing definitely better PFS and better MRD negativity, as you can see here. Back to our guidelines, Saudi Myeloma Working Group. I still have 2 minutes. So here, in the transplant ineligible patients, we have stratified the patients based on fitness, whether fit, frail, or very frail. So fit, you can, the quadruplets in the transplant ineligible, when you think, these are not suitable for everybody. quadruplets are probably in those who are maybe not transplant eligible, mostly because of age only, otherwise they are fit. Probably those patients you can consider for a quadruplet. And those who deny transplant, who are basically transplant eligible, but deny transplant for their own reasons, those can be considered for a quadruplet. And here we put them as fit induction with an anti-CD38 plus VRD, which is the quadruplet. For frail patients, we kept DARA-RD or ESA-RD as the best choice. And for very frail patients, you can utilize a doublet, whether VD, RD, or DARA-R based on the IFM trial that I have just shown. So this is the last slide. Most patients should receive an anti-CD38 in induction, whether transplant eligible or not eligible. Quadruplets is superior to triplets therapy for induction and for fit ineligible transplant ineligible patients. So we have to use our best myeloma upfront, myeloma treatment upfront. Transplant remains standard of care for transplant eligible patients, and exciting approaches are coming up. Thank you very much.
Thank you, Dr. Ayman, for this elegant presentation. So it's my pleasure now to present the next speaker, Dr. Abdullah Saleh. Dr. Abdullah Sulaiman Saleh is a distinguished expert in adult hematology. He served as acting section head and consulted at KMC, Riyadh, Saudi Arabia, and holds a position of assistant professor at King Saud bin Abdulaziz University and Health Science. For health science, specialized training from Mayo Clinic, including fellowship in CAR T cells and dysproteinemia. Today, Dr. Saleh will share the valuable insight on CAR T cell versus bispecific antibodies in myeloma. Please join me in welcoming Dr. Saleh on the stage. Go ahead.
Thank you very much. I would like to thank everyone. Thank you for this invite. I will talk about what's hot now in terms of CAR T versus bispecific. So in my presentation, I will start with what we have for CAR T, what do we have for bispecifics. I'm going to share with you the updated results. Then I'm going to talk about the toxicities associated with this treatment. Then I'm going to answer the big question, which patient should you go with CAR T, which patient should you go with bispecific? So I always like to start my talk with myeloma with this slide. So we know that patients with the multiple myeloma who are relapsed, refractory, especially penta-refractory cases, the median PFS is actually less than 6 months, and the median overall survival is less than a year. So definitely we need some treatment for these patients. So in order for us to understand the process, I'm sure all of you are aware, so for the patients who are considered for CAR T, we start by leukapheresis, and there can be some challenges with leukapheresis, especially in patients who have advanced disease. When you collect the T cells and you send them, it will take around 6 to 8 weeks. So in that time, some patients will need some treatment, what we call bridging, which I will discuss. And then when the cells are back, you just give lymphodepletion, chemotherapy, and then you infuse the cells, and you have to manage these patients for toxicities. So the first CAR T is ide-cel. Ide-cel is a BCMA CAR T in the initial KarMMa trial, in which patients with triple exposed were included in this trial. You can see that the overall response rate was around 81%. However, despite these high response rates, the problem what we have with myeloma compared to lymphoma is that the durability of response is not there. So if you look at the median PFS here for the whole population was less than 10 months, and the median overall survival was around 20 months. So definitely patients respond, but the problem, they don't maintain their response. So another CAR T is cell-to-cell. So this differs than ide-cel in terms of the two single-domain antibodies targeting the BCMA. And in the initial CARTITUDE trial, where they included patients with relapsed and refractory disease, again, the overall response rate was high. It was reaching 98%. And these are the updated results for the PFS and the overall survival. You can see that in some group of these patients who are previously exposed to myeloma therapy, they were relapsed, refractory, they got the CAR T, you can see that the median overall survival is not reached. And some myeloma experts are talking about some cure for subgroup of these patients. However, we need longer-term data to decide and see if these patients are really cured. So I talked about patients who are relapsed refractory with many lines. So if you bring the ide-cel or the cilta-cel up front, are the responses and the durability of response differ? So this is the KarMMa-3 trial in which the ide-cel was used. And you can see here that the median PFS was slightly longer than the initial KarMMa trial. Here it's like 13.8 months compared to 8 months. It's very important to mention that the control arm was receiving mainly Dara-PD, Dara-VD, little bit of carfilzomib-based therapy, so that's not the usual what we do in patients with relapsed and refractory disease. However, despite the responses, the PFS was only for around 13 months. How about the cilta-cel? So if you bring the cilta-cel up in the CARTITUDE-4 trial, this is the updated analysis showing the median PFS. You can see that the median, at 30 months, around 60% of the patients are progression-free. Again, the competitor arm here was mainly Dara-PD, which is not usually what we use, and no patients were receiving carfilzomib-based therapy. So the updated overall survival is also shown here. You can see that at the 30 months, around 75% of the patients are still alive without relapse. So in terms of the side effects, I will discuss the CRS, the ICANS, and the other side effects in details, but here I want to highlight some key differences between the ide-cel and the cilta-cel. You can see that most of the grades of CRS we see with both treatments are mainly grade 1 and 2. Grade 3 and more are around 4 to 5%. What is also different between the two is that the time to CRS. So in the ide-cel, usually patients will start with the CRS early on, the first day. However, in the cilta-cel, usually it's delayed 6 to 7 days. The neurotoxicity, the ICANS, again, mostly grade 1 and 2. Grade 3 and 4 are around 2 to 3%. But what is unique to cilta-cel, if you look here, is the delayed neurotoxicity, which I will talk about in details in the next upcoming slides. So is there any data looking or comparing cilta-cel versus ide-cel? Of course, no prospective data will be there, but if you look at the retrospective analysis, this is data from more than 19 centers in the US, more than 600 patients. They tried to match patients in terms of baseline characteristics and treatment, and you can see that the cilta-cel PFS and the median overall survival was better with cilta-cel compared to ide-cel. So in our center, what are we doing? So we're using cilta-cel. Cilta-cel has been approved for patients with myeloma after failing first line of therapy. But of course, we're going to discuss the toxicities associated with this treatment. So which group of patients in our center we're considering to use cilta-cel after first relapse? So these patients who are failing quads, so you start Dara-VRd and they progress, or patients with high-risk features such as plasma cell leukemia, 17p, TP53 mutation patients, or a patient with upfront treatment, you're giving upfront quads transplant, and then they progress early, within a year or two post-transplants. So now shifting gears to bispecifics, so I'm going to talk about the approved ones, updated data. So first of all is teclistamab in the Majestic trial. Majestic 1, it's a bispecific, BCMA targeted, and you can see that almost all the bispecifics, they start with a step-up dose. You start with a small dose, you monitor the patient, and then you increase the dose until you reach the full dose. And the maximum dose here is 1.5 milligram per kg. Initially, we're doing weekly, but then we have also an option to space this up to every 2 weeks, especially in patients who achieve CR more than 6 months. I'm going also to share the Majestic 3 trials in which teclistamab was following the DARA schedule. So what are the responses? So we are seeing across the bispecifics, remember these patients heavily pre-treated, median lines of therapy is around 6. The overall response rate is 60%, and this is the updated progression-free survival, showing a median overall survival of around 12 months in the whole population. However, if you achieve CR, the median overall survival is not reached. The toxicity associated with the bispecifics, to be honest, what we faced mostly in practice is infections. So initially in the trials, they were not mandating IVIG for all patients. However, in our practice now, we're giving IVIG for all patients, even if they have normal IgG level. If you look here at the grade 3 and 4 infections, they were around 55%, and mostly died from COVID during the trial. CRS is not a big concern with the bispecifics. Mostly it's a grade 1 and 2, and grade 3 is less than 1%. So teclistamab in clinical trials, how about in real practice? So the overall response is similar to what we see in the trials. The median PFS is slightly lower, but this is explained by the more liberal criteria to include patients than in the clinical trials. But what is interesting here, if you look at the grade 3 and 4 infections, is decreased compared to the trial. It's around 30% or 25%. So this is, I believe, mainly because of the increased supportive management for these patients, including the use of IVIG. So in the magnetism trial in ranatamab, again, subcut, step-up dosing, fixed 12, 32, 76 milligrams. And then you can dose it every 2 weeks or every 4 weeks, depending on the response. We are seeing similar results in terms of the response, overall response rate of 60%, mostly VGPR and CR. And you look at the median PFS updated analysis is around 17 months, with a median overall survival 24 months. Now again, the concerns with the bispecific is infection. Grade 3 and 4 infections were around 40%, and no concerns in terms of CRS or ICANS, I mean grade 3 and 4. How about linvoseltamab in the Lincoln trial? Again, step-up dosing, the maximum dose is 200 milligrams. And then if you achieve VGPR, you can space it up to every 4 weeks. Less than VGPR, you can do every 2 weeks. Overall response rates, again, similar to 70%. This is the updated analysis showing median PFS not reached. The median overall survival is around 31 months. Now, toxicity, again, it's similar. We talked about BCMA bispecifics. So how about another target? So GPRC5D, which is talquetamab. And then in the monumental trial, again, step-up dosing, subcut, you start by 0.1, 0.6, and then you have the option between doing it weekly versus every 2 weeks. Overall response rates, again, is nearly equivalent to what we see with bispecific. However, this can also be used in patients who receive BCMA-targeted therapies, with the overall responses lower than the other patients, but this is explained because patients has received BCMA-targeted therapy. Now, what is unique about talquetamab in terms of the side effects is the GPRC5D location. So it's present in the skin and the oral mucosa, so patients can have skin rashes, they can have dysgeusia, they can have weight loss, and I'm going to mention these in details. So to summarize the bispecifics, overall response rate is around 60%. CRS and ICANS are acceptable. The major concern is infection. And GPRC5D bispecifics have a unique toxicity in terms of the skin and the dysgeusia. So now let's talk about the side effects. We talked about the response rates and how effective this treatment is, but let's now talk about the side effects and how to manage them. So the first one is the CRS, cytokine release syndrome, in which there is hyperstimulation of the immune system. So cytokine are being released, IL-1, IL-6. Patients will have symptoms ranging from grade 1 CRS with fever only. Then you can have fever with hypotension responding to fluids. This is grade 2, or low-grade hypoxia. Then if you have hypotension that is persistent, requiring a pressor, this is grade 3, or hypoxia requiring high flow oxygen. And then, of course, grade 4, you're requiring multiple pressors, you're on mechanical ventilation. So what is important here is actually early recognition. So when you recognize a patient with a CRS, we talked about the percentages, you have to support them. So you start antibiotics just in case there is an infection. For a grade 1 CRS, you give paracetamol or something to calm the fever. In my practice, if the patient is still having fever even after 24 to 48 hours, especially with high burden disease, I actually consider tocilizumab early. So I give tocilizumab and then not responding dexamethasone. And second line include the use of anakinra and other interleukin inhibitors. Now, I wanted to mention that there is the OPTIC trial where actually tocilizumab was used as a prophylaxis before the first teclistamab dose, and it's been shown that it's very effective. I have to admit that in my practice, I consider it, especially in elderly patients with high burden disease. So it decreases the risk of CRS and it does not affect the response rates. So now shifting gears to neurotoxicity. So with the immunotherapy that we have the usual ICANS toxicity that we see with lymphoma. However, we also have the delayed neurotoxicity, which is unique or more common with cilta-cel. So the neurotoxicity, again, is similar pathophysiology. However, there is a blood-brain barrier effect. So patients will have symptoms ranging from mild confusion, inability to name objects, which can progress to severe symptoms, coma with brain edema. So it's very important to mention that mostly it's grade 1 and 2. Grade 3 and more is less than 5% across the treatments that we have. Now, how would you manage them? So we start with the supportive management. You involve your colleagues from neurology. You increase the dose of the prophylactic antiepileptics if they are on. You do imaging to make sure there's nothing else going on. And then, of course, you use the steroids, mainly dexamethasone. And then if the patient is not responding, you can consider the interleukin inhibitors such as anakinra. Now, the delayed neurotoxicity. So this is more interesting, more difficult to be managed. So these patients, usually with cilta-cel, when you give the treatment, it can happen, the median time is around 3 to 4 weeks after you give the therapy. The most common is actually cranial nerve palsies, mainly the 7th nerve. Patients also can have Parkinson-like features. What do you do? So you rule out other causes and you start treatment with dexamethasone, steroids, and IVIG. I have to say that the cranial nerve palsies, the responses are better. However, the Parkinsonism, usually the treatment is not effective and most patients will not benefit from treatment. I have to mention here that the GPRC5D CAR-Ts that are ongoing, we are seeing some signal of also cerebellar toxicity in the form of ataxia, dizziness, because of the presence of this in the cerebellum. Now, did this change the neurotoxicity when we brought up the cilta-cel early? So I have to mention that, yes, the Parkinsonism rate has decreased to around less than 1%. However, the cranial nerve palsies and the other toxicities are still there. We talked about the management. So another important thing to recognize as a side effect is the immune effector cell hemophagocytosis. In fact, we just had a patient who was admitted in our hospital with very bad myeloma who had full-blown disease. We started this patient with cilta-cel. The patient was doing fine until day 6, 7, started to have fever, and then in the next day, very bad transaminitis, ALTs, ASTs in the 800s, bilirubin were going up, DIC, triglyceride very high. So we had to act fast. We started dexamethasone and anakinra, because if this storm passes by, it will be very difficult to control and the mortality rate is high. So what is important here is actually early recognition. So any patient with CRS that is not being controlled or very rapid CRS, the hemophagocytosis should be kept in mind. So the management, we talked about steroids, we talked about actually in our patient we had to give steroids, and then we also used anakinra. And in patients who are not responding, you should be thinking about the others, such as imalimumab, for example, or ruxolitinib. So GPRC5D, we talked about the unique toxicities. So the skin lesions in the form of skin rash, sometimes the skin nodules, sometimes you can have it bad to the point where the patient is having desquamation in the skin. I have to mention also nail toxicity. Some patients will have difficulties, very weak nails that are sloughing off from the skin. So what do you do here? You can use emollient for the skin. Topical steroids can be effective. And then most patients, I have to say, will require spacing up the dose or decreasing the dose to control this. So infections, very well-known complications from both bispecifics and CAR-T in the form of viral infections, bacterial infections, fungal infections. Those are some supportive management that is required for these patients include the antiviral prophylaxis with acyclovir, for example. The bacterial prophylaxis usually we do for patients with prolonged neutropenia or if they're still requiring steroids. We do PGP prophylaxis for all patients. And then IVIG is very important, as we mentioned. And patients after the first month, if they're still neutropenic, we can consider GCSF. Now, I mentioned this before, the IVIG for the bispecifics, the rates of infection, grade 3 and 4 infections were very high, but after the use of IVIG, even if the immunoglobulin levels are normal, in the bispecifics, the rate of infections have decreased. You know, in practice, when we use teclistamab, we see the immunoglobulins, in fact, undetectable, meaning that there are no B cells, and that's why many patients are having infections. So how about cytopenias? Cytopenias are common after the CAR-Ts. If you look across the trials, the KARMA trial and the CARTITUDE trials, the cytopenias were still there in some patients after the first month. So what do we do? Supportive management. We do GCSF. We use TPO agonist. And then I have to say there are some evidence to use a stem cell boost for patients who actually are not responding with the traditional measures. So malignancy is very important to talk about because, you know, these treatments are effective. How about what are the risks of malignancies? If you look across the KARMA trials and the CARTITUDE trials, it can happen up to 10%. For the solid cancers, it can be invasive or non-invasive. For the hematological malignancies, it's in the form of MDS, AML, and there are some cases of T-cell lymphoma as well. So now let's talk about bridging. You know, let's say that you have a patient for CAR-T and you collected the cells. Is there any role for bridging? If you look at the CARTITUDE-4 trial, 15% of the patients actually progressed even with bridging and were not able to get the CAR-T. And that explains the drop in the curve initially. So bridging is very important. In fact, in the CARTITUDE-4 trials, most patients received bridging, and if you respond to bridging, the median progression-free survival is better. How about in the real world? So there are some data from cell to cell showing that most patients, in fact, require bridging because their myeloma is aggressive, they need some bridging to control the disease, and if you require bridging, the PFS could be lower. However, if you receive bridging and your disease is stable, the CAR-Ts can be effective. IDCL, the patients who were receiving bridging had inferior outcome, and this was actually more pronounced than cell-to-cell, maybe because of the efficacy of the CAR-T. And when we talk about bridging, why we do it? In fact, the main important thing is actually to make your patient still eligible and able to get the CAR-T. So it controls the disease, it can lead to better outcomes, especially if there is a deep response, and also it will decrease the toxicity that you can get from treatment. So let's say that you agree that this patient requires bridging. What bridging would you use? It depends on many things. So it depends on the patient's comorbidities. For example, a patient with heart disease, you might not consider carfilzomib. You would look at the previous lines of therapy. Is there any target that you can use? For example, venetoclax and 1114. And it depends on how aggressive is the disease. So I tried to look, is there any data for bispecifics to be used as bridging before the CAR-T? And this is the largest retrospective review looking at teclistamab and talquetamab, 10 patients only, in which they used actually the bispecific before the CAR-T. You can see that in the upper part is teclistamab, in the lower part talquetamab. You know, and when teclistamab was used, there was a lot of out of spec. This is expected because it's the same target, BCMA. However, when the patient received the CAR-T, all of them responded. And the PFS was not difference between the patient who received bispecific versus others. And the only thing that was noticed is that decreased BCMA expression on the plasma cells. So if you have another target, why not use GPRC5D bispecific as bridging? And I think this was presented in ASH, showing in fact in 63 patients the overall response rates and the duration of response is good when talquetamab was used as bridging before CAR-T. Now the last part of my lecture is to talk about which to choose, the CAR-T or the bispecific, which can be very difficult. I will try to make it simple for you. So we have now so many strategies and we have so many ongoing clinical trials. So the first question, Is your patient on fire or not? You know, multiple myeloma patients are not the same. You have a patient with plasma cell leukemia, extramedullary disease, very high LDH with cytopenias. This patient will not wait for the CAR T to be manufactured and come. So these patients, you have to act fast. So most likely they will use the bispecific. This is compared to a patient who's actually having, you know, biochemical relapse. They're at high risk, but only biochemical relapse. You can collect them, give them some treatment, waiting for the CAR T to come, and then you can infuse the patient. The other question is the patient fit or frail? You know, you have an elderly patient, 80 plus, who has comorbidities, they are progressing, you know that they will not tolerate the CAR T, then you can consider bispecifics. I believe there's no age limit for the bispecifics. I had a patient, 85 years old, received the bispecific, and they're doing well.
3 minutes, please.
Okay. So the other question, does the patient want the big hammer? So some patients will prefer treatment, short time, give the treatment, deal with the toxicities, and then without any further treatment. However, I have to mention that some patients with cilta-cel can develop cytopenias, and these can be prolonged cytopenias. They will still require to come and get supportive management. So it's not always true that the CAR T is one-time treatment. So the other important thing to answer, do you think that this patient will require treatment down the road after the CAR T, for example? So why is this important? Because based on retrospective data, the effect of CAR T after bispecific, the responses are way less, and the PFS and the overall survival are less. So for example, if you're using cilta-cel after bispecific, this the overall, from real world data, the overall response rate drops. And this is more noticeable if the bispecific has been used within 6 months of the CAR T. You can see here the overall response rate, 94%, from after more than 6 months away from the bispecific, compared to 54%. If you have prior exposure, of course, the outcomes are less. And you can see on the curve here on the right side, the patients who received it within 6 months, the PFS is actually less than 3 months. So we talked about cilta-cel. How about any data for ide-cel? Again, the same thing. If you give ide-cel after BCMA targeted therapy, the response rates are less. Here, more noticeable the effect on the PFS and the overall survival. However, if you look at the other way around, so can you do bispecific after CAR T? You can look here at the Majestic trial, actually. Patients who received BCMA targeted therapy, yes, the responses are less, but they are not decreased like the one we saw with the CAR T. Teclistamab post-BCMA therapy, this is updated analysis showing a median overall survival of 15 months if you're using teclistamab after the CAR T. And this also goes with the elranatamab in patients who respond after the CAR T. The median for any prior BCMA therapies are actually 17 months. So cost is very important to talk about. So is there any comparisons between the two? Actually, the cost of the bispecific in 1 year is nearly equivalent to the cost of the CAR T. I'm talking here about the product only, without the admission to the hospitals and the other things. So although the bispecifics are showing response and promise, the cost is a concern. Is there any data regarding the cost economic? So this is data presented in ASH, actually showing that cilta-cel is cost effective. Now, just 2 slides about where are we going. So the Majestic 3, this is the trial, was late-breaking abstract last ASH. Patients who received 1 to 3 lines of therapy, only PI or IMiDs, anti-CD38 antibodies were not included, were randomized between Tec-Dara versus Dara-PD. Most patients received Dara-PD. And you can see that the schedule for the teclistamab was following the Dara, so less frequent scheduling. And the overall response rates are impressive, and what is more impressive are the overall survival and the PFS. So 2 slides about the CARTITUDE. Dr. Hijazi mentioned the CARTITUDE-5, which is the VRD versus CAR-T. And then also we have the more interesting, which is the CARTITUDE-6, Dara-VRD transplant versus Dara-VRD and cilta-cel. So with this, I conclude. So immunotherapy is rapidly evolving. You know, the major challenges which patients you should choose for CAR-T versus bispecific. You have to keep in mind the side effects and remember that the supportive management is invaluable. Thank you very much.
Very interesting talk. Thank you very much. It's a pleasure to present Dr. Ghazi Al-Utaibi. Dr. Ghazi is a Canadian-American board-certified internal medicine and hematologist. He is a Mayo Clinic trained specialist in multiple myeloma, amyloidosis, and dysproteinemias. As a PhD holder in health outcome research, his research focuses on epidemiological studies of monoclonal gammopathy in Saudi Arabia. Please welcome Dr. Ghazi.
Assalamu alaikum. Thank you very much for the invitation. So this is not the slide. This is the slide for the subsequent talk. This slide is the MRD. So thank you to the organizing committee, and it's a pleasure to present to you today the role of MRD negativity in myeloma. And it's very important to know that there's actually a lot of therapeutics that have changed in the last 15 years in myeloma, but the response assessment has also been evolving in the last 5 years. So now you all remember the CR, VGPR, and stringent CR. So most of these have changed quite a bit. So now we've got actually MRD-based response assessment that has to be the endpoint that we should monitor our patients clinically on. And these are my disclosures. The goal of therapy in myeloma is basically to reduce the treatment burden, to reduce the symptoms of the patients, but ultimately, I think we're trying also to prolong overall survival, to make it a chronic disease that can be, can allow for people to live a normal life despite being on therapy. And maybe at some point we can even stop therapy, and I'll show you some data on this. So is all CR the same? I mean, we can clearly see from all the maintenance trial that people who are with the old label of CR, if they are not MRD negative, being biochemically negative doesn't actually reflect, a very long PFS. And all the trial done by, McCarthy and his team, where they looked at, maintenance as a tool of therapy that prolongs survival, those who are actually MRD positive, they actually did not do as good as those who are MRD negative. So MRD negativity is actually the goal, even in those who are actually on maintenance therapy. So what MRD testing do you do? I think MRD testing will become very challenging because, soon and soon we'll start to adopt this in our clinical practice. And I think maybe in the next 3 years, it will be actually a mandatory tool for response assessment. And in the market, we ideally should have a next generation flow cytometry, which is actually not very expensive. It costs about, $250. It doesn't take a long time. You don't actually need a baseline sample. And the only caveat here is you have to have a fresh sample to the lab, and it's been actually Euroflow validated. The next generation sequencing is actually a much better yield. It actually requires a smaller number of cells, and that's the problem with the flow. The flow in myeloma for MRD assessment requires actually a lot of plasma cells. So ultimately, you'll actually end up sometimes collecting 40 cc of bone marrow to send for an MRD if you want to run it by flow. So NGS is probably very manageable. The problem is that you need actually a benchmark initial testing. You don't actually have to have a fresh sample. If you have somebody who's come with a patchy bone marrow, so this might actually affect this, and it's adaptive validated. What the myeloma field have done over the last 10 years, from 2010, is they continued to combine IMiDs and PIs and play around them for the last 10 years, and then maybe 5 years ago we started to add anti-CD38, and you can see that with every change in therapy the MRD continues to improve, but the best thing we have achieved is like 50% MRD negativity, and we're not talking about sustained MRD. We're only talking about MRD at one point, and we're also not talking about high sensitivity MRD. So most of these things are actually 10 to the minus 5. But this has changed significantly over the last 2 years when we started to add bispecifics to the initial therapy. And these numbers have not only stayed less than 50, but they've also doubled to close to 100%. And I'll show you the data that if you actually look at the Majestic 5, so the Majestic 5 is actually an idea to incorporate anti-BCMA therapy initially in the studies. And with all best available therapies in the past, we have never achieved more than 50% MRD negativity, 10 to the 5. Now with next generation flow, 10 to the 6, in all comers at 6 months of maintenance, everybody's MRD negativity rate or measurable residual disease negativity rate is 100%. And we've known, from the the collective data of so many clinical trials that the deeper the depth of response, the better the PFS and the better the overall survival. The PFS correlates, very well. This is from the very famous, Nikhil Munshi's meta-analysis, where he actually looked at individual patients' data where, the MRD negative patients, whether they are transplant ineligible, eligible, or even relapse refractory, those who are MRD negative, they actually stay as longer with disease control than those who are not. Same thing have been reflected on the overall survival in both the transplant eligible and also the relapse refractory population. So we know that MRD negativity can be a very beneficial surrogate endpoints. And in the world of myeloma, you really don't have to wait, 10, 15 years to allow for the data to mature. You can actually utilize MRD negativity as a surrogate endpoint. So now this is something we've clearly outlined in the previous slides, that if somebody is classically in CR, if they are actually not a CR MRD negative, they can be a CR MRD positive, and they actually behave as bad as VGPR and PR. So only the true MRD negativity is actually what actually does quite okay. But those who are actually even CR but they remain MRD positive, their outcome is not as good, and this has been replicated in so many European studies. And because of this reason, the combination of these trials have created this data. The FDA now consider MRD negativity as a very valid endpoint in phase 3 clinical trials, and it actually leads to drug approval. But we have to know a couple of things. Number one, not all assays are the same, and MRD by flow, or is it MRD by NGS? What depth of response? So 10 to the 4 is very unacceptable in myeloma. The least thing you can do is 10 to the minus 5. 10 to the minus 6 is ideal, and the Chicago group is actually even doing 10 to the minus 7 next generation flow. But I mean, the problem is you'll end up with so many patients, not providing adequate sample, for testing. So older assays are actually not valid. When you actually look at older studies, clearly you have to see, what kind of MRD assay they used. And then sustained MRD negativity in myeloma is very important. And there is a recent publication last year from the Demobulus group where those who achieved MRD negativity for 3 years, they managed to stop their maintenance therapy, and 86% of those people remained off therapy without disease progression for another 3 years. So MRD sustainability over a long period of time is probably a better predictor than a one-time MRD negativity. So now, the techniques we'll talk about, but this is the updated IMWG consensus, criteria. It has been actually established on the basis of the 2016 initial data, but the, remains, sustained MRD, flow MRD negative, or NGS MRD negativity, and to add, to the predictability of this testing, PET scan plus MRD negativity is probably even a better tool on those patients who are actually MRD negative, because you can see a very small number of patients will have a bone marrow that's clean of myeloma, but they'll end up with some relapse in the form of extramedullary disease. So these are the testing, and we've covered the imaging. So again, all MRD testing is better than nothing, but most of these things are actually not alike. You really have to look at the details. And one of the important things is, which patients you should actually send their samples for MRD testing. Do you send for everybody after therapy, or do you only send those who achieved VGPR, or you send those who actually had a CR biochemically? So there's actually quite a bit of discordance, mostly because the M protein, some of the M proteins, mostly, IgG, can actually last for a couple of months before it actually clears from the body. So those people will remain, immune fixation positive. But if you actually look at their bone marrow, they're actually very MRD negative. So you cannot measure any residual disease. In addition to this, the caveat of using a monoclonal antibody that is basically an IgG-based molecule, so this will give you a positive immune fixation. So most of the studies now, they include anybody who's above VGPR. So more than VGPR, you actually go for MRD testing to look for residual disease. And these are the techniques that have been utilized in some of these studies. The commonest one is next generation flow, which is the one before the end. But the multicolored flow or our usual flow it can be used reasonably. You can actually also do PCR testing, so looking at the VDJ heavy chain analysis. NGS is a great idea, and the poor man's test is PET scan. If you cannot do an MRD, then maybe end of consolidation / transplant. PET scan can give you a better idea, especially if they are MRD negative, if they are NCR with negative immune fixation. So what do you expect in 2025, 2026 with MRD negativity rates? So this is the data I showed you in the past. So in those who are transplant eligible, the best MRD you get with time is 20% in the past. This has actually improved, with the ISKIA and HD7 to 40s, and then maybe now with the CFIUS and we're reaching 65. Sustained MRD negativity remains less than 50%. The addition of anti-CD38 have added about 20-30% MRD negativity rate. So in the non-eligible, same thing applies. With the increase in therapeutics, we've managed to increase the MRD negativity rate by at least 50%. So it goes from 9% in the RD to 30%. But these numbers, over time, it actually improves quite a bit. The Majestic 5 is probably a treatment or a landscape-changing therapy. So in that study, I've given people teclistamab with DR versus teclistamab with DR over 4 weeks, or teclistamab with VRD. And they transplanted everybody, and they gave them maintenance TECDAR. And again, this study, not because it's an innovative therapy, but it also have actually changed the treatment outcome completely. And I have to emphasize that really the best MRD negativity we've seen, the MRD negativity with the Maya gives 60 months of PFS. The MRD negativity is only 30%. And, people have been celebrating the Maya trial for a long time. So the Majestic 5, it doesn't report the 30%. It actually reports 100% MRD negativity at end of consolidation. So I think, this will probably allow for more studies to incorporate, stopping therapy in patients with myeloma. So the CARTITUDE has been covered very well, but, the CARTITUDE, looked at MRD rates in so many ways, but the 10 to the 6, the numbers are not very impressive. You're only looking at 57% of the patients reaching an MRD negativity of 10 to the minus 6. So should we consolidate based on MRD? I mean, we've been talking about MRD all day long. Does it affect what we do? I think so. If you look at the MIDAS, so the MIDAS have done something, quite interesting. So they ignored all risk cytogenetics. They decided that anybody who gets 6 cycles of induction, they will be randomized based on their MRD. So their MRD positive, those are the high-risk people. If they're MRD negative, those are actually the not high-risk people. So the high-risk people, everybody gets a transplant. The question is, it 1 or 2 transplants? If they're MRD negative after induction, you go no transplant or you go for transplant. And what they have actually reported in their first cohort, so arm A and B outcomes that have been reported in New England a couple of months ago, that if you're MRD negative post-induction, you don't need a transplant. So your MRD negativity rate is 86%, 84%. So I think that's very important. I think, the MRD outcome will probably change what sort of consolidation therapy you do. But again, these are prelim data, difficult to make a solid conclusion from these. Do you stop maintenance based on risk? This is the master trial. It's a very difficult protocol to give, honestly. So it's a data KRD for million cycles, and then everybody gets a transplant, and then after the transplant, they do something called MRD sure. So MRD sure is not sustained MRD. Sustained MRD has to be over 1 year. MRD sure is every 4 months they repeat the MRD testing. So it's very, very difficult to do on patients. And they give either 0 or 4 or 8 consolidation cycles. Anybody who achieves 2 MRD negativity, they call them MRD sure negative, and they stop therapy. So in that study, although the protocol is very complicated, but nearly any patients who had MRD sure negativity, they did not actually relapse. So they continue to do very well for a long period of time. And who are those people? Only those who had MRD sure and they had 0 or 1 high risk had genetics. So they did not, those who are high risk disease, doesn't matter. The disease after 2 MRD shores can actually come back. So in those who are 0 or 1 high risk, you can stop therapy if they're MRD sure, but not everybody. Again, this is a phase 2 clinical study. And again, you see the 0 high risk group, they did actually quite okay. ISIS stage 1 or 2, they did actually quite okay, but not the high risk patients. So high risk disease can respond, but they come back. CAR T, the problem with MRD testing post CAR T is, the bone marrow can be hypocellular in so many patients. But we've learned that, those who achieve MRD negativity and they had a decent bone marrow, it's actually a good predictor of a very long PFS if they're MRD negative 1 month after CAR T. But again, it's not a curable therapy. And it's important to look at sustained MRD, of course. Doesn't matter if the MRD is after CAR T or T-cell engagers. The answer is no. It really doesn't matter. So those who are MRD negative, they do as good as those, whether or not, they're CAR T versus bispecifics. So if somebody is MRD negative and they become MRD positive, do you change therapy or do you stay the same? The diagnostic or the response assessment by the International Myeloma Working Group have reported that those who had an MRD resurgence, they're considered patient relapse, and you should actually change therapy. Do we do that all the time? I guess in theory, I don't think, if we have the utility, I wouldn't feel comfortable jumping on treating somebody just because they became MRD positive. I'll probably, wait a tiny bit, to see how the disease biology, behaves. But looking at the Casubia data, this is a data presented by Saad Osmani in the last IMS. So those on maintenance, anybody who stayed MRD positive, after 1 year, they become actually, they can actually go into MRD negativity, but their disease progression can be faster than those who lost MRD, than those who are initially MRD negative from the beginning. But how long does it take? Usually if somebody is MRD negative and then they had a disease resurgence in the form of measurable disease positivity. So it depends on what kind of therapy they received. So in the master, it took them 9 months, between MRD positivity until they developed clinical progression. In the Forte, which had a very long consolidation, it took them almost 2 years and in the Ssbmt trial, 39 months between MRD positive. You've got time to probably monitor those patients. The differences are mostly due to what kind of MRD testing they have done. So is it beneficial to treat based on MRD resurgence? I think we can tackle this question from 2 ends. Number one is, if you look at the Predator study, it's a very small study published or presented in last EHA. We don't have the full abstract yet, but in those who had they stopped their maintenance therapy when they became MRD, those who had MRD resurgence, they gave them daratumumab, and they did actually much better than those who continued on observation. I guess, it makes clinical sense, but is this the right treatment, or should you treat them as a clinical progression and you move on to the next line of therapy? We don't know. The other way is, if you look at somebody post-induction and you transplanted them, in the Origa trial, for example, those who were actually remained MRD positive, they added on a treatment. So instead of giving them single agent maintenance, they gave them doublets, and their outcome have been actually much better than those who stayed without doublet therapy. So the PFS and the overall survival is actually much longer in the doublets arm. So in summary, I think with quad and transplant doublets, no transplant, sustained MRD negativity rate are actually increasing to the 60s instead of what we've seen in the past. Sustained MRD negativity is actually the way to go when it comes and when it comes to using it as a surrogate endpoint. One-time testing is not very important. Sustained MRD more than 2 years is better. With 3 years, it's even much better. So this is something that can be used as prognostic. We need to standardize these things. We need to actually think about implementing this very urgently in our labs, and unclear what best timing with the first MRD. Do you do it after induction, after transplant, after consolidation, after 1 year of maintenance? You probably don't know. And with that, I conclude. Thank you very much.
Thank you, Dr. Ghazi, for this wonderful lecture. Now, the last talk will be by Dr. Majid Al-Ahmadi. It's my pleasure to introduce Dr. Majid Al-Ahmadi. He's a respected consultant hematologist at Princess Noura Center, Cancer Center. He completed the clinical fellowship in lymphoma and myeloma at the Princess Margaret Center, Toronto, Canada, and he received multiple myeloma other board certificate. He's assistant professor at King Saud bin Abdulaziz University for Health Science and Hematology Fellowship Program Director at King Abdulaziz Medical City, Jeddah. Dr. Ahmadi will share insight on plasma cell leukemia, update on therapy standard of care. Floor is yours.
Okay. Bismillahirrahmanirrahim. Assalamu alaikum and good afternoon, everyone. And thanks for the introduction. Thanks for the Ssbmt for the invitation and for choosing this topic, which rarely get presented in most of the meetings. So that's a good choice. So it's a good choice for them, but it was a tough task for me because you've seen all of the very nice clinical trial and well done and phase 3 and all of the fancy data. When it comes to plasma cell leukemia, things are very different. So I had to, to collect all the pieces together, try to stitch them, and I was trying to get with the best conclusion that I can come out with. So apologize for that because there is a rarity of the data anyway. So I will start my presentation with one of my patients just to know how tough these patients are. So this is a 39-year-old gentleman. And always, tough cases, when do they come? They come on the weekend. So I remember that weekend when this patient came to me, and that was in 2020. So he came with WBC of 170, landed in ER, very cytopenic with single-digit platelets and hemoglobin of 5, and very sick, and and he had a renal impairment, so he was admitted to the ICU, and the blood film showed many circulating plasma cells that confirmed by flow they were expressing CD27, 38, 56, and 138. He had a very high kappa lambda ratio. So it was, we did not need to do a bone marrow on him. We did all the testing on the peripheral blood. So the fish was actually triple hit. So he had all the bad markers, so 17p, 1q, and 1p deletion. So he was started on pulse dex with some response, and then we started him on the chemo. I remember even in the ICU, so he started on VRD PACE. He actually, after 2 cycles, he achieved a CR actually with disappearance of the plasma cells and even from the peripheral blood and the bone marrow. So it was an excellent response. We collected the stem cells with cyclo-G-CSF. In the meantime, we did HLA typing, and he had a full match sibling. So he went for auto transplant with melphalan 200, and then Rec Allo from his sister, 10 out of 10 match, and then we put him on double maintenance with lenalidomide, bortezomib. He developed actually grade 2 GVHD of the skin and the liver. So I was monitoring him, by, annually with imaging and with the free light chains, because he's a free light chain secretor. And then he came with the right upper quadrant abdominal pain, ultrasound, and then CT scan showed a very large 10 by 10 centimeter mass in the liver. So, and surprisingly, that was not associated with any increase in the free light chain. So it was like so we did, I was, thinking that it could be another malignancy, but we took a biopsy, and it actually confirmed plasma cell neoplasm. And the bone marrow was done and was negative. So it was completely an extramedullary disease with non-secretory. So we start him on ESA-KD. There was slight decrease in the size of the mass, but in the meantime, he developed leg swelling, and we did pan-CT, and it showed actually multiple deposits in the muscles of the thigh all over. A biopsy was taken, and it's actually also plasma cell neoplasm. So unfortunately, progressing, and clinically he got very ill right away with sepsis and renal failure, and unfortunately he passed away. They're just to show you how nightmare these cases are, and despite how much aggressive therapy this patient has received. So now, in terms of definition, so the plasma cell leukemia has evolved in terms of the definition. The older definition, I remember when I was in medical school and as a trainee in the beginning of my training, so we learned that plasma cell leukemia is basically if the plasma cell represent more than 20% of the circulating WBCs, or an absolute number more than 2 million. But that has changed, and I will tell you why. So now, at this moment, the definition of plasma cell leukemia is more than or equal to 5%, and that's done by morphology. Would that be good enough? Now, I see some projections. So shall we use a lower threshold? And is morphology good enough to diagnose plasma cell leukemia? These are still an open questions. So the definition has changed based on the IMWG consensus. So basically, they looked at two big registry of myeloma patients, and they actually classify the patients based on the circulating plasma cells from 0, 1 to 4, 5 to 20, or more than 20. And what they found that there is actually a missing slide. Actually, yeah, so there was, there is actually a miss, but basically what they found that the overall survival of the patients, once their plasma cells more than 5% goes badly low, and that defined that 5% should be a new threshold for definition of plasma cell leukemia. But the other question is 5% good enough? And is peripheral blood morphology is enough? Because morphology is an operator dependent, and you can have these plasma cells that it looks like maybe atypical lymphocyte and can easily be missed. So in this analysis, looking at 185 patients with newly diagnosed myeloma, all of them, they underwent multicolor flow cytometry, and they found that 3/4 of these patients, they had a positive flow cytometry, but of a low level. When they looked at the patient where the flow cytometry was 2% to 20%, that represent close from 10% of these patients. And what they found that once we reach to a 2% by flow cytometry, the PFS goes low. So you can see a difference of 10 months in PFS just with any plasma cells of more than 2%. And when they looked at the prognosis of these patients with 2% and compare it to the older definition, which is more than 20%, you can see that these two lines are identical, which means that maybe we should go lower to that. And now the question that I would ask you, so where to draw the line? 20%, 5%, or 2%? Actually, is there a line to start with? And it's actually very important here, because as we are looking at the lymphoma patients, when we are looking at the LDH, do we have a line? I think the circulating plasma cells should be dealt with it as a continuous variable than categorical. Like, I cannot say that this patient has a 4% plasma cells, they are good. This patient is 5% plasma cell leukemia and a bad prognosis. I think it should be a continuous variable rather than categorical. And that actually represents that. You can see on this analysis that, patients with 2%, they did better than 3%, but the 3% did better than the 4%, meaning that the more plasma cells you have, the worse prognosis. So my message that I always tell it to my trainees that do not forget to do a peripheral blood film on any newly diagnosed myeloma patients. It gets sometimes forgotten and can be easily get missed if you did not look for it. So now for plasma cell leukemia, so it's classified into either primary or secondary. Primary meaning it's a newly diagnosed patients, never received any treatment. So this is more common. It represents about 3/4 of the plasma cell leukemia, where secondary, it happened in patients with previous diagnosis of myeloma, previously treated. Which one has, so primary is more common, secondary has worse outcomes. Now we see more secondary, and part of that because of the improvement of the treatment of myeloma. So we can see more of a natural history. So before people with myeloma, they would die within 3 to 5 years. Now 10 years plus, so we see more secondary plasma cell leukemia. So in general, it's represent 2 to 4% of all newly diagnosed myeloma patients, but I think it's underdiagnosed, maybe part of it because we don't diagnose it right. Maybe we are not using the right technique. We are depending on morphology rather than flow, and it can be missed sometimes. In general, these patients, they tend to be younger than their comparators, myeloma patients. So in terms of their presentation, usually it presents with aggressive presentation. So usually they came with more cytopenias, renal failure, and it tend to be more of light chain gammopathy or light chain component. And usually these patients would present with the true extramedullary disease, the non-osseous, and that's related to the lack of adhesion molecules like CD56, LFA1, LFA3, and VL5. Lytic bone disease is less common, but it is not completely not known. And in terms of the diagnostic workups, as you can tell, these patients, they have a higher burden, so they have a higher LDH, higher beta-2 myoglobulin, and heavier bone marrow infiltrations. And in terms of the immunophenotyping, they can have a little bit of differences. So they have B cell markers on their plasma cells like CD20, 27, and 28, and 45. And they tend to have, as we expect, more poor cytogenetic abnormalities like 17p, 1q, and 1p, and usually they have more than one abnormality. So this is actually summarized the different mutations that we see with these patients. So we see more TP53, more biallelic TP53, and more KRAS. So this table, just to summarize what I said, and you can see that these patients, they are younger, they have a higher disease burden, higher cytogenetic abnormalities, and more extramedullary disease. So historically, we know that these patients, they do poorly, and their median PFS is something around 5 months. And if we are talking about overall survival, it's just about 1.5 years. So they don't do well, and their prognosis is more worsen if they are more elder, so more than 60 years, if the platelet counts are less than 100, and if the circulating plasma cells in the peripheral blood is more than 20%. So in terms of prognosis, the Chinese group, they looked at large number of plasma cell patients, and they tried to look at all of the different variables, and they found that the most important prognostic markers are age, LDH, and 17p. They came with a normogram, and based on that normogram, you can classify the patient into either lower risk. Both they are poor risk, but they can be lower risk or higher risk, and you can see that in the diagram in terms of the difference of their survival. So in terms of therapy, these patients, they came sick, so you have to be prompt in your therapy. You have to be aggressive, and you have to tend for deeper responses, VGPR or better. Important point for my colleagues from any non-transplant center, if you have a patient like that and you want to treat it in your center, consult the transplant center earlier, because we have to start the workup for transplant earlier. We have to do the HLA typing earlier. So because we don't have time to waste, we have to immediately take these patients for transplant. So unfortunately, as I mentioned to you, in terms of randomized clinical trial, there is sparsity in the data. Most of the recommendations are coming either from small, prospective or retrospective data, or from registration and data analysis. So the EMN, they have presented their treatment paradigm for plasma cell leukemia recently. And so for patients with primary plasma cell leukemia who are transplant eligible, their recommendation is to go with 4 cycles of quadruplet therapy, followed by double transplant, so either tandem O2O2 or at O2LO if the patient has a suitable donor. Then you have to go with consolidation with 2 cycles, then maintenance. So in these patients, treatment holidays should not be done. So you have to treat until disease progression. If the patient is transplant eligible and fit, also go with quadruplet continuous until disease progression. If they are non-fit, you can go with monoclonal antibody triplet, like either anti-CD38 with LEN, or bortezomib, or carfilzomib. So also earlier, this is, the treatment algorithm was published. And, what I want to point here that chemotherapy can be added to these patients, especially if you want to induce a faster response to just overcome the leukemic phase. So addition, something like cyclophosphamide or liposomal doxorubicin. But the novel therapies should be incorporated in the management of these patients. Why is that? So this is actually one of the few prospective trials done on myeloma patients from the IFM group. So they looked at 40 patients with newly diagnosed primary plasma cell leukemia, and they were treated with alternation between PAD and VCD. And if the patient responded, and their response definition was stable disease with circulating plasma cells less than 1%, they will go for O2 transplant, first transplant, and then based on donor availability, if the patient has a suitable donor, they will go for REC-ALLO. If no available donor, they will go with second O2 transplant, followed by maintenance. Based on their analysis, outcomes was not the best. We know that these patients, they do very poorly. VGPR or better was only in about 20% of the patients. So, it's just to see how difficult these patients are. But the good thing that with the incorporation of the bortezomib, there was an improvement in the PFS if we want to compare it with the historical data. I showed you that what was known about plasma cell leukemia, PFS is around 5 months. In this trial, PFS was 15 months, with the median overall survival was 36 months, meaning that incorporating novel agent did something with these patients. So the second question that I have was, is carfilzomib better than bortezomib? So the HOVON, the EMN group, they tried to look at that in the EMN 12 HOVON 129 trial. So they had 2 different cohort. The younger transplant eligible patients, they received KRD times 4 cycles, followed by tandem transplant, O2O2 or O2 REC-ALLO if the patient has a suitable donor, followed by 2 cycles of consolidation with KRD, followed by KR maintenance until disease progression. If the patient is transplant ineligible, they would get KRD times 8, then KR maintenance until disease progression. So the outcomes was actually, better than what we have seen in the IFM trial. So the VGPR or better was detected in about 3/4 of these patients, regardless if they are transplant eligible or transplant ineligible. And that was translated also in, improvement in the PFS. So PFS around 15, more than 15 months in the transplant eligible, and about 14 months in the transplant ineligible, with the overall survival around 3 years. What about incorporating chemotherapy? So lymphoma-like regimen, like VDD-based, VRD-based, KRD-based, hyper-CVAT. So to tell you the truth, no one can say that these regimens are better than the quadruplet. Why? Because most of the data in the literature is actually extrapolation from very old myeloma trial. So there is no direct comparison between quadruplet versus lymphoma-like protocols. And what's more than that, we've seen in the previous sessions all the data about the upfront therapy. So the Griffin, Perseus, in these patients, in these trial, plasma cell leukemia was excluded completely from this trial. So there is lots of uncertainty here. So to answer this question, maybe kind of, I would say, the Greek, they looked at their registry, so 20 years of follow-up from 2001 till 2021, and they found 110 plasma cell leukemia, and they looked at what treatment that they have received. So 21 of the patients, they received DARA-based quadruplet, 16% received VRD, 52% they received bortezomib standard combination, and 11% they received conventional chemotherapy. And these are the treatment they have received, and we can see that in chemo, in the standard bortezomib group, they included the VDD base and VCD. So basically, they try to compare between the DARA-based quadruplet and patients who received either bortezomib standard therapy, like VTD-based, VRD-based, or conventional chemotherapy. And they found that actually, and this is retrospective, so you have to understand the limitations for it, associated with a better PFS, 25 months in comparison to 13 months, with a significant p-value. And in terms of the overall survival, quadruplet, the median PFS was not reached after 52 months of follow-up. That was resulted in a difference in the Kaplan-Meier curve, as you can see here.
3 minutes.
So the predictor for poor survival was 17p and platelet less than 100. So what the recommended induction in primary plasma cell leukemia, based on that, I would suggest to you quadruplets with anti-CD3 VRD or KRD. Conventional chemotherapy can be incorporated into the first 1 or 2 cycles if rapid response needed and you want to get rid of the leukemic phase. Now, in terms of transplant, what to do, single, tandem, or allo. So the CIBMTR, they looked at their data over 7 years from 2008 and 2015. They're able to found this number of primary plasma cell leukemia. Around 300, they underwent auto-transplant. Around 71, they had allogenic transplant. The table in front of you is showing you their status at the time of the transplant and what induction that they have received. So you can see here in terms of the outcome, so the non-relapse mortality, meaning that the TRM, so the TRM in the allo, as we can expect, was more, but the relapse rate on the allo was better. So meaning that you even out, you are increasing the mortality by the allo, but maybe you are decreasing the relapse rate. So, but as a conclusion, you can see that the PFS was comparable between both and also the overall survival. The predictors for survival was good performance status. So if you want to take a patient for allo transplant, be selective in the good performance. So what to make out of this? Tandem transplant or allotransplant are close to each other in terms of outcomes in primary plasma cell leukemia. Allotransplant should be offered if there is a suitable donor, acceptable functional status, and should be provided early in the treatment course if it's going to be provided at all. So what's coming next? So the IFM now, they are doing this trial, the BCL2 trial, for newly diagnosed primary plasma cell leukemia. Patient will receive DARA VRD 4 cycles, first transplant, 2 DARA VRD, second transplant, then DARA VRD every 2 months, so meaning for 1 year, then maintenance. So that's still ongoing. What about incorporating the CAR T cell in the management of these patients? So there are 2 ongoing trials. One of them is a phase 2, so you can see here newly diagnosed myeloma, plasma cell leukemia. They would receive VRD, CAR T, and then VR anti-disease progression. The other trial using a sandwich technique, so VRD times 3, first CAR, auto transplant, second CAR, and then Len until disease progression. In terms of the relapse refractory setting, so it's tough. So basically, you use whatever you haven't used before, incorporate CAR T cell or bispecific for these patients. So it was noted that about 25 up to 75 of patients with primary plasma cell leukemia, they have 11-14. So there is some, some data about the use of venetoclax in management of these patients in term of small case series or case study, but it showed efficacy. So that could be an option. How to assess response? Same to as multiple myeloma, but you have to assess their blood film, and you have to do radiological assessment to look for response in their extramedullary disease. Supportive therapy, these patients, they are sick, they can present with TLS, so you have to give them adequate hydration, allopurinol, raspibericase if needed, adequate antimicrobial therapy, VTA prophylaxis, and in terms of bone-directed therapy, it's also recommended even if there is no bone disease. So in conclusion and recommendation, so plasma cell leukemia is a very aggressive form of plasma cell disorder associated with worse prognosis. Recommended therapy based on the current data and recommendations, induction with anti-CD38 VRD or KRD 4 cycles, first transplant, consolidation 2 cycles, same as induction, second transplant, either O2 or allo if the patient is fit and has a suitable donor, maintenance with triplet or doublet until disease progression. Do not stop therapy for these patients. The patients are ill, initiate therapy as inpatient, especially in the first cycle. Consult the BMT center early, supportive therapy with blood product, antimicrobial, and growth factor support. Thank you so much.
So we have the plenary session. So yes. So we welcome back Dr. Ghazi Al-Atabi. Welcome back.
Thank you very much. I know everybody is very tired, very sleepy. I'll try to make it very interesting. So Majid presented a very difficult topic, and the bottom line of Majid talk is you cannot treat plasma cell leukemia. So we'll move on to something that's very interesting. So what is the role of PCMA therapy in patients with relapsed refractory myeloma? It's very unfortunate when you see, a publication published in October of 2025 labeled the Saudi myeloma guidelines, and you look at it today, and it has to be updated because the second line in that paper doesn't actually apply to today. So if you look at the topic today, we wanted to really explain to you that PCMA should actually come earlier. This is a satellite symposium funded by our colleagues at GSK who manufactured belantamab mavedotin. But over the last literally 10 years, the landscape of myeloma have changed significantly from the advent of daratumumab to isatuximab, and then belantamab came initially in 2019 initial publication took off the market, actually was withdrawn from the market because of, the dosing was not, optimized, and now it's back again with the addition of also teclistamab and talquetamab and linvoseltamab and CAR-T and elranatamab. So this guideline is outdated, and I would recommend that Dr. Ayman, start working on the next iteration of this guideline, because the second line in most of our patients now should be 3 options. Option number 1 is, they either go for a CAR-T, or they should go for daratumumab with teclistamab as a second line, or if they're actually in the category where they cannot have access to the initial 2, then maybe belantamab-based combination should be an option. And I'll show you that, compared to whatever conventional triple therapy you have as second line, these 3 options, outtrumps these things in terms of overall survival. So CAR-T has been covered very well by Dr. Saleh, so we will not, spend too much time. But we have ide-cel, which has never left the USA, and then the cilta-cel that's available in Saudi, and these are the data you've seen earlier. The outcome of the CARTITUDE-4 is quite excellent, but it's not actually the best in the world. But it's still, it's a one-point therapy. People on average, they become disease free for a couple of years. They will not require any other therapies if they survive the CAR-T without cytopenia or needing transfusion support. So now, what is the third option? Belantamab as an anti-BCMA antibody drug conjugate is available in the market to be used from 1 to 3 lines of therapy. It comes in 2 combination. So in those who are LIN refractory, then belantamab, Velcade, Dex is an option, which is probably have a better efficacy and safety than any other combination from the conventional, 3 drug regimen we used. We used to give Dara-KD as our famous second line. In the Ssbmt, belantamab Pomdex has been also investigated and examined against, pomalidomide Velcade Dex. So Ssbmt was actually established on the basis of the DREAM-1, DREAM-2 studies in the 2015-16 time. So it's belantamab Velcade Dex. So those people that are actually LIN refractory from the beginning, the comparator is actually Dara-VD. So it's actually a very nice control arm, and this is the first time we see a study, really examining a good drug versus conventional therapy that we actually can use in the second line setting. And you can see the dosing is much different than the initial study. So now it's actually 2.5 milligram. In the Ssbmt, it's actually 1.9 milligram. And in those people, the treatment is given literally every 3 weeks to even every 4 weeks from the beginning of the study. The initial dosing was actually 2.5 milligram weekly for 3 weeks. So it's, that's why it used to be toxic. And then you can stop the Velcade Dex at one point from cycle 9 and continue on belantamab. So what we see from this study is if you give somebody Dara-VD, then you're giving them an inferior outcome compared if you give them belantamab Velcade Dex. So their median PFS is much better at 40 months follow-up. So it's actually a very effective therapy where the median overall survival was not reached in the intervention arm compared to the control arm. So that's a very valid option. Now, what are the baseline characteristics of those people, or what are the post-protocol therapy? It's not uncommon to see, the post-protocol therapy not being the most effective therapy in myeloma. And maybe some of the safety, maybe some of the overall survival signal is driven from the subsequent lines of therapy they have received. But it's very important to know that, they mostly received a Dara-based combination in their subsequent lines of therapy. So it's considered, appropriate. Not so many of those people received a T-cell engager as a subsequent lines of therapy in the control arm. So the benefit was actually very clear even in the PFS number 2. So whatever second line of therapy they received, you can see that still the intervention arm is doing much better compared to the control arm, with about 49% risk reduction in progression over the study period. So what therapies they received? They mostly received darapomdix or isopomdix. So the good majority of those people received daratumumab-based combination. These combination were actually done in about 53%. Some of those people, they had received pomalidomide-based combination. A good chunk they received carfilzomib, and so on and so forth. Those who received an anti-CD38, the most common companion is pomalidomide in the about 1/4 of the patients. Some of those people, in about 8 patients out of 46, they have received daratumumab monotherapy, which is not a very common regimen we use in the subsequent lines of therapy. Do they use bispecifics? About 10 patients throughout the whole study, they received the subsequent T-cell engagers, but in small numbers, some of those received cefustamab, pomdix, teclistamab, or talquetamab. So about only 10 patients, and the outcome of those people was actually much better than the outcome of those who did not receive a T-cell engager in the post-protocol therapy in the control arm. So one of the important facts in myeloma is those who are len refractory, they do very poor, regardless of their line of therapy. So in this study, those who are len refractory, they were about 50 to 60% of the study population in the DREAM7. They have outperformed the DARA-VD arm in the control arm. So the median PFS or the median PFS is about 25 months compared to about 8 months in the DARA-VD. So it's definitely a much better therapy, especially in those len refractory 1 to 3 lines of therapy. Their overall survival is much higher compared to DVD, so about 85% versus 60%. So it's a great option to be considered. And the MRD negativity rate was about 25% compared to only 5%. And we know that MRD negativity rate is actually much lower in the relapse setting. So the numbers I quoted in the initial talk was in the initial first line of therapy, where you can see 50, 60, 70, even 100%. But in the relapse refractory setting, this number goes down by half. And then the duration of response, is certainly much better. So duration of response is those who achieve the CR, how long do they stay in PFS? And the median has not been reached in the first intervention arm compared to the DARA-VD arm. So DREAM8 is similar, but a tiny bit less efficacious combination, because those populations are actually a tiny bit different. They're mostly, they continue to say 1 to 3 lines of therapy, but they're mostly beyond 2 lines of therapy. The backbone is pomalidomide dex-based compared to, POM, Velcade, dex in the control arm. And again, their primary endpoint is PFS, and their key secondary endpoint is overall survival and MRD negativity. So mostly those people are, again, about 50% or more, they're actually beyond 2 lines of therapy. They have received, lenalidomide in about 100% of the time. So those are certainly, len refractory in all comers. Their prior exposure to anti-CD38 is not very high. It's about 20-25%. So is it an effective therapy for those patients? If in the second line, it's super effective compared to the Velcade Pomdix, which is a reasonable, second line therapy. So the median PFS in the extended follow-up study is about 30 months, which is something you don't actually see in the second relapse third line setting, compared to only 1 year, which is very expected. But this is what we see in third line therapy. And the PFS has been maintained across all arms, and almost all groups have actually benefited, quite a bit from the combination of an anti-BCMA antibody drug conjugate. So forget everything I told you, because I think we know that belantamab is effective. Any anti-BCMA is more than conventional therapy. Now, how can we overcome the very bad hype of belantamab, which is the ocular toxicity? So the mavedotin is actually quite toxic to the cornea, and we've seen this mostly in the belantamab, but we have not seen this with other mavedotin because of the MMA is a tiny bit different in the mavedotin with belantamab than the one you see with brentuximab or any other antibody drug conjugate. So in the study, about 90% they had an eye side effect. So this is something we have to know from the beginning. And those who come to the study with risk factors to any eye adverse events, they will probably have a high probability to develop this. But if you actually look at the majority of these eye adverse events, they're mostly blurry vision and dry eyes. So really serious eye manifestation is not very common. Blindness did not happen in the study. So nobody's going to get blind from this drug, but their best corrected visual acuity, drops with time. And this is why we should really look closely to those people. So in the label, they have to see an optometrist, prior to every visit. And then, based on certain numbers, you can actually either stop the drug and space it out, or you can even go down on the dosing. And with this effective, strategy, and this is why the FDA went back and reapproved the drug, after the RIMS, program they have created. So ultimately dose reduction happened in about 60% in the study population. Discontinuation only happened in about 9% if you actually accurately follow those people. And the follow-up is actually very easy. So it's a certain number, you have to look it up, and if they reach this number, then either you do dose reduction or you do discontinuation, and then in a couple of weeks you go back and examine them again. And the majority of those people, their eye side effect comes back to normal. So now, what is the expected timing? Don't expect this to happen quickly. So I have currently 6 patients on belantamab from their compassionate use, and it's very early to see these side effects, except until you reach 11 weeks. So 11, 16 weeks is when most of these side effects happens. And if those who develop blurry vision, you can sometimes expect correction without holding therapy. But in those you hold therapy, in about 9 weeks, all of these side effects disappear completely in those people. So reduction in best corrected visual acuity was reported in about 35% of the patients. So now, does it truly affect if you continue or discontinue therapy or delay therapy? Does this affect the effectiveness of the drug? The correct answer is no. It actually hasn't been very detrimental to the effect of this drug. But what's interesting here is most of those people. So here the percentage of people who developed 20/50 vision or worse, the number goes down because the spacing of the drug continues to go up. So the initial study, according to protocol, is every 3 weeks in the Ssbmt or every 4 weeks with PALM combination. So you start every 3 weeks, and in the majority of patients, at one point it becomes every 9 weeks, every 12 weeks. So the drug continues to be over a very long period of time, but the response or the median, the depth of response remains the same. And this has been the case in both, the Ssbmt or the Ssbmt. So now, in those who had extended, dose delay, what happened to them? So those who started with less than PR, which is about 55%, even after discontinuation, 94% they had either they maintained PR or they actually had a deepening of response. So we know that these are a very effective drug. The utilization of maximum tolerated dose is not the right strategy. It's probably a small amount of drug is needed to suppress the BCMA. And this is the same thing with the Ssbmt. I think the take-home message from the Ssbmt and 8 ophthalmology examination is, dose modification is very important. The amount of people who had remained with response even after more than 9 weeks of delay is 92 in the Ssbmt and 94 in the Ssbmt. So those about more than 90%, they continue to have the same depth of response despite even more than 9 weeks of discontinuation. But keep in mind the number is not very high, but it's about 100 patients. The other take-home message is if you look at the clinical trials reporting, so the CTCA grading, all of these side effects or these blurry vision or dry eye, they're more or less grade 1 toxicity. They're not actually grade 3 or 4, and that's in the majority of the patient, more than 90%. So and in those who started the study, they get initial reading assessment and abilities to driving assessment. Even with the side effects, 97% of the time it did not affect their reading ability, and 92% of the time it did not affect their driving ability. So it's an effective drug in my opinion, but we just have to be very careful with how you manage it. Again, we're back to 3 options. Second line, CAR T is probably the best. If people can afford going to CAR T, not necessarily first relapse, but probably best timing is second relapse to, compensate for the expected, secondary toxicity and neurotoxicity that happens from CAR T. Probably anti-BCMA bispecific plus daratumumab is a very more appealing, drug with some infection risk, but a tiny bit more safety profile. Belantamab can come to a small, proportion of patients who are probably at a high risk of infections because, with this drug, risk of infection has not been very high. With that, I think we'll conclude because the bispecific talk has been covered. Thank you very much.
Thank you very much for all the speakers. We could proceed with the panel discussion. While everything is gathered, I would like to just remind and invite everyone today for the evening satellite symposium. Very distinguished talkers. We have Dr. Ail Yahya, Dr. of course Ayman Hijazi, Dr. Musa Zahrani, and it will be followed by an outdoor gala dinner for everyone for us to meet and socialize together, inshallah. At 7:30, sorry. If anyone wants to start, have any questions here, please, let's start. Do we have microphones for the audience? We could start here, please. It's okay. We could start there, please. Thank you.
Assalamu alaikum. Thanks for all the speakers for the distinguished talks. So I have a question, and it's to all speakers, and if you can answer that. If a patient became MRD negative for a period of years, can I say as a physician that after like 15 years, potentially or functionally, this patient is cured, or after 20 years or after 10 years of MRD negativity?
Very difficult hypothetical question. The study from Athens that was published last year looked at a cohort of patients who received the initial, usually VRD induction, transplant, and maintenance with LIN. They have realized that those who are MRD negative at 3 years, and they remained MRD for 3 years, they have been able to achieve another 3 years of progression-free survival and normal survival with no disease resurgence in about 86%. So, would you consider those people functionally cured? I think, certainly you could do that, but in myeloma, we have not been able to call people cured because the majority of patients were required to stay on therapy, and mostly they will succumb to their disease.
Do you have any of your patients, all of you four, that's more than 10 years disease-free?
I'm probably the youngest in the group, so I'll leave this to Ayman.
I do have, a couple of patients who are, after the first line of therapy, they are in remission for more than 10 years. I do. Hopefully they continue. Are they cured? Probably yes. I don't know.
Okay, Dr. Mohsen and then Dr. Askar.
Yes, thank you for the very nice presentations. What is the current recommendation for the maintenance, the duration of maintenance therapy post first-line treatment and transplant? Is it like continuous, or with these new effective agents, second line, third line, should we stop at 2 years? Is there any new guidelines?
This question has been debatable over years. Nobody knew exactly. The initial maintenance durations in the lenalidomide, you remember, was 2 years. And then subsequently, we knew that 3 years is better. And we know those who continue on maintenance will have a reduced relapse rate. So in the Perseus trial, where they have incorporated daratumumab in addition to lenalidomide, they governed this by MRD testing that you have to do every year. And if the patient has persistent MRD negativity at 2 years, in the trial, they stopped daratumumab, but they still continued lenalidomide. What is the general advice among myeloma treating physicians, although this does not have a strong evidence is to continue until progression, if well tolerated. Any other comments?
So I have a strong opinion against what Dr. Ayman said.
Thank you.
So in the Perseus trial, if somebody started on daratumumab, I mean, they're mostly, they end up with Dara-Lin maintenance, and then in 2 years, they randomize them to, based on MRD. I mean, now, if somebody has finished a year of Lin and daratumumab, would they actually benefit from continuing daratumumab? Would their depth of response gets better with time? Not necessarily. And the problem is if you actually continue daratumumab and they progress on dara, you've actually prevented them from getting a very effective second-line therapy, which is daratumumab with teclistamab, because the study that looked at dara-tec, they allowed for exposed patients, but not dara-refractory. And the outcome has been quite, magnificent compared to teclistamab monotherapy. So I would probably stop at 2 years, let them progress, but they wouldn't they would be still, data naive, or data exposed but not refractory, so I can combine with teclistamab. It's probably cost effective.
If I may add, I think we all agree that patients should be on maintenance. I mean, our myeloma biology is different, I believe. Patients are presenting at a younger age. It's usually aggressive. So to be honest with you, I feel scared to stop maintenance. I always push for maintenance. We can debate about what type of maintenance, but for me, I push for maintenance until disease progression, and unless we have the MRD testing and follow-up from the trials.
Dr. Ahmed, please.
Well, actually, I was going to ask the same question, but now it turns out to be a comment, since the question is already raised, and I would again support what Dr. Ayman and Dr. Abdullah mentioned in terms of continuing maintenance. I mean, it's from the same hospital, but based on experience, I mean, and you probably you showed the data again. I mean, the achieving MRD is the target, and leaving it out, I mean, patient will relapse. Now, whether you continue or you stop and wait for relapse, that would be the question. Now, would it be justified to wait for relapse so you could use the agent again? Again, since you achieved that depth of remission, I would continue. And now, given again the multiple agents, mashallah, in multiple myeloma, I think you still have other options to use. I mean, the CAR-T, the O2, the others. Just opinion. But again, that brings us to another question. Would you use single agent in maintenance, or double agents or doublets? Again, the data is still not mature, but I'm waiting for something that would even push us towards even using doublets as maintenance in these
Excellent
cases.
comment, Dr. Al-Askar. Now, I would like to clarify that I'm not talking about stopping Lin. So the discussion is, do you continue daratumumab or not? Lin should be continued until disease progression. There's no question about it. If somebody started on dara, let's say, in January 2026, this patient was started on dara plus Lin. If they stayed till the end of the year on dara and Lin, would you expect daratumumab to add anything next year? In the study, no, it didn't actually deepen their response, and it's probably time to stop the daratumumab, but the Lin continues, and I would like to utilize that daratumumab, because there's an excellent, basic science synergy between CD38 and BCMA, so it makes clinical sense that the combination is actually more efficacious than one. But the Lin, there is an overall survival from Lin, so we would not stop this.
Okay, just another comment with regard that daratumumab is part of the maintenance. So if you want to learn something from another trial, which is the Cassiopeia trial. So the Cassiopeia trial, there is one point we can get out of it, although it's not the perfect scenario. So basically, they randomized the patient to receive dara VDD or VDD, and then they did another randomization for no maintenance or dara maintenance. So they found that, you know, most of the benefit for the DARA maintenance was in the patient who did not receive DARA in the upfront. There was slight difference. There was slight advantage with DARA maintenance in both, but it was more evident in patient who did not receive it. So now the big question, if the patient received DARA as a upfront, as a quadruplet, would they get a benefit if we add DARA to the LEN? I think that's not not an answered question, but the Casubia gave us a hint about that you can just go with LEN maintenance with no يعني, a must DARA with it. Yeah, so plasma cell leukemia, I definitely I would add bortezomib because bortezomib for these patients so I would go with bortezomib blend or DARA bortezomib blend, something like that. And definitely the treatment is continuous until progression or an acceptable toxicity.
For all high-risk patients, yeah, I guess, I mean, high-risk patients, we always give a doublet. Now, what is a doublet as maintenance? We used to give len and bortezomib. Now we are maybe towards being more fashionable, probably, give len and dara. But I guess high-risk patients need a doublet if you can afford. I mean, there are trials that have given them full therapy, continuous, VRD, continuous.
So are you all believer in the 17 years projected median BFS with the quadruple transplant and doublet maintenance? Because we are seeing patient progressing within a year with DARA VRD.
Well, I mean, this is based on calculations, but it's only time will tell how long, I mean, the median PFS will be. It's just expectations of statisticians, which I doubt about what they do, but that's what has been, I mean, told. But definitely it's going to be probably the longest median PFS we have seen in the upfront therapy so far. I mean, short of the new modalities that we are going to see in the future when we have bispecific CAR-T in the upfront line.
There's a lot of similarities between like the ultra high risk multiple myeloma, plasma cell leukemia. Should there be like differences or boundaries in the therapy, or should they be treated similar? I mean,
okay, most of the ongoing or the recruiting clinical trial, they are including both ultra high risk and plasma cell leukemia. I think part of that because it would be challenging to do only a trial for plasma cell leukemia. The recruitment will take so long. So now with the newer recommendation, they are trying to, you know, lump it together. Yeah.
Dr. Mohsen?
Yes, question regarding the second transplant for those who relapse more than 18 or 24 months. Is there still a place for second autologous transplant? You know, we store cells for 2 transplants. So with this bispecific CAR-T and all of these new agents?
Well, for me, I have never done a second transplant, maybe Dr. Ayman, but I would still recommend to collect for 2, just in case to use the stem cells for post-cytopenias for CAR-T.
You remember, Dr. Mohsen, I mean, in the past, I mean, recommendations used to be if the patient achieves a 1.5 year duration of remission, you can do a second auto upon relapse. And then when we had the lenalidomide maintenance, then people said, okay, that's if he was off lenalidomide, but on lenalidomide, 3 years of median remission. And now, since we have all these other modalities of treatment, the second transplant upon relapse is really fading away. I know you want to have empty space for, you want to throw whatever you have collected in the bank, but it's becoming less and less utilized as a second or a third line option, to be honest. Unless you have collected somebody that you did not do upfront transplant,
that you deferred the transplant for later. That's something different.
One more question. So how about the number of cycles during the induction?
Yes, good.
I mean, we see again 4, 6, 2, 8. More is better. What do you think?
I mean, traditionally, we did 4 cycles, and most of the trials did 4 cycles induction. And most of the recent trials have included 2 cycles consolidation. In our guidelines, when we, published it, we said 4 up to 6 consolidation, 2 cycles, if the induction was 4. And whatever we have said, which we said it earlier than the EM and EHA guidelines, the most recent one, and they have exactly copied what we have said. So 4 induction, 2 consolidation, but if you gave 6 induction, you can omit consolidation.
Well, if I may,
Yes. Yeah, I mean, sometimes if you chase a better response before transplant, you may lose the transplant point. So I would not really extend therapy hoping for a deeper response and delaying transplant unless I have the decision to delay transplant from the beginning.
if I may add the concern about the collection, and if you're using a quads data-based, usually if you're past cycle 4, reaching cycle 6, you might have difficulties with the collection of the stem cells. So we have had some patients where we had to use more cyclophosphamide to collect. So this is another thing to keep in mind.
Actually, that was shown in the ESA-KIA trial. So in the initial protocol, they gave 6 cycles of ESA-KRD. So they had lots of failure of collection. So they amend the protocol to get 3 cycles of ESA-KRD, collect, and then you can give more. So the point of the collection is always a concern. Now, the number of the cycles. So in President Noura Oncology Center, we decided to, this is actually was presented by the Spanish group to give 6 cycles before induction because they found that more MRD negativity with 6 cycles of induction prior to transplant, and outcomes of transplant will be better if you achieve MRD negativity prior to that. So we inherited that approach. Part of that because unfortunately we don't have the luxury of doing MRD detection. So just we are assuming with giving 6 cycles before transplant, you are inducing more MRD negativity.
Okay, thank you very much for everyone. So I think a coffee break and then we're back for the gene therapy. And please don't forget the satellite symposium at 7:30, followed by dinner, inshallah.
هلا حياك دكتور احمد، حياك الله، كيف حالك شيخ؟ So we are now starting the fourth session about hemoglobinopathies, and we will start with the Vertex Satellite Symposium. So about gene therapies, new era and hemoglobinopathies. It will be presented by Dr. Ihab Al-Hamidi. He's a consultant in adult hematology and assistant professor at King Saud bin Abdulaziz for Health Sciences. He trained in London at Guy St. Thomas and King's College Hospital, has been practicing hematology since 2003, currently working at the Princess Noor Oncology Center in Jeddah. He's a member of the Royal College of Physicians and fellow of the Royal College of Pathologists, among other professional affiliations. He has over 30 publications, including editing 2 books. Dr. Ihab, the mic is yours.
Thank you very much, Dr. Sultan, for your kind introduction. And I'd like to thank Vertex for this opportunity and thank Ssbmt and SSH for the invitation. So I'm going to talk to you today about gene therapy, a new era in hemoglobinopathies. So what we'll discuss today is the incidence of sickle cell disease worldwide, gene therapy history, and gene therapy trials results. So worldwide, we get about 500,000 child a year affected by sickle cell disease. And as you can see here, the countries in orangey color, and the darker the orange, the more the incidence of sickle cell disease in these countries. And you can see here the specific mortality from sickle cell disease. As the country is more advanced, then the death rate is reduced and the country color becomes light blue, despite the higher incidence. And you can see Saudi Arabia here, although the incidence is high, but the mortality from the disease is lower than African countries. This is the incidence of death under the age of 5 years from sickle cell disease, and I can see that the countries who are affected by this in terms of ranking. And the cause-specific death from sickle cell disease, patients who are affected by sickle cell disease, they don't do as well as the general population, as you can see here. This is the sickle cell mortality between 15 to 49. Again, the mortality in this point in time is increased due to sickle cell disease. So history of gene therapy, in 1987, Atsu Nakata group in Japan, they described this CRISPR finding in Escherichia coli. It's the P stands for palindromic, and palindromic means it can be read from left to right and right to left the same way, just the same as the statement like race car. You can read race car from left to right and right to left. So these are repeats inside the Escherichia coli that help the Escherichia coli detect retrovirus when they enter it. So it's part of the immune system of bacteria, and it helps bacteria fight viruses. So this is CRISPR. The Cas is an enzyme. It's a nuclease in Streptococcus pyogenes. And when it is bound to the technology of identifying areas that are palindromic, it gives us gene editing ability. So this is the Cas9, which helps bacteria fight retroviruses. It cuts DNA as it finds the CRISPR, the palindromic areas in the virus DNA, and kills the virus. These two ladies, Donna and Carpentier, They got the Nobel Prize in 2020 because they transformed the technology which was found and described in the bacteria into cell lines in vitro. And this CRISPR-Cas technology has wide variety of applications, not only in gene therapy, but also in biofuels, ethical concerns, disease-resistant cancer. In the future, it will be also applied in cancer therapies. So in the CRISPR technology, the first point in editing a gene is to identify the area that is palindromic. And this is done by a guide RNA. This is synthesized in the lab, and it guides the CRISPR-Cas nuclease into this area. And what we do is we collect the stem cells from the patients, and then the cells are taken to the lab, and in the lab the stem cells are electrocuted, so it have pores in the cells, and these pores through which the CRISPR-Cas nuclease enters the stem cells. And for this reason, because some of the cells actually die from the electrical currents, for this reason why this technology requires a lot more stem cells than any other autologous or allogeneic stem cell transplant we do. And as the CRISPR-Cas technology enters the cell, it identifies the area that it binds to it, and then it targets the gene that we want to edit. We find the gene that needs to be edited, and it either deletes or modifies or adds a gene. So there are many other editing technologies. CRISPR-Cas is one of them. There is the TALENs and the Zinger finger nucleases, and all are the other two, the TALENs and Zinger finger, is a DNA technology, while the CRISPR-Cas is a DNA-guided technology. So this is one of the differences. The RNA sequencing is important in the CRISPR-Cas technology. It uses the Cas9 enzyme, while the other two technologies use the focal nuclease. The difference between CRISPR-Cas and the other technologies is very easy to use, while the others are more moderate to difficult. The Zinger finger nuclease was the first to be discovered, and I think now it's become historical. The cost is lower with CRISPR-Cas, and the editing efficiency is higher with CRISPR-Cas, and the off-target risk is moderate. So multiplex editing is easier, but it's rapidly expanding the CRISPR-Cas technology. There are other technologies being processed at the moment, and you can see this in the list. Some of them use permanent technologies to edit the genes permanently, some don't. And we will see more of these technologies of editing genes in the future. So we'll go to the trial results, the CLIMB 121 and 131 of exa-cel. And basically here, the CRISPR-Cas is used to edit a gene called BCL11A, which inhibits hemoglobin F. And as you delete this gene, then the hemoglobin F is started to be produced more because this gene inhibits hemoglobin F production. So we've discussed this. We screen the patients, we collect the stem cells, then after the stem cells are dealt with, the patients are conditioned, and then the exa-cel is infused, and then follow-up for 2 years is the CLIMB 121 trial, and after 2 years it was called a CLIMB 131 trial. And we will see the results of both trials. So the age was about 21, 46 patients were enrolled in this trial. The majority were actually 18 to less than 35. The majority were hemoglobin SS disease, 90% of the patients, and very few patients had one gene deletion of alpha gene. There are very few of 2 gene and triple gene deletions enrolled in this trial. So the engraftment was about 1 month of neutrophils and about 1 month for platelets. The CLIMB 1-to-1 primary endpoint was freedom from painful crisis, vaso-occlusive crisis, and freedom from hospitalization. And at 1 year, 91% of patients were free from vaso-occlusive crisis, and 98% were free from hospitalization. This is a swimmer's plot which shows the patients in gray are the patients before they get the treatment, and each line is one patient, and the red bars are the transfusions they had, and then the dots in the green line tells us whether the patient had vaso-occlusive crisis after the therapy or not. And you can see the majority of patients didn't have any vaso-occlusive crisis after the therapy. The one I marked here in red is one of the few patients who had multiple vaso-occlusive crises after the gene therapy. In the older group and in the younger group, only one patient that had multiple vaso-occlusive crises. The rest, as you can see, there aren't any dots in their lines. The hospitalization was even better, and so very few patients, even if they had vaso-occlusive crisis, they were not admitted. It was mild vaso-occlusive crisis, and the majority of patients were not hospitalized after the therapy. This is the level of hemoglobin F, and you can see here the hemoglobin has improved after the treatment, and the hemoglobin F reached about 45 to 50% in the majority of patients. So half the hemoglobin became hemoglobin F. This is a bone marrow showing the percentage of patients with edited cells, and you can see here that 70 to 80% of the patients have actually edited cells. The hemolysis markers, the LDH, haptoglobin, reticulocyte count, indirect hemoglobin, all improved after the therapy. So this is the quality of life of patients after the therapy, and you can see, compared to the US population, the quality of life of the patient in this trial has improved, and it's equivalent to the US population or maybe slightly better. The toxicity is related to the busulfan, which we expect because it's like an autologous transplant, and the mortality was about 1 patient died, which is about 2.2% of the patients. So this trial concluded that 91 achieved the freedom from vaso-occlusive crisis, 98% from hospitalization, 100% were actually free from hospitalization of vaso-occlusive crisis at the latest follow-up at 3 years. So at 3 years, everyone was free from vaso-occlusive crisis and hospitalization. It's durable. Hemoglobin F is about 40% or more, stable editing, and results were consistent along the age groups. Adolescents required few mobilization cycles, which is an issue sometimes, and safety profile is consistent with myeloablative busulfan, and long-term follow-up is needed to see if there is a functional cure for these severely affected patients. This is a thalassemia patients where the same gene is being edited, and again the age is about 21 years, and it's hemoglobin beta 0, and beta 0, beta-like, the majority of the patients. Iron overload, the median iron ferritin level was about more than 1,200. And this is important. Neutrophil engraftment, again, same like 1 month. And again, this swimmer plot shows the patients who require blood transfusion after the transfusion of the cells. And you can see the majority of patients actually don't need transfusion, while very few patients needed transfusion after the infusion of the cells. The majority of the patients actually had green lines. The hemoglobin F here was much higher than in sickle patients, and you can see here hemoglobin F was about 11 grams. And the bone marrow, again, maintained the allelic ratio. There is no death in this part of the study in thalassemia patients. Patients on iron chelation had to stop iron chelation before the infusion for about a week. And then after the cells are infused, they are not allowed to start iron chelation for at least 6 months after the infusion. And then they looked at their iron levels, and you can see here 69% of patients after 6 months they restarted their therapy, and 70% are without any iron overload. This is their serum ferritin improved, and this is their liver iron, again improved after the trial. And this is their erythroferrone and hepcidin levels, again, they're all improved. So concluded that after follow-up of 6.5 years, 95% of participants achieved the primary target of freedom from transfusion at 12 months after the infusion of the cells. 98% of the patients are free from transfusion at 3.9 years after the end of therapy, and it's durable increase in hemoglobin F and stable allelic ratios. So exa-cel is potentially correcting the ineffective erythropoiesis in sickle cell. 70% of patients do not require long-term iron chelation after the infusion, and there is no evidence of reaccumulation of iron in these patients. The safety is consistent with someone receiving busulfan conditioning. The long-term follow-up continues to demonstrate exa-cel has the potential to provide one-time functional cure to patients with TDT. The next gene type of treatment is the gene addition trials. The gene addition trials, the lovo-cel. The lovo-cel is used for sickle cell patients. It is similar to exa-cel. You need to use busulfan, but here you edit the gene. So you delete the gene that's causing sickle cell, and with a lentivirus, you introduce a gene that can produce normal hemoglobin A. So encoding beta hemoglobin A, it's called beta 8087Q. And the process is similar. You collect the cells, you use the lentivirus to introduce the new gene that edits the sickle gene, and then you treat the patient with busulfan, and then you infuse the cells that have been edited. In this trial, there are 3 groups. Group A was an exploratory trial where they did the harvest, doing bone marrow harvest, and they used a lower dose of busulfan, and the targeted total amount of CD34 cells was about 1.5. The group B, they did as well bone marrow harvest, but here the busulfan dose was increased, and they used more CD34 cells for infusion. Group B, they did bone marrow harvest and plexifor apheresis, and again, they did conditioning with busulfan at a higher level, and the stem cell dose was 2 × 10⁶ per kilogram. So the outcome, as you can see here, these are single patients. There isn't results for all the patients tried. And you can see here improvement in the patients' hemoglobins and sickle cell crisis. They looked at this in blood abstract in 2023, and they've shown that the hemoglobin A in these patients increased from being 0 to about 40 to 50%, and the quality of life has improved using this gene therapy. Here again, another swimmer's plot showing those patients who actually had a crisis after the infusion of the edited cells, and you can see that the red dots, the majority of patients actually had improvement and didn't have any vaso-occlusive crisis. These are other trials of gene editing that are ongoing at the moment, and they all use busulfan, some use melphalan as conditioning regimen, but we don't have any results of these. There are other editing trials, like this other trial, again using BCL11A locus, and we're awaiting the results of this trial, but this trial uses the Zinger finger nuclease editing rather than CRISPR-Cas9. So in summary, these gene therapies are effective in erythropoiesis and maintaining erythropoiesis. They mitigate downstream complications, including vaso-occlusive crisis, hemolysis, and end organ damage. They are transformative as one-time intervention, and they produce a good quality of life. And you don't need a donor to treat patients. You can treat them with their own stem cells. Complications like graft-versus-host disease are prevented, are not part of complications of this intervention. The difference between gene addition and gene editing is that gene addition, you get material from other source, while editing you use the patient's own DNA to edit. Here in the addition, you need a virus to introduce the gene, while in editing you use electroporation to introduce the enzyme inside the cells. The gene addition is less precise, while the editing is highly precise. So which patient qualify for modifying therapies like the gene therapy that we discussed? So why are sickle patients different? Hemoglobin F level is something that affects the severity of the disease. Alpha thalassemia traits, again, modulate sickle cell anemia. It reduces intracellular concentration of hemoglobin S that in turn decreases hemoglobin S polymers and induces cellular damage, which ameliorates hemolysis. So the amount of alpha thalassemia genetic mutation helps to reduce the risk of sickle cell crisis. So that's why we have different diseases or different sickle cell clinical findings. Some patients get pain, some patients get stroke, some patients get retinopathy, some patients get renal disease based on their genetics and based on many factors, including the alpha gene mutations. So the principal haplotype includes of sickle cell the Arabian Indian type, and it is suggested that this type and the Senegalese type have higher hemoglobin F, and that's why they are milder disease, in contrast to the sickle cell originating from Benin, Cameroon, and Central Africa, which has lower hemoglobin F %. And however, this does not reflect true in real practice. There are still patients with Arabian Indian type who have severe disease. We need in the future to know which patient will develop stroke, which patient will develop acute chest crisis. And there is a lot of work at looking at genetics that are involved, may be involved with the presence of S that might lead to complications like stroke and chest crisis. But until this moment, we don't have clear genetic changes that tells us which patients are going to have severe phenotype. So who should we refer for stem cell transplant or gene therapy? The referral pathway, there is no clear-cut consensus. Continued evolution of overall improvement in care for children and sickle cell disease. There is increased number of curative therapies in 2020s, in addition to hydroxyurea. However, the median lifespan of a sickle cell patient still remains at 48, even in the best health care systems. So how to consider referring a patient for gene therapy or stem cell transplant will depend on our clinical judgment and the type of disease the patient has. So who should we choose to refer, and who has the higher risk of dying from disease versus dying from toxicity from the proposed treatment? There isn't any phase 3 trial that randomizes the two types of patients, more intensive versus standard of care, and that's why we have to depend on our clinical judgment. So thus we need our clinical skills in determining the patient most likely to benefit from more intense therapy. And this American guideline published in 2021 helps us to identify some of the patients that might benefit from more toxic therapies like stem cell transplant and gene therapy. So they made their recommendation into strong recommendation, whereby there is enough evidence to recommend a treatment, and conditional recommendation when there isn't very strong evidence, but there is some evidence. So stroke, the ASH guidelines say that HLA match sibling rather than standard care hydroxyurea in patients who have sickle cell disease, who have an overt stroke, or have an abnormal transdoppler ultrasound in children. This is a conditional recommendation for stem cell transplantation, preferably in patients who are less than 16 years. Recommendation 2 is for patients with pain while compliant on medications. For these patients, if they have frequent pains, then this is a conditional recommendation for stem cell transplantation. This is defined as more than two painful crises in the last 2 years. So the potential of benefiting from match-related allogeneic bone marrow transplant varies from small to moderate, and acute pain post-transplant was found to be low to non-existent after transplantation. And this is a beneficial, and maybe having multiple painful crises is a marker of severity of disease, and maybe these patients actually will have a problem in the future with other organs damage. So hydroxyurea can be used in patients who have less crisis, new targeted therapies, chronic transfusion therapies, and patient deemed to be compliant. Conclusion of recommendation 2, its benefit versus harm. The overall certainty of evidence is low. However, if patients have a recurrent crisis, it might be a marker of severe sickle cell disease, and they recommend for stem cell transplantation. Acute chest crisis, for patients with recurrent episodes of acute chest crisis, the ASH recommendation suggests allogeneic bone marrow transplantation, condition recommendation with very low certainty. It's preferable to do it at an earlier age rather than an older age, as we will see. Why is that? That's again a conditional recommendation. Optimal hemoglobinopathy clinic setup is preferable if you have high incidence of sickle in the community, because in these types of clinic you can risk stratify patients into severe patients, presence of multidisciplinary team in the clinic, and an update of clinical guidelines. And if you have clear guidelines, you can refer patients earlier when you discover they have severe disease, timely exclusion of required investigations, and early referral to referral centers. So safety of stem cell transplantation. The data suggests that large retrospective analysis of sickle cell, the mortality from transplant is about 5 to 20%. And the probability of overall survival in those who are less than 16 years, overall survival of 95%, event-free survival of 93%. However, patients above 16, the overall survival drops to 81% and event-free survival to 77%. And in CABMTR, they shown that patients above the age of 13 with myeloablative conditioning, they don't do very well with transplant. So patients less than 16 years of age, acute GVHD is 12%, chronic GVHD is 14%. When you go above 16, the GVH increases to 16 to 23%. Graft failure incidence, again, is about 5 to 10% in match-related donor patients, which is a risk with allogeneic transplant. Infection risk is, again, a risk with allogeneic bone marrow transplants. And infertility is another risk for referral to allogeneic bone marrow transplants. Secondary malignancies in the long term is, again, a risk for allogeneic bone marrow transplants. And some centers use myeloablative therapy. However, this is median age is younger group. This is mainly pediatric patients. And overall survival is very good, 94 to 100%. However, the graft rejection is about 2 to 10%, and chronic graft versus D about 12 to 20%. And transplant-related mortality can be high if you use myeloablative. And you can see here in this specific study, the mortality was 13%. So reduced intensity, again, very good survival. However, graft rejection is a bit higher in this group. However, chronic graft versus host disease and TRM is less. At our center, we use less intensity treatment. So stroke or clinically significant neurologic deficit lasting more than 24 months is an indication. 2 or more episodes of acute chest crisis is an indication. And 2 or more vaso-occlusive crisis in 2 years is an indication. And tricuspid irritation of velocity of more than 2.7 in an echo is another indication. And regular blood transfusions, more than 8 transfusions per year for more than a year is another indication for referral. Some consideration for case-by-case, cardiac dysfunction and tricuspid regurgitation, diastolic dysfunction, confirmed by right heart catheterization, lung disease or progressive lung disease is another indication that needs case-by-case discussion: progressive kidney disease, major priapism, and early bone disease. And AVNs, again, is considered as an indication in certain cases. Early liver disease and chronic blood transfusion complications. We all know alloimmunization. So patients who are receiving multiple blood transfusion over a long period will develop alloimmunization, and this is very important that we avoid that. So excluded from referral is left ventricular ejection fraction less than 45, carbon monoxide diffusion less than 50, estimated GFR less than 30, and sickle cell related
1 minute, Doctor.
hepatopathy is another indication. So liver fibrosis. So gene therapy, the trial included patients 12 to 16, but they didn't have any CNS problems or less than 150 centimeters per second. And they had 2 vaso-occlusive crises per year, and they were sickle cell disease. So, and they had good echo status. Exclusion criteria was patients who did not have, there included patients who did not have HLA matched siblings, and patients who had alloimmunization and did not have blood available were excluded from the gene therapy trials. They excluded patients with renal impairment and poor lung function and lower ejection fraction. So I will conclude my study. There is a certainly benefit for gene therapy over transplant in terms of neutrophil engraftment. In terms of transplant-related mortality is much less. Graft failure is non-existent in gene therapy, and acute GVHD is also non-existent. And finally, we have to use our clinical sense and the clinical phenotype and treatment to identify patients who actually qualify for allogeneic stem cell transplant and gene therapy. And thank you very much.
Thank you very much, Dr. Ihab. Discussion will be at the end of the session. By the way, we have 5 speakers in this session, so it's going to be a long session. But very important. Our second speaker is Dr. Mohsen Al-Zahrani. He is very well known in the management and transplantation and now gene therapy for sickle cell disease patients with thalassemia. Dr. Mohsen obtained his medical degree in 2000 from King Abdulaziz University in Jeddah. He obtained the Saudi Board of Internal Medicine in year 2005 and completed hematology residency training in 2009 from Halifax, Canada, and he spent 2 years of fellowship in hematopoietic stem cell transplantation and lymphoma in Halifax and University of Toronto as well in Canada. Dr. Zahrani currently is a consultant of hematology and hematopoietic stem cell transplant and head division of stem cell transplant and cellular therapy at King Abdulaziz Medical City National Guard in Jeddah. You have 25 minutes, Dr. Abdul Mohsen, and you will tell us about the gene therapy and sickle cell and thalassemia. What is the economy, which is very important, and the outcome, clinical outcome.
Thank you, Dr. Ahmed, for the nice introduction, and thank you, Ssbmt, for inviting me to be presenter. Yes, I know it is a difficult subject and very sensitive subject. I'd like to thank also Dr. Ihab for his presentation. He make it easy for me, so I'll overcome some of the slides. This is my objective. So, you know, both sickle cell disease and thalassemia, it's chronic disease with lifelong accumulating complications, multiple systems, serious complications that will affect the health of patients. From different aspects, from the disease and from the treatment also. Quality of life of both disease is, if you survey these patients, it is poor. And in this survey, for both and adult, the quality of life of patients with sickle cell disease and thalassemia is almost close to patients with cancer. Survival with improvement in prophylactic therapies, transfusions, but still, as you see in these curves, patients with sickle cell disease, they live shorter than healthy patients. And in the left side there, or your right side there, the median survival between 50 to 54 years for sickle cell disease, which is significantly short survival, unfortunately. The cost of therapy in this study, it was done from Canada, large patient, 10,000 sickle cell disease. They compared the cost of therapy to another 10,000 other groups of patients with different diseases between 2016 to 2022, and at all aspects of treatment, admissions, medications, treatment of complications, as you see in the table for both adult and pediatric, the cost of care of patients with sickle cell disease is much higher than other patients. The lifetime medical cost, this also from North America, study done. The cost of caring for one patient is almost 1.6 million US dollar, the lifetime cost, which is almost equal maybe to 7 million Saudi riyal. In Saudi Arabia, I found this very interesting recent publication from the Eastern Province, which is showing they did very nice economic calculation to calculate the cost of therapy related to societal cost, total healthcare cost, and the total productivity or indirect cost. So by Saudi riyal, if you calculate all the three domains, it's 18 million per one patient for the lifetime of the patient. So the North America was 7 million, here is 18 million, there is a big gap. But the care of these patients, we know it's very expensive because we are dealing with serious complications and treating patients that maybe at one point they reach in this stage of life. So usually I put this slide, the first slide, but I put it here because you know the cost now and you know the large number of the patients. So the burden of treating patients with sickle cell disease in the country is huge. And the Ministry of Health and all health institutions. So treating these patients with curative treatment, I think it is a very important strategic goals for our country that we need to work on. The other point, the current therapies, there are a lot of limitations. They are not like hydroxyurea. It's a very good drug, but doesn't work for all patients. And it has also side effects, unfortunately. Chronic transfusion, you know the risk of chronic transfusions, the iron overload, and allogenic transplant is a very good type of treatment, but also there is the limitations, donor, GVHD, transplant-related mortality. This has been presented by Dr. Ihab. The gene therapy, it is autologous transplant. At the end, the patient will get conditioning regimen. It's not like the hemophilia gene therapy, just one infusion. No, here you will collect the cells and cryopreserve it, but compared to autologous transplant for myeloma or lymphoma, there will be some modification of the cells before we infuse it back to the patient. And these are the strategies for gene addition or editing that was presented by Dr. Ihab. The gene addition, we use the lentivirus. It is a complex type of procedure. So we estimate it will be of high cost. And the CRISPR-Cas also was shown by Dr. Ihab. So, but really we don't know what is the cost. When we send the lab cells to the lab or to the company, what is the cost of the gene modification, gene editing? Does it really reach that high level of price that we pay for this type of treatment? But it is still, it is a very sophisticated type of modifications. So the patient journey, very important here, as shown by Dr. Ihab, it's 6 steps: patient identification, pre-mobilization, mobilization, gene editing, conditioning, and follow-up. So what we will pay to the company, we will pay only this part, from 2 to 3 million US dollars. We pay this one. While all of these steps, it's still additional cost on the hospital that we don't count. So we have to take this also in consideration. These are the trials for For the gene, for the TDT, Dr. Ihab mentioned about PTCL and XSL, and for sickle cell disease, Lovocell, XSL, and the BEAM also is base editing of PCL11A. We don't have the screen here. This was also shown by Dr. Ihab. This is the updated presentation from the last ASH 2025. For the XSL for sickle cell disease, the primary endpoint, previously it was 94%. With long follow-up, you see it dropped to 91%. So it's still durable, but we need a longer follow-up. Is it going to drop further more than this? We don't know. Even the secondary endpoint, 100%, but it dropped to 98%. And for the transfusion-independent thalassemia, it's 98% of the patient achieved free transfusion at 1 year. Okay, so this slide is also important. It's showing that this type of treatment is durable. So far with this amount of follow-up for like the maximum like 54 months, we are maintaining the level of the hemoglobin and the hemoglobin F. And not like the hemophilia gene therapy when you see drop in the level of factor 8 or factor 9 with time, but here we are seeing maintenance of the response, which is very important aspect in regard to this type of treatment. And by checking the gene editing, also it's maintained over time. And quality of life is a very important aspect that is add on to the benefit of this treatment. The toxicity, it's mainly limited to the chemotherapy, which is busulfan. So if we find a gene therapy without conditioning, that will be even non-toxic, even type of treatment. These are the inclusions for sickle cell disease, basically age 12 and above in the Saudi FDA, but in our hospital we cap it to 35, similar to the study design. Basically patient with recurrent VOCs or acute chest syndrome. But you see a very long list of exclusion criteria. We receive many referrals, but many of them, they will have one of these exclusion criteria as red flags to exclude them from the gene therapy. For transfusion-dependent thalassemia, a minimum 10 transfusions per year or 100 ml per kg per year. So at a level of institution or operationally, you need authorized treatment center. It's not a treatment that can be given in every hospital. There are many important services that need to be available to administer this treatment to make it safe for the administration. GMP facility, if you are going to do the gene editing or gene addition in your lab, multidisciplinary team. It's very important to have all services, infectious, pulmonary, because they will have a role in preparing these patients and follow-up post-transplant manufacturing timeline, ICU and ward capacity, long-term follow-up and registries also important. So the economic reality, here we have the gene therapy involve a high single event cost of approximately $2 to $3 million per patient, creating significant short-term budget impact. This cost must be interpreted in contrast to the cumulative lifetime expenses of chronic disease management. The primary economic challenge here of gene therapy is the concentration of lifetime treatment cost into a single upfront payment. While long-term value may be favorable, short-term affordability remains a major health system constraint. So you are comparing one-time treatment that will have durable and free of other complications to a conventional type of treatment with lifelong complications and treatment. So you are providing here a durable, if you provide durable genetic correction, then the patient will be transfusion free and chelation free. Then fewer hospital and ICU admission, reduced the long-term healthcare utilization, and improved quality of life and societal productivity. Yes, we have to take these in consideration when we think about the cost of the treatment, to say it is expensive or it's not expensive and it has good value. So talking about cost versus value, the cost reflects the price paid at a single point in time, while value reflects the clinical benefit achieved over the patient's lifetime. In gene therapy, value is determined by the durability of response, magnitude of clinical outcome, and quality-adjusted life years gained rather than upfront price alone. So a high-cost therapy may still be of high value if it prevents years of morbidity, eliminate recurrent admissions, improve survival, and delay functions. And I think this can be applied to this type of treatment, the gene therapy. While a lower cost therapy can be low value, like if you think about the current available medications for sickle cell disease or thalassemia, it requires lifelong treatment, accumulates complications despite receiving the treatment, and fails to change disease trajectory. Also, there is a big challenge of health system that we need to take in consideration: the budget allocation, reimbursement model, outcome-based payment, and long-term liability. The challenge for health systems is not whether gene therapy works, but how to responsibly pay for it, monitor it, and remain accountable for outcomes over decades. The clinical reality today, this is not the first-line treatment. We have to realize that. As Dr. Rehab mentioned, not all patients need gene therapy or transplant. Some of these patients, they have very mild phenotype, so we are not applying this therapy for them. It's best to be delivered in expert centers that do a lot of transplants. Then they use this as based on their experience, because you will have less risk of complication, and you know how to manage complication because you are already doing this for transplant. Now, is it competing with transplant or complementing transplant? I think it is complementing transplant. We are lucky to have both modalities in our country for our patients because the number of patients is huge. You cannot do transplant for all patients, and you cannot do gene therapy for all patients. Not all patients are eligible for transplant, and not all patients are eligible for gene therapy. So, and we know from, at least from our experience, the transplant is very good and benefit a lot of patients. So it is complementing the allogenic transplant. However, careful patient selection is very important. Optimal outcome in younger patients with preserved organ function requires assessment of medical, psychological, and logistical readiness, and this is what we do before we take patient into transplant. Future directions: less toxic conditioning, and currently there are conditioning non-chemotherapy, like antibody-based, where you have antibody directed to the stem cells in the bone marrow, and that will not cause toxicity to the body. So this will be like game-changing. In vivo gene editing, also like the hemophilia gene therapy, you just infuse the gene, the product, it will go and it will do the in vivo gene editing, and here you don't need to give chemotherapy. And this can be applicable to those patients who are excluded from current gene therapy because they cannot receive Peselvan. Improved access, expansion of qualified treatment centers, and this is already done. Development of regional and national referral network, streamline manufacturing and scheduling pathway, cost reduction over time, manufacturing efficiencies with the scale, competition across platforms, potential for innovative payment models, and I'm sure there are multiple companies that will come, and the price of the currently available gene therapy also will go down. So take-home message: gene therapy is clinically transformative, as mentioned by Dr. Ihab, can achieve sustained disease controlled and functional cure in selected patients. It's still complex and resource intensive, requires transplant level infrastructure, prolonged hospitalization, and specialized teams. Gene therapy is not replacing existing curative strategy, it is expanding the curative landscape for carefully selected patients. And this is what we saw in our setting. It's become like additional for some patients. Appropriate patient selection remains the strongest determinant of success. Wider adoption will depend on safety, scalability, and sustainability. Thank you very much.
Thanks, Dr. Mohsen. Our next talk is managing challenging cases of sickle cell disease. Will be presented by Dr. Jadallah Ali. He's an adult hematology consultant at the Prince Mohammed bin Nasser Hospital in Jizan. He was born in Sudan, graduated from Jazeera University in 2003 and completed Saudi Board of Internal Medicine, followed by fellowship in adult hematology in 2022. He's trained in King Faisal Specialty Hospital, Riyadh, focusing on both malignant and benign hematology conditions. Dr. Jadallah, the mic is yours.
Thank you for your introduction, and thank you for organizing committee to give me chance to share our local experience in treatment of managing challenging cases in sickle cell anemia in Prince Mohammed bin Nasser Hospital. So this is my disclosure, and I will go through short introduction about sickle cell anemia. It was talked previously by Dr. Al-Hamidi and Dr. Mohsen. So sickle cell anemia is one of the most common inherited life-threatening disorder in human. It's predominantly affect people in Africa, India, and Arab ancestry, and its variants are genetic disorder resulting from presence of mutated from hemoglobin S, and it was result from homozygous and compound heterozygous inheritance, and the disease was first prescribed by Herrick in 1910. So it's worldwide disease distribution, and in Saudi Arabia, you know that it was the common patients in eastern province and western eastern province, mainly in Jizan area and Al Hafuf. As mentioned before by Dr. Al-Hamidi, there is two types. The first, more severe phenotype, which we are facing problems here in Jizan area. Most of our patients here, they have difficult to control with conventional therapy, and was more severe phenotype, and it was called African haplotype or Penin type. And it was characterized by low hemoglobin F and high rate of complication and hospitalization, and difficult to control by conventional therapy. Most of the severe difficult patients, they need new therapies, BMT or referral for gene therapy. The other less severe phenotype, it was called Arab Indian haplotype, which was characterized by low hemoglobin F and sometimes associated with alpha thalassemia, co-inheritance, and it has lower complication and lower hospitalization despite very severe cases in same less severe phenotype. And most of the patient was controlled with conventional therapies. So managing challenging cases in sickle cell disease, it needs a multidisciplinary team, patient-centered approach, focus on prevention and aggressive management of acute complications like vaso-occlusive crisis, CNS crisis, etc. And I will present these cases which was managed in our hospital. So the first case is a 19-year-old male patient. He is known case of sickle cell anemia. This patient, he has a history of recurrent vaso-occlusive crisis, recurrent acute chest syndrome, and recurrent lower limb deep venous thrombosis, diagnosed 2 years back. But the patient, he is not compliant to his anticoagulation, so he has a recurrence. Also, he has gallbladder stone. He denied any history of CNS crisis or periapism, and he has no surgical operation before. Sadly, the patient has no siblings, and both parents were dead. The patient has good performance, and he started to be compliant on hydroxyurea for the last few months. This is a CT in the first acute chest syndrome 2 years back or 3 years back, and at that time the patient was treated with antibiotic automated exchange transfusion with no ICU admission. But this time he came to our hospital in March, in 30th of March, from peripheral hospital with a history of a fever, shortness of breath, chest pain, cough, and admitted to ICU there as his oxygen demand increased. He has good vital signs there, only he has fever, normotensive or borderline blood pressure, and he has tachypnea and tachycardia, but he's requiring around 10-liter high flow nasal cannula, and he has bilateral crepitation on chest examination. He has leukocytosis, myeloneutrophilia. His hemoglobin is 8.9, and his MCV around 68. This questioning that he is not compliant to hydroxyurea. His platelet was normal, but he has mild hyperbilirubinemia with normal renal function test and INR, mildly elevated LDH, and he has sinus tachycardia. X-ray shows that he has bilateral infiltration, and echo study it was normal. The patient was started on antibiotic in peripheral hospital with tazocine, vancomycin, azithromycin, and prophylactic enoxaparin plus folic acid, calcium carbonate, hydroxyurea, and vitamin D. So the patient admitted to the ICU as a case of acute chest syndrome, need non-invasive ventilation, and the CT chest angiography, because of tachycardia, tachypnea, we did for him CT chest angiography. There is no evidence of pulmonary embolism, but he has bilateral consolidation, indicates that he has acute chest syndrome. We prepare the patient for automated, we take consent from the family, and we continue antibiotic. This is the CT, shows that he has massive diffuse bilateral consolidation in the CT chest. On the next day, the patient, he was on maximum non-invasive ventilation, and he's still desatting, and he's still distressed with hypoxemia. So decided by ICU for intubation, and the patient intubated due to hypoxemic respiratory failure, and he's acidotic by blood sampling for blood gas. And at the same day, the patient was started on full automated exchange transfusion by 8 unit. And the called ECMO team called at that day. And early morning the next day, the patient was cannulated with ECMO, extracorporeal membrane oxygenation. Despite that, he is not on inotropic support, and his MAP around 83, but he started to have multi-organ failure in favor of, he has hyperbilirubin increasing to 189, mainly direct. His creatinine also increased from 62 to 138, and he has good urine output. His abdomen ultrasound shows that he has mild hepatomegaly with one stone around 8 mm and small sludge. Bronchoscopy done at the same time, at the same day. Chest X-ray also follow up, it showed bilateral infiltration. After few days this week, is still the patient, he is febrile, but his leukocyte count was improved. Despite that, he have mild thrombocytopenia, but improved at the end of this week. Creatinine is starting to going up, he did not improve. All culture was negative, so antibiotic was managed by ID and start changes from tazocine to imipenem, vancomycin, azithromycin, and given one shot of amikacin. A few days later, the patient improved on antibiotic, and after full automatic exchange transfusion, his hemoglobin less at that time less than 30%. So the patient decannulated after 7 days of ECMO, and he was extubated around 10 days after admission to the ICU. We start him on incentive spirometry for chest physiotherapy, and we continue antibiotic for 2 weeks. This is a CT after 2 weeks, as there is clear improvement and resolution of the previous consolidation. The patient was shifted to the ward and started on oral care, limb and chest physiotherapy, nutritional support, and wound care, as he has developed bed sore third degree in sacral area while he was admitted in ICU. The patient after that, he improved and discharged home, and future plan, as he has no sibling, and sadly he has where his parent was dead, so we refer him for haploidentical stem cell transplant versus gene therapy. So This is the New England Journal of Medicine, which shows that the most common cause of death in sickle cell anemia is acute chest syndrome and hospitalization among patients with sickle cell disease. The second case is sickle cell anemia with acute chest syndrome, pulmonary embolism, and intracerebral hemorrhage. This is a 39-year-old female patient. She is known case of sickle cell anemia. This patient, she has a history of acute chest syndrome previously, received blood exchange transfusion at that time, a few years back, and she has AVN of the hip that was has left hip replacement 20 years back, and she has also a history of pregnancy-related deep venous thrombosis of the left lower limb 3 years back. As a patient, currently she is on contraceptive implant for the last 3 years, and she is not compliant to hydroxyurea, according to her, because of supply. So this patient, she denied any history of CNS crisis and no history of bleeding disorder before. And she was also referred to us because of history of fever for 5 days in peripheral hospital, followed by chest pain, shortness of breath for 3 days, and referred to our hospital as a case of acute chest syndrome in July 2023. On arrival to our hospital, the patient was sick, and she was admitted immediately to ICU as she have tachycardia, tachypnea. She is normotensive at that time, but she is requiring oxygen. She is desatting, and she has no sign of lower limb DVT. All other examination was normal, including CNS examination. It was grossly intact. At arrival lab, she has anemia. She had mild thrombocytopenia and high LDS 3960, and she had also hyperbilirubinemia in form of total bilirubin 125 with normal creatinine. Workup showed that she have sinus tachycardia in ECG with ST elevation and T-wave inversion in lead AVR, V1, V6, V2, and V3 that suggest acute right ventricular strain and typical feature of pulmonary embolism in ECG in S1, Q3, and T3. So the patient was took to the CT chest angiography, which shows that she has multiple level of pulmonary embolism, segmental and subsegmental, and she received blood transfusion immediately with 2-unit pack RBCs. Unfortunately, the patient deteriorated, and this is the echo. Also, it was done at the same time. It showed markedly huge dilated right ventricle with impaired systolic function and increased pulmonary pressure, 41. And unfortunately, the patient, this is a CT, showed that she have bilateral involving a lower segmental and subsegmental pulmonary arteries embolism. Patient started on therapeutic enoxaparin, 1 milligram per kg subcutaneous BID, and we involve multidisciplinary team, ICU, pulmonary cardiology, and hematology, as the patient unfortunately deteriorated in form of hypotension and echo finding, and they decided to start for the patient full thrombolytic therapy with actylase. So the patient thrombolized. Unfortunately, 24 hours, the patient, she developed decreased level of consciousness, GCS going down up to 10, with right side weakness, mainly upper limb. At that time, she has low platelet 78, and INR 1.3, and she has borderline blood pressure, and she's maintaining 10 liter oxygen by mask. And we did for her CT brain. It shows that she have intracerebral bleed. This 24 hours after thrombolytic therapy. The patient intubated due to low GCS and received 1-unit pack RBCs and prepared for full automated exchange transfusion, and all anticoagulation was stopped. Neurosurgery was consulted and started. No intervention at that time, as the patient kept on prophylaxis compressive stocking. This is a CT brain, showed that she have SOBRA and infratentorial hemorrhage. We did MRI on the next day, also showed the hemorrhage. This is a MRI brain of the patient. So 6 units of PAC RBCs were collected and automatic exchange transfusion was done for the patient. At that time, her hemoglobin 9 and platelet only 30. Also, she received 6 unit platelet transfusion and platelet increment up to 99. Hemoglobin S after transfusion came 7.6. We did CT brain after 4 days. After this, still there is hemorrhage, and the patient improved clinically, and they decided to be extubated after around 12 days of intubation, and she was extubated successfully. On the day of extubation, the patient, we did for her CT brain and CT chest because of she have respiratory symptom. Unfortunately, she have neo consolidation, but there is interval regression of the previously described pulmonary embolism. So the patient started on antibiotic, tazocine, vancomycin. This is a CT brain. It showed reduction in the number and size of previously hemorrhage in the brain. And again, after 2 weeks, we decide by multidisciplinary team to resume anticoagulation. At this time, the decision is to start with the half dose heparin infusion and then gradually increase and to do CT brain every 72 hours to see if there is any improvement or any new hemorrhage in the CT, and we stop all anticoagulation whenever there is sign of bleeding or new neurological symptom or imaging indicating that the worsening of bleeding. And we decide to remove contraceptive implant by gynae and to explain to the watcher the further plan this, and we counsel the husband and the family for central line insertion and starting heparin infusion. They understood the benefit to treat and prevent further pulmonary embolism and risk for intracerebral hemorrhage. So 2 days later, CT brain, it was normal and resolved intracerebral hemorrhage. So we start heparin infusion and we did CT brain every 72 hours. And everything is okay at that time. Every 3 days we are seeing the CT brain. There is no hemorrhage. The last, it was around 27 days and it was composed, no significant interval change or new developed abnormality. So the patient shifted to enoxaparin and finally to apixaban, and we refer the patient to OB/GYN for contraceptive implant removal, lymphotherapy, and incentive spirometry, as the patient discharged home safely. This is the last CT brain upon discharge, which was totally resolved intracerebral hemorrhage. And finally, around 27% of sickle cell patients, they were found to have had at least one thrombotic event during their hospitalization. So in systemic thrombolytic syndrome in sickle cell anemia with pulmonary embolism, we have to stratify the risk for our patient for thrombolytic and to review the absolute contraindication and relative contraindication for thrombolytic therapy. And multidisciplinary team involvement is always recommended for such cases. And sickle cell disease patients have vasculopathy which have increased the risk of bleeding like our patient we described. And we have to differentiate between pulmonary embolism and fat embolism. And the possibility of direct thrombolytic still is there, but she needs experienced radiology intervention team when we have high risk bleeding. And this, it has a less risk of bleeding and less hospitalization and ICU duration of admission. So from our local experience, this is a first case that we did full thrombolytic therapy, but our colleague Dr. Hafiz Anas and Dr. Muhammad Bakar before, they almost we have agreement that half dose of thrombolytic is valid and effective when we have high risk patient for bleeding. So this is case 3, sickle cell hepatopathy. I have this patient. He's a 37-year-old male patient. He's no case of sickle cell anemia, and also he has a history of recurrent vaso-occlusive crisis, acute chest syndrome before, and also he has a history of AVN right hip, status post right hip arthroplasty, and he has also lumbar disc prolapse and secondary iron overload with history of sickle cell hepatopathy twice in the last 5 years. This patient, he was on monthly regular exchange transfusion because of all the time he has hyperbilirubinemia, and whenever he does not have exchange, his bilirubin is high. He presented to our hospital with deep jaundice all over the body and yellow discoloration of the sclera. When we saw the patient, he is hypotensive and he is maintaining his oxygen saturation, he is afebrile, and we did for him lab. It shows that his hemoglobin is 9, MCV 76, that he is not compliant to hydroxyurea, and he had mild thrombocytopenia, and creatinine is high, 300. This is the first time. And he has total bilirubin around 1,585, that is mainly direct, around 916, with high LDH. With the arranged liver enzymes, AST around 195 and ALT around 60. INR is high also. He has coagulopathy in form of INR 0.2, PTT 63 and PT 39, and hyperferritinemia in form of 3,864. So ultrasound abdomen was done for this patient. It shows that he has mild hepatomegaly with gallbladder sludge, and liver MRI and MRCP was done, shows that he has feature of iron overload and no biliary stone or no CBD obstruction. So we summarize this patient that he have jaundice, hyperbilirubinemia, hepatitis B virus, antigen positive, he has transaminitis, acute kidney injury. So he received 8 units of PAC RBCs by automated exchange in ICU until his hemoglobin S reached 23%, and he was started on desferal infusion, entecavir, ursodeoxycholic acid, antibiotic, IV hydration, FFB, and last automated was done in before 3 months, and referred for BMT, and also he is following in hepatology clinic for also possible liver transplant. So this is increment of his ferritin and total bilirubin. It was coming down after exchange transfusion up to less than 250, and his ferritin is around 3,800, and this is hemoglobin S coming down up to 23%.
2 minutes, doctor.
Okay. So for the management of liver complication in sickle cell anemia, and this is presented by Ash, and actually they divided it in acute liver disease or chronic liver disease, either related to sickling process or related to multiple blood transfusion. I will go through this and I will skip because most of them is considering regular exchange transfusion until the patient reached end stage chronic liver disease. If he is young, so he is eligible for liver transplant plus bone marrow transplant. So in conclusion of sickle cell hepatopathy, aggressive exchange transfusion for acute or progressive intrahepatic cholestasis targeting hemoglobin less than 20%, but also to bring down total bilirubin level to baseline following by urgent stem cell transplant plus minus liver transplant. For intrahepatic cholestasis, consider regular oxygen transfusion as bridging with long-term follow-up, and consider refer to mass sibling stem cell transplant. And for benign hyperbilirubinemia, even indirect hyperbilirubinemia in the absence of hemolysis, close monitoring of liver function test trend, clinical condition of the patient, and imaging of the liver, we would consider it as persistent hyperbilirubinemia, the oxygen transfusion program as bridging followed by mass sibling allogenic stem cell transplant. I will go through the first case quickly. This is a 38-year-old female patient. She is known case of sickle cell anemia, complicated with refractory vaso-occlusive crisis. She is on hydroxyurea 500, sometimes 1000, and sometimes of hydroxyurea because of pancytopenia. Actually, this patient, she has a history of multiple admission with recurrent pancytopenia. And she has a history of acute syndrome twice with pleural effusion and ICU admission. She denied any CNS or venous thrombosis.
1 minute, yeah, doctor.
Okay.
Time is.
Yeah, no problem. So, because of this pancytopenia early in 2022, they did for her bone marrow, which was negative. At that time, she was found to have COVID-19 plus dengue fever. In the last year, this patient, she was admitted 3 times because of pancytopenia due to the use of drug hydroxyurea. Actually, we are manipulating the dose. Whenever she is coming with higher dose, which she came with severe pancytopenia, we stop the drug and we commence it gradually. Her count improve until reach it normal, and whenever we increase it to 1,000, again she is coming with pancytopenia. So in this year, she came 3 times with pancytopenia, and she has good regular follow-up in our clinic. And all the time we are doing for her oxygen transfusion to prevent complication, and she is on antibiotic, antiviral vaccination. And this is a trend in the last year. She has 3 times pancytopenia and neutropenia and admitted as febrile neutropenia. Finally, this patient was discussed in our meeting and said, this is hyperferritinemia because of frequent blood transfusion and oxygen. We discussed her in our BMT referral meeting, and she was referred for bone marrow transplant. We tried to commence L-glutamine, but unfortunately it was not available. So she was on regular blood transfusion, inoculation, and referred to our colleague in National Guard Hospital in Riyadh. So this, I have some information about hydroxyurea and sickle cell anemia. This is approved by MSH trial. This is a very multidisciplinary advanced study summary. This is a summary that it improves the rate of pain crisis, and this is also about the risk and benefit for long-term use of hydroxyurea. So our message from the last case that hydroxyurea is mandatory for all the patients, but some patients, they are not tolerating or sensitive. They have sensitive bone marrow. They are not tolerating hydroxyurea, but it was essential and important to our patient. It reduced the frequency of acute cell pain, acute chest syndrome, and reduced the need for red blood cell transfusion, hospitalization, and prolonged survival. And the patient should be reminded the effectiveness of hydroxyurea depending on their adherence and daily dose. And we have to monitor well MCV, hemoglobin F, consistent with progressive laboratory response, and all the time the clinical response of treatment to hydroxyurea. It takes 0 to 6 months. And thank you.
Shukran, thank you. Thank you, Dr. Jad, for sharing your experience with us. Very interesting cases about sickle cell disease management in Jizan. Now we'll move from Jizan to Katif, and from the experience of management of sickle cell to thalassemia. Our next speaker is Dr. Abdullah Zayed. He is a very well-known consultant in the Eastern Province and also in the management of hemoglobinopathies in Dammam and Eastern Province of Saudi Arabia. He had his MBBS from King Saud University. He is certified in internal medicine and completed his fellowship in hematology from Dublin, Ireland. As well, he is the head of the apheresis unit, and he established the apheresis unit in Katif Central Hospital for the red cell exchange and the plasma exchange in sickle cell disease. Also, he initiative for sickle cell disease and hemophilia as well. Dr. Zaid has established a specialized clinic for inherited blood disorder and pioneered outpatient plasma exchange procedure. He is active in teaching and mentoring medical residents while also contributing to various hematology associations. Dr. Abdullah will tell us about a new medication in the management of beta thalassemia major. It is erythroid maturation agent.
Thank you
You have
very much.
25 minutes. Yes.
Thank you very much, Dr. Ahmed. This is a very nice introduction. I'd like also to express my gratitude to the organizers, both Ssbmt and also SSH. Actually, my presentation will not be only luspatercept, but also what's behind luspatercept. So just be ready for some new information. But I have to start with some basic background. So these are my outlines. As you can see, I'm going to talk briefly about pathophysiology, current medication, the management, as well as the luspatercept mechanism, as well as the clinical evidence. Then I'll move to the novel and cellular therapy and what is the future directions that will be in the coming few years. So we've been taught when we were in medical school that these are the typical clinical features for sickle cell, for thalassemia, and this should not happen. We should not see it anymore. The mongoloid features, the frontal bossing, or the depression of the nasal bridge, or what's called the chipmunk facies. If this happens, this means that the patient is not well managed or he is not compliant to his treatment. So we know this may happen in certain areas, but this should not happen and should be a history, medical history, not anymore. So we know that thalassemia is basically a spectrum. It's not only one disease. So some patients may have no symptoms, so they are trait, and we have some patients who they have mild to moderate symptoms. They may require transfusion, so they are non-transfusion dependent thalassemia. And some patients, they are really hooked on transfusion, where they will be on transfusion to survive, and that's basically the transfusion dependent thalassemia. And these two groups, the non-transfusion dependent thalassemia and transfusion dependent thalassemia, we have guidelines for them from the TEF, the Thalassemia International Federation, so we are following these guidelines. And when we talk about the erythropoiesis, normally there are a lot of cytokines, the transcription factors, including erythropoietin, where this really maturation of the erythroid precursors are not always happening in patients with thalassemia. So basically, to understand it very well, normally we will have the two stages of the maturation. So the first stage is the proliferation, and the second stage is the maturation or the differentiation of the erythroid precursor. So that's the later stage. In thalassemia patients, what we have is an expansion of the erythroid progenitor. So that will lead to more erythroid precursors, and because of there is already high erythropoietin, but the maturation is defected. That's why we'll have impaired erythroid maturation. So basically, erythropoietin is high, but again, TGF-beta superfamily ligand is high. That's why we'll not have a proper formation of the red blood cells, and therefore anemia. And here you can see in the left side where the normal patients, they have normal red blood cell production, while in the right side you have the increment or the enlargement of the erythroid expansion, where the product ultimately will be very low and there will be anemia, and in addition to the hemolysis there. So that will result into multiple symptoms due to the ineffective erythropoiesis, anemia, iron overload, abnormal bone marrow microenvironment, in addition to the hypercoagulability. So the outlines of the management, normally some patients, they may have splenectomy in order to tackle the anemia and ameliorate the symptoms, and that will be on the expenses of developing more hypercoagulable state. Some patients, they will require transfusion to tackle both the ineffective erythropoiesis and the anemia, but that again will pay the price for secondary iron overload that will necessitate to have iron chelation therapy and to treat both the secondary iron overload and the primary iron overload. And you can see here that we have multiple targeted points. It's very complicated process, and to one lock that we will see multiple points that we need to look at. And some patients, we enrolled to JAK2 inhibitors, the gamma globin persistent, including hydroxyurea, the alpha globin mutation, and there are also some trials for the iron overload. But the most important part here is basically to look at these two here, the luspatercept and the pyruvate kinase receptor agonist, the metabivats. So what is luspatercept? It is basically a first-in-class recombinant protein that binds to select TGF-beta superfamily ligands and inhibit the SMAD2 and 3 signaling and enhance the late stage of erythropoiesis. So basically, the luspatercept will come and inhibit TGF-beta superfamily ligand, will lead to the inhibition of the cascade down intracellular and removal of the inhibition on the erythroid maturation. So we are basically inhibiting the inhibition, so that will lead to stimulation of the erythroid production. And this drug is being already studied in 2 landmark clinical trials. The first one is the Believe It trial that was studied for patients with TDT, transfusion-dependent thalassemia, and the study was published in New England Journal of Medicine in 2020. And the second one is the Beyond trial, which is basically for patients who are non-TDT, and that was published in 2021. And looking at the Believe It trial, you can see that those patients enrolled were transfusion-dependent thalassemia, were randomized into 2-to-1. Luspatercept arm was 224 patients, and the placebo arm was 112. And they were allowed to go into the open label phase up to 5 years in order to see the outcome. And those patients basically looked at the blood transfusion burden reduction more than 33%. And you can see here that the primary endpoint was already achieved, and see that the patients who were on the luspatercept arm achieved more than 33% reduction in 21.4%, while it was 4.5% on the placebo arm. And if you look at the subgroup analysis, it was all of them, but more with patients who are splenectomized and those patients who were non-beta 0, beta 0 group. And the side effects was acceptable. Most of these are headaches, arthralgia, back pain, and flu symptoms like. And that's not only for the blood transfusion, but also for the iron overload parameters, including serum ferritin and the MRI liver iron concentration. And that's why it was integrated in the management of the guidelines of the TIF guidelines. It is for those patients who are 18 years of age and above, so you can use luspatercept. On the Beyond trial, which is for the non-TDT patients, again, the patients were randomized into 2 groups and comparing them with the placebo arm. And basically, the endpoint was to have increment by 1 gram, at least by 1 gram. And that was achieved in 77.1% in patients who were in the luspatercept, while there was 0 in the placebo. And it was also evident in all subgroup analysis as well. And you can see here that 77.1% of the patient got 1 gram increment, and 52.1% got even more to 1.5 gram increment. And you can see some patients even they reach to 3 grams increment on luspatercept. Not only the hemoglobin, but also the quality of life, and that's reflected on the long-term follow-up on those patients. It was already integrated on the non-TDT guidelines from the TIF, and you can see here that any patient who are 18 years old and of age, they can be started on luspatercept. What about pediatric patients? This is only 18 years of age, but there are, in the last ASH, last December, we got some updates that they are using it for pediatric patients with promising results, but waiting to get more data to be approved to be used in pediatric patients. So this is not only for pediatric, but there are also ongoing clinical trial for the alpha thalassemia, and it estimated to be completed on July 2027. And hopefully you can be able to use it also for alpha thalassemia once the results are out. So what about cellular therapy? We know that there are a lot of the novel therapies, and thanks to Dr. Mohsen and Dr. Ihab for setting the stage for me to talk about the cellular therapy. We know that the curative therapies are basically either stem cell transplant or gene therapy in patients with thalassemia. And we know that the patient with thalassemia are between two options. The first option to go with blood transfusion and to treat the complication of the blood transfusion, iron chelation, and so on, or to take those patients to transplant early on, preferably below the age of 16, so that we will get the transplant earlier. Although there are complications like infectious complication, graft failure, or graft versus host disease, where we have to keep in mind that we do not really need to have this graft versus malignancy because this is a benign disease. What about if we do not have a donor? And many patients, they do not have donor for thalassemia patient. That's where the gene therapy comes in. And thalassemia was among the first genetic diseases that were proposed to get also gene thappy. And the advantages here are basically that we do not really need a matched donor. We do not really need to worry about graft versus host disease or graft rejection. And there was the clinical trials on genetic gene therapy. And we know that there are two approved medication gene therapy for thalassemia, the Beticel, which was approved in 2022, and it was the most expensive drug back then, and now the other therapies are coming, so maybe the prices will be less, and hopefully we'll get lower prices. So that's the Beticel, the Bluebird Bio company, the Zynteglo, and the other one is the Casgevy or the Exicel, and by Vertex, and this was approved in 2023, and thankfully we have this approved in Saudi Arabia, and that basically we are using it, and I have already one patient who came to me last week after gene therapy 1.5 years ago. The issue here is that whether to go with viral vector or CRISPR-Cas9 technology, the problem is that both of them, they will require busulfan myeloablation conditioning, and that's really bothering the patient to make them hesitant to go for gene therapy because of the side effects of this myeloablation. This has been already explained by both Dr. Ihab and Dr. Mohsen, so you can see that they already developed transfusion independence and up to 98% on the Casgevy patients. There are also the Bluebird, although it is not approved in Saudi, the Bluebird Bio drug, which is also published recently, the outcomes, which was really showing a sustainable transfusion independence up to 10 years, and you can see those patients, even all different age, pediatric and adult, as well as all the genotypes for the patient. I know there is some patients who are still did not achieve the transfusion independence, but this is also a good result that we have at least 90% of the patient achieve transfusion dependence. And that's why integrated into the TIF guidelines, any patient who were 18 and above, or even 12 and above, they can be sent for Beticel. This guidelines was in 2022. Back then, the Exicel was not approved yet, but probably it will be included in the updated guidelines, and likely to be included as well. The question is, who's going this expensive? So not all patients will be able to afford this treatment. You know, the Exicel is $2.2 million, and the Beticel is $2.8 million. That's very expensive, and most of the patients will not be able to afford it. And that's why we really need to have other alternative medications. And here we come to talk about the PKR agonist, the pyruvate kinase agonist, mitapivat and etapivat. And these two medication are already on clinical, completed clinical trials. The etavobat is already completed late last year, but it's not published yet. And hopefully we'll hear about the outcome of this phase 2 gladiolus trial that will show us the outcome of this medication. And that was supposedly to be completed last September. So coming to the metabovat or pyruvate kinase receptor, we know it's been already approved for pyruvate kinase deficiency patients, and it's been also used for sickle cell disease patients, but now we are focusing on the thalassemia, and here we are talking about both alpha and beta thalassemia. So we are only talking about these two clinical trials, which is the ENERGIZE and the ENERGIZE-T. The ENERGIZE is for non-transfusion dependent thalassemia, and ENERGIZE-T is for transfusion dependent thalassemia. So what is metabovat? It is a first-in-class oral small molecule allosteric activator for red blood cell specific form of pyruvate kinase receptors. So we know that the ATP inside the red blood cell is insufficient. That's why these red blood cells get hemolyzed, and that's why the lifespan of the red blood cell will be low. And what exactly metabovat does, it's activate the pyruvate kinase receptor, so the ATP will get more and decrease the buildup of the 2,3-DPG, and that will lead to increment in the lifespan of the red blood cells. That will lead to improvement in the anemia and also improvement in the ineffective erythropoiesis, and ultimately removing the iron overload and decreasing the iron overload. So what the clinical trial here is the ENERGIZE-T, where the patient were again randomized into two arms, the metabovat 100 milligram twice daily, 171 patients, and the placebo arm which was 87 patients, and they were into the double-blind period for 48 weeks, and they allowed to go into metabovat after the blind period up to 5 years. And the target point or the primary endpoint was to get a transfusion reduction response, and that was defined to be a 50% reduction or more, plus more than or equal to 2 units reduction, and that was the primary endpoint for. There are also secondary endpoints that was in the clinical trial, and you can see here that we have 30.4% of these patients who were on the metabovat achieved this primary endpoint, which was very successful. Coming to the non-TDT patients, the ENERGIZE, so these are the non-transfusion dependent patients. Again, they were randomized 194 patients into 2-to-1 randomization. 130 patients were on the metabovat 100 milligram BID, while 64 patients were on the placebo arm, and they were followed up to 24 weeks. They were also allowed to go into the open label phase, which was up to 5 years. And it was published with showing very good result as well. You can see the graph here, the increment of the hemoglobin as well as the improvement on the fatigue score for the metabovat arm. And you can see that metabovat arm has achieved the endpoint, which was 42% in those patients. Will you dare to compare both luspatercept and metabovat? Well, somebody already did, and dared to compare both of them, and it was published. Very nice article. Who is interested and read more, I would advise to read this very nice, nicely written review. But in summary, so luspatercept versus metabovat, we know that luspatercept only for beta thalassemia as of the moment, but it can be also used for myelodysplastic syndrome patients. It is subcutaneous injection every 3 weeks that you need to escalate the dose if needed, while in the metabovat, it's been already approved for pyruvate kinase deficiency and both alpha and beta thalassemia, transfusion dependent and non-transfusion dependent, and there is already ongoing clinical trial for sickle cell disease patient, and hopefully the Rise Up clinical trial will tell us that it is also can be used in sickle cell disease patients. So it is an oral tablet, typically twice daily with a fixed dose, and hopefully we'll hear good news for our patient with sickle cell disease. Whether they can synergize with each other, this is only can be told when we come to the real world data, and hopefully we can use them both together to synergize each other. Looking at the horizon, so what is there is basically that when we look at the cellular therapy, we know it is technically demanding. There is chemotherapy, and there are organ toxicity, the infertility issue, and those patients require to be admitted in order to receive this cellular therapy. And also the cost is very expensive, in addition to the worry that some off-target side effects and long-term safety profile is still unknown. So we have two types of gene therapy. We have the ex vivo, which is the currently approved medication, where this patient is basically got harvest the stem cells and then getting the transplant after giving the conditioning chemotherapy. And this is basically what at least concern me and concern the patients. But it is really proven safety and efficacy, but again, the side effects that may happen over the years makes people worried. And the cell processing needs really advanced center, high cost, hospitalization, as well as the toxicity of the conditioning itself. But on the other hand, where an in vivo gene therapy is basically with the use of viral vector or nanoparticles that can be injected directly. So it can be really a simple method, can be a walk-in basis with a low cost, with also off-target delivery much less. And in this situation where we can give it without getting much of worry. So this is the current standard of ex vivo gene therapy. The patient go to the apheresis machine, get the cells to the lab to be bioengineered. Then the patient will be given chemotherapy conditioning, and then the transplant, where the patient will be isolated for at least 4 weeks. And that's really what most of the patient doesn't like, to go in that prison or jail for that isolated room. But what we are really hopefully will get in the future is in vivo delivery, where only the LNP, the lipid nanoparticles, can be done in the lab and then can be intravenously injected to the patient as an outpatient setup. So there are a lot of curative strategy landscape going on, and where it is heading, I said already about the ex vivo beta cell and X cell, but we have what is called the base editing to induce hemoglobin F, which is also rapidly advancing. We have the in vivo editor delivery, which is the lipid nanoparticle stem cell transplant, but we have also the epigenetic hemoglobin F induction for those patients. So basically, there is already an a preclinical trial for non-chemo conditioning gene therapy is being already studied on animals, and we know these all can be done. So what they give is basically a CD45 antibody drug conjugate. So this is CD45 ADC, and this is showed really a comparable engraftment with also hemoglobin F reactivation. It was similar to TBI and busulfan, and basically what will be is really a paradigm shift or a game changer, where we do not worry about the myeloablation, so there is no worry about the organ of the patient or the toxicity of the chemotherapy, and hopefully we'll get this just simple infusion in the near future, and hopefully in the coming few years we'll hear more about this. And that showed also good result and efficacy in terms of the proven durability and sustained clinical benefits. What about the less invasive and conditioning free? So we do not give conditioning at all, and that's basically the lipid nanoparticles that can be given in those patients where this LNP goes into the cell, and that will produce the editing for intracellularly. That will be really hopeful without any worry. It is a non-viral delivery system, eliminates the needs for collecting and mobilization of the stem cells, but it provides a potent and one-time treatment potential for blood disorders such as sickle cell and TDT. The worry is that with the standard LNP, that there might be a trap in the liver. That's basically an off-target, but hopefully with the optimized LNP 168, these cells will go directly to the stem cell and the bone marrow itself. So the last but not least, the DMT207, which is a novel hemoglobin F inducer, which is been already studied on preclinical setup that it is showing really a good result and even better than decitabine. And you can see that decitabine increases the hemoglobin F, but with toxicity, while in the DMT-207 is improving the hemoglobin F, but with which was safe as well. And that was already showing here. This is basically the spleen of the mice, and you can see the size of the spleen was enlarged with the DMT-07. That spleen size has regressed. The take-home messages here are the luspatercept is really a validated medical disease modifying option that can meaningfully reduce the transfusion burden in both TDT and non-TDT patients, but beta thalassemia patients, while the pyruvate kinase receptors agonist is really very promising, whether to be used alone or to be added to luspatercept. That's a question to be answered with the clinical practice, and it is used for both alpha and beta thalassemia. We have the gene therapy, which is really approved, and we have more than 90% transfusion independence, were really promising. But the coming new generation for in vivo delivery or even non-chemotherapy conditioning, that will be showing as of the moment in the preclinical status, and hopefully we'll hear more in the coming few months and years. Thank you very much. With this, I conclude.
Thank you, Dr. Abdullah. We'll come to the last talk, Challenges in Thalassemia for Precision Medicine, Evidence-Based Research. It will be with Prof. Suad Al-Jaouni. She is a professor consultant of hematology and pediatric hematology oncology in King Abdulaziz Hospital, over 35 years of experience. She founded a division of pediatric hematology oncology in King Abdulaziz University and had multiple leadership roles in various organizations and more than 35 research papers that she published and recognized in the top 2% of scientists worldwide by Stanford University. She actively participated in international conferences, keynote speakers, and hold important positions in the academic and research committees. Prof. Suad.
Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to thanks the organizing committee, especially Prof. Ahmed Al-Askar, and to be last speaker after all this excellent presentation. I don't know what I can add. We'll see. Inshallah. Okay, and thank you for the kind introduction. The outline of my talk will be the potential of precision medicine in thalassemia, the prevalence of gene in thalassemia, natural history and pathophysiology, just titles. Then we summarized the challenges in the diagnosis and the treatment as cases presentation. Problems and challenges, sometimes not solved completely in the clinical trial. Chronic pain, it's common in thalassemias like sickle cell disease. Is there novel to improve the quality of life for thalassemic? Is there a novel stem cell for the neonatal hereditary blood disease, and the importance of prevention? Everybody would like to go for precision medicine, especially chronic diseases and thalassemias and hemoglobinopathies really need wellness vision. Improve equality in both diagnosis and treatment. It's a comprehensive, it's a holistic approach, and improve the outcome of the patient and patient satisfaction, happiness, and have normal life. I add to wellness vision, it's treatment for all, because these days start to be treatment not for all. Early detections of disease risk, solve the challenges, which is really important, prevent disease complications, keep the patient out of the hospital, and the safety of any medications, tolerable safety, and satisfaction of the patient. No relevant disclosure. Here, just the map to see in Saudi Arabia, there is different areas. And if you look to Jeddah area, we have around 40% alpha thalassemias, beta thalassemia, lesser, and E, and other hemoglobinopathies. Here, like, because we are in Jizan, it's unfortunately, it's the highest of inheritance for beta thalassemia. So I'll hope next year with our programs will be, this prevalence will be changes. Thalassemias decrease synthesis. And really here, I would like to put for our area alpha thalassemia, we have it's different alpha thalassemia than Far East. Well, luckily, like we have the prevalence of silent carriers and alpha plus. We don't see, we have some areas more than 40% alpha thalassemia. We have H disease in our area. We don't see much like stillbirth. This is the one I would like to put attention because really I will go with you with cases for diagnosis, challenges in diagnosis and prevention. Like here, like beta thalassemia major, there is no A, but should be a clinical, ask about the clinical, they require transfusion less than 2 years. This is nice to see how a free alpha chain can cause all these problems. I summarize the natural history and the treatment of thalassemia in these pictures. And I add, like, if you don't have treatment, what will happen to the patient? Transfusion complications of iron overload, the oral chelations, and the stem cell gene therapy. And there is a novel for pediatric and a novel for hemoglobinopathies. All the time, we need to look for the goal of iron chelations, like safety of the tissue iron, and the other thing, acceptable toxicity. All the time, we have a lot of novel researches and novel treatment, but look for acceptable toxicity. And the most important for the all goal of iron chelations is prevent stress oxidative damage, because this is affecting all organ. Challenges. Thalassemia, because it's a chronic disease, have a lot of challenges. So all the time, availability for diagnosis. Some of the patient, they don't have even the diagnosis. They don't have the eligibility for the treatment. They don't have like enough available blood transfusion for them. So the trend was before for increasing the splenectomy complications. And now about more and more we can see about the quality of life for their patient. Just I will go quickly for challenges in the diagnosis, premarital screening. All the time I put this picture because I kept seeing more and more unfortunate. This is my patient, the groom. He is thalassemia intermedia. He want to marry. This is his bride, and this is her CBC. Her CBC, if we put it in the exam and all the time, we need to keep it in mind. The patient look like mild anemia, microcytosis, and the patient hemoglobin electrophoresis is normal. So the things like, if we look to this, I put mark to see, is this marriage is compatible or not? What your answer? Most likely, what you'd like to say, yes or no? Thank you so much. Yes, it's very simple. If we look for RDW, it's high. So it's really iron deficiency anemia. This is why hemoglobin A2 wasn't high. So this marriage, unfortunately, it's not. And they get married, and they have 4 thalassemia daughter, okay? And they have the complication later. This study long term, just when we start, we look what the survival and the disease complication. I put this study for 14 years retrospective to see what the cause of death. It was 2 causes because that time only we have this feral injection. So the cardiac was in younger teenager, iron overload in the heart, and second one, the infection in children, they are splenectomized. Challenges in the diagnosis, like is serum ferritin accurate assessment for cardiac iron overload? And this is a 15 years old boy. He was treated while he was child, thalassemia transfusion dependent. He presented lated with intermittent claudications. Growth parameters were normal. Mean serum ferritin less than 2,000. Cardiology assessment normal. So we sent him to Royal Free Hospital for MRI to start in 1995. So if we look to the picture with the arrow, a big difference between the two, and then we get the result, why he had intermittent claudications, because severe iron overload, so has been treated with oral chelation, and he is fine. Now, compatibility and availability of a blood transfusion. Thalassemias, its problems and challenges because over the years. The more they are growing, the more there is a problem. If we look here for this thalassemia major patient, she is phenotyped properly, she is giving screening well, giving blood, no antibodies. During 2 years, she received 43 units. And if you still look, her hemoglobin, it dropped to 6 and 7. So availability of transfusion, until now, there is no artificial blood transfusion. We face it in some patients. Challenges in iron overload. This is a patient, he presented, he's excellent, he is compliant, is good with XJADE. His serum ferritin is 578, which is excellent. He is all the problem complaining of chronic fatigue syndrome. He is the one highly educated, graduate from the state, he is working, but he said, when I'll go to the work, really like every single of my body, like I'm pushing myself for work. He's smart. When we do MRI to star, he's severe liver iron overload. Okay, this is another girl, thalassemia major transfusion dependent. She is followed in private hospital. She's all the time, her serum ferritin very high, around 7,000. She's on XJADE. When we ask her how you should take XJADE, she stuffed the tablet, so without drinking much blood. So unfortunately, when we do her MRI to start, it was severe iron overload. But unfortunately, the hair physician in private hospital decided to remove the spleen because the spleen can solve the liver iron overload, doesn't make it worse. Here the patient, I change her from XJ to Jadinu, and for her, I put her on 3 times this feral. If we look for her MRI to start, markedly from severe to moderate. But the patient, she wasn't happy with like injection of this feral. And Jadinu, it's not enough for her. Thalassemia intermedia, please don't treat thalassemia intermedia like thalassemia major. This is a patient, he had, if we look to his diagnosis, just if we look to the diagnosis, his electrophoresis like thalassemia major. But if you go to the history, over 14 years, only he had 8 times transfusion. So please don't go with electrophoresis history, very important. This patient, his serum ferritin is 1,500. He has a problem with severe iron overload in the liver. This patient, unfortunately, he's died 2 months ago with pulmonary hypertension. This is a young patient, thalassemia intermedia. Unfortunately, she's splenectomized. She was well until she became at 20 of her age, start to require more transfusion after she get married. And unfortunately, her platelet count higher 1,000,000. And she had abortion, and she presented to ER with hemoglobin 5. Before, no problem. And she had like moderate iron overload. So thalassemia intermedia, it's naturally different from thalassemia major. We need to consider that. And if you look to your centers, we have a lot of thalassemia major still alive. Thalassemia intermedia, unfortunately, they have a lot of complication, morbidity very high. So we recommend all centers, anybody to treat thalassemia, they should have MRIT to start routinely for follow-up. Okay, is splenectomy increase the risk? Just one study, like here, the patient splenectomized all the time. Everybody loved to remove the spleen. It was a trend, alhamdulillah, change. This patient, the idea is if you remove the spleen, you remove the iron with it. If you remove the spleen, you minimize the transfusion. Let's see this patient, 34 years, E beta, thalassemia intermedia, the platelet 2 millions. And this patient, she had frequent blood transfusion before. To certain age, this thalassemia intermedia, she become requiring a lot of transfusion. If you look for each year, because she come with very low hemoglobin, and he had iron overload very severe. Her platelet sky high, her hemoglobin with in spite of all transfusion markedly down. This is see how much she is receiving. Another patient, okay, splenectomized, splenectomized, more transfusion, more abortions. Okay, so really, in spite, if you do all the phenotyping, giving good blood, they required a lot of transfusion for certain age. This is as a summary of her transfusion before, no problem. When she get like on 20s, she had more complication with the sky high platelet and abortions. 38 years, the same, but his serum ferritin wasn't high. It's the same, he had like iron overload with MRIT to start. So conclusion, splenectomy does not minimize transfusion, does not prevent anemias. It's accelerate the hepatic and cardiac overload. Splenectomy. Can we avoid splenectomy? Yes, we have this study over 17 years with hydroxyurea, do good job, but you need to be very patient. Endocrine complication. Did we get better? Let's see in our studies. We have a lot of a study on endocrine in our center with collaboration with international network of clinician endocrine. What we found, pediatric and adult, there is increase in endocrine complications. I will not go through because we have another message. Start to have seeing more of glucose dysregulations in our patient. I will skip all this, okay? Chronic pain. Chronic pain we presented in 22 in EHA about chronic pain for thalassemia major, and recent study has published with Journal of Applied Hematology. What we found, it's a problem for the patient, and some of them, they are in narcotic. If you look for quality of life, tell me, all of the quality of life is very bad, and it's unfortunate. So it's not only to give medications, you need to have normal quality of life for your patient. Okay, so conclusion, chronic pain is common. It's a major problem. Unfortunately, it wasn't addressed well. Non-analgesic, narcotic, it's not the ideal. There is a solution for them. Is there a novel therapy to improve the quality of life and chronic pain for thalassemia? This patient, he is like 38 years old, thalassemia intermedia. He has a major problem of shoulder pain. He said, even I cannot eat, and back pain. So referred, we have in our center wet cupping clinic. It was established in 2012, and he referred for this severe pain. And also he had a frequent transfusion like thalassemias. If you look in a year, he received too much transfusion lately. So after a cupping, he markedly improved. But what we see after cupping, so even we try his requirement for transfusion decreased, his serum ferritin decreased. The amazing this one. Look to his like iron overload in the liver. All our study, it's done in Netherlands because we don't have a software, unfortunately, recently. So that the MRIT to start in our hospital, we send the result to Netherlands to read it. If you look to his liver, from moderate and become normal after 3 cupping. So this is a great news. This is another patient. He has a major problem with increased liver enzymes. He had vitamin D is low in spite he is in oral drops. What we found after cupping, because of severe back pain, he is a young chap, he is like working for the family. We try, if you see his serum ferritin, from 4,000 to 3,000 from one sitting. And severe iron overload of the liver. The amazing, if you look to the figure here, after the first cupping, what happened to the patient? There is immobilization of the liver. I didn't tell in Netherlands. They said, what invasive you are doing? It's like if you look for the scan is completely different. Okay, so this is a patient, marvelous patient, young patient, thalassemia major. All the time, her menarche stopped, and she had a chronic fatigue syndrome referred by her OB-GYN. She had severe iron overload for the liver, liver enzyme is high. The amazing, after the first cupping, from 8,000 to 4,000. So it's a marvelous, like for me, like I found really should be all center trained to do cupping. This is the first paper we published. See, all the diseases has been referred to cupping therapy in our center. Okay, so we found cupping has improved the brain, removed the iron overload from the liver, improved the anemia. So, is there any further study for cupping therapy? Yes. Okay, now we'll go with you with this is a study to see chronic in our center. Unfortunately, the majority of referral is pain, headache, infertility, allergic, autoimmune, okay? And improve the quality of life. This is a study, it's amazing. Would like to know why this cupping therapy improve the quality of for pain. This study has been published in Oxford Academy, and what we found, all the inflammatory markers markedly down. There is 17 interleukins, new interleukins. They are waiting for us and will be maybe a Nobel Prize. This is the result. How after cupping, there is markedly improvement in inflammatory markers, and there is 16 interleukins, a natural killer. Okay? So wet cupping, this is from Academy, shows wet cupping remove oxidant and decrease oxidative stress, this is what we need. Okay, this is a clinical trial has been, I'm part of it. What we found in this one, we found like immunity markedly increased for thalassaemic patient, this one children. It's a clinical trial. It was addressed and registered as a clinical trial internationally. And the oxidative stress, prevent the oxidative stress for thalassaemic children. And this is what I want. And this is, anybody please read. This is another pilot study, also in children, how this, it's safe to do wet cupping therapy for thalassaemic children to decrease the iron overload and increase the immunity. I would like, this is another paper, please need to be in hand, certified hand to do wet cupping therapy. Wet cupping therapy, it's a treatment. What happened, the difference? It should be in epidermis. The needle, the scratch of the, should be in only epidermis. If you go deeper, it's not a cupping. So should be a certified who doing cupping therapy. How the mechanism remove the iron? So a lot of papers, I recommend with a comprehensive care in all center. It's cheap, it's excellent result, and it's for emergency. We lost a lot of patients like you give. These viral infusions, if you start, no, nothing stop them. So should be certified cupping therapy clinic. We need to have the wisdom of traditional and should be impactable and a solution for a lot of diseases. This is, I was...
1 minute, yeah, Doctora. 1 minute, Prof.
1 minute?
Yeah.
Okay. Novel treatment. In Australia, they said milk of the mother have stem cell. Then start to be a lot of paper, stem cell in the milk of the mother, a lot of paper, and now they use it for premature babies, okay? And then there is a recent study from Iraq, University of Iraq, shows a randomized clinical trial, how if you get a non-mother breastfeeding, it's work like a novel stem cell. So for me, if you would like to see it and see the result. Conclusions, how we can no more complication of thalassemia, preventions. This is take-home messages. Please look to this one, then do that one. Thank you so much.
Thank you, Prof. Saad. On time. I will ask all the speakers to come to the stage here for the 10 minutes. We have only 10 minutes for question and answers. Dr. Ihab, Dr. Jad, Dr. Abdullah, Dr. Mohsen al-Zahrani. شكله طلع. طبعا نشكركم لتواجدكم إلى آخر لحظة. Any questions?
Yeah, thank you all for great talks. Maybe this question for Dr. Abdullah. I mean, mitapivat versus luspatercept. I mean, how do you see the efficacy? And if anybody used mitapivat, I know we used it in a clinical trial in 1 or 2 patients, part of this clinical trial. I don't know if Abdulrahman Raiza is around or not. But I mean, what's your, have you used it or, I mean, what's your impression about it? I know the study showing positivity and it's been FDA approved based on the study, but in practice, mitapivat versus luspatercept, what do you think?
Good question, and everybody would like to know the right answer for this. And if we are going to look at the studies and compare it both of them, it might not be really easy to extrapolate the answer. However, I haven't yet used it, so mitapivat. I used the Ssbmt in 2 patients. It's showing some improvement, specifically talking about the baseline hemoglobin, so there will be increment and also reduction in the transfusion burden. I would say asking the same investigators who did both trials, like this is, I should not mention the names, but we asked specifically about, they said mitapivat probably more potent, but is this going to be reflected on clinical practice, whether we will have this supported by real world evidence? That has to be answered with the time. Otherwise, you cannot really compare.
Thank you for the excellent session. Actually, I have a question to Dr. Ihab, Dr. Gadalla, and Professor Dr. Suad Hanem. I will start by Dr. Ihab concerning cases of sickle thalassemia. In Egypt, we do have more incidence of sickle thalassemia rather than isolated sickle. Would you like to use in such condition XSL or LOVO cell? LOVO, of course, is better with the alpha thalassemia concerning other types, beta thalassemia or something like that. And my second question, do we have documentation of improvement of by T2 star cardiac iron deposition after using gene therapy for cases of sickle cell?
Thank you for your questions. To differentiate between the two, there were patients who had S beta 0 in the trial, XSL, and in the LOVO cell. I think it's a different approach. I think I don't see that clinically there will be difference in terms of response. Both will probably equally have a good response. Maybe theoretically the gene addition, because it will only add the S, so it will only change the S type. So maybe it will have less response than the XSL because of that, because the other gene will be a beta gene rather than a sickle gene. So I'm not sure if they've included patients like this in the gene addition trials or not. But I can see that maybe it will not be as efficacious and you would use XSL in this situation. For your second question about cardiac ferritin being reduced after the therapy, I think most of the patients that were included in trial actually were very good treated patients. So the range was like between 1,000 to 4,500 ferritin before they started the treatment. So there were not patients with very high ferritins or iron overload entering the trial. And if you have someone with high ferritin or high iron in the heart, and to the degree that it's affected their cardiac function, this type of patient would probably be excluded from the trial. But looking at the data, you have 70% of patients required 6 months of therapy and then they stopped. So theoretically, if the cardiac iron was of low level, you would expect it also to respond like the liver. There is no data looking at the cardiac iron, because I suspect that most patients, or maybe all patients, actually didn't have much in terms of cardiac disease as they enter the trial.
Yeah, sure.
Dr. Gadalla, thank you for your outstanding cases and moreover, excellent management. Concerning your second case, the lady with contraceptive device implant, do you think that this is a wise decision to implant hormonal device in a patient with sickle cell disease, and in the same patient in such aggressive thrombotic episodes? Do you think that we might have some inherited thrombotic or thrombophilia apparent in this patient?
Yeah, thank you for your question. Regarding contraceptive in sickle cell, you know that sickle cell patient, they are hypercoagulable status and usually are not preferring to use oral contraceptive in form of
We don't use
hormonal at all.
Yeah, in
Yeah,
Egypt,
we
we don't use
prefer
it.
to use like IUCD and other normal preventive of pregnancy.
Mhm.
But this patient, يعني unfortunately, she implanted out of our advice and she's not on regular
Especially
follow-ups.
after the DVT with her previous pregnancy, I
Yes.
don't think this is at all indicated, even it is
Yes.
contraindicated for such lady.
Yeah, unfortunately, she's not following with us and until she came with this massive PE. And we are not advised, and such patient, especially she had history of previous DVT and she came again with this massive. We are not advising for this.
Okay, concerning your third patient with thousands transaminases, do you feel comfortable to prescribe Desferal for this patient, or you prefer Deferazirox or something less hepatotoxic?
If the ferritin is very high, it's better as the patient is hospitalized, he will stay with us. We can start this feral infusion for more and fast decrease in ferritin level. And whenever we are comfortable, then we can transfer him to Defracirox or Jadneo, this medication.
Professor Suad, my question is regarding cupping therapy. Do you think that it will be more effective in cases of sickle cell because we are having more inflammatory process, more affection to the complement? And I think in that context, if you are showing us such fascinating results of decreasing inflammatory marker, this could be more beneficial for patients with sickle disease, or are you intending to do a study on this group of population of your patients?
Thank you very much for this question. We did on sickle cell disease. The patient of sickle cell disease, they came to us. But the problem with sickle cell disease, we don't do it except if they are in Jeddah area, because like cupping, there is improved some of interstitial fluid. And one of the patient, she came, she insisted to came after she see the result of Prof. Hassan Abdel Jabbar about the infertility. She's a sickler, she is a nurse. She had, unfortunately, severe pain. She said, do it for pain, and her planning to get infertility, to be infertile. So we did for her. But she was ended in ER with severe pain because we told her to drink a lot of water. We are removing fluid. She said, yes, 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 I will do. So after that, only we do sickle cell disease, who they are required and compliance to drink much water. We have like sickle cell disease, we have now in our study, we have a 24 patient. We'll publish it later. Most of the patients coming from the south, one of them travel 16 hour, I don't know, to be coming to do, it's a sickle cell disease. It's remarkable improvement in their quality of life. But about MRIT to star, we do MRIT to star to compare between thalassemia and sickle cell disease. Natural history completely different, and there is no iron overload like thalassemias and like thalassemia intermedia.
Excuse me. Thank you for the all speaker. I have two questions. First for Prof. Suad, regarding the same for cupping therapy. With this evidence from our region and international, I see clinical authors from international level. I don't see the cupping therapy as one of the recommendation in management of iron chelation therapy. I mean the guidelines or recommendation also. Why is not there till now? And what about if we can extend the clinical trial and evidence from our region and to include it in our guidelines, at least locally, if it is positive value?
This is excellent. This is why I presented. For us, two clinical trials register internationally, and there is a 12 paper to see the pathophysiology, how improve and how the mechanism to improve the iron, and even there is publication to improve the anemia. We will be happy, but should be certified cupping employee, staff, because really, if you go deeper than epidermis, it's not a cupping. Okay, and really I would like to call for multi-center. Now we are applying for clinical trial for our patient for thalassemia. Will be nice if will be combined if you have cupping therapy patient.
If I may, just one comment. And I think I just want to alert, I think, our audience. This is still in, I mean, Dr. Suad, I think, is studying it. So it's not necessary, not yet, I mean, evidence-based. But I see that's your experience now.
It's evidence-based because two clinical trial register internationally, and there is 10 paper.
No, what do you mean? Clinical trial registered internationally?
Yes.
Is when we do clinical trial, we register it internationally.
Yes.
But doesn't mean that's evidence yet. So the evidence comes after it's published in peer-reviewed journals.
True.
Probably
true.
that's what you want to say.
Right.
So
yes.
is it published in a peer-reviewed journal? Then that's evidence is there, but it doesn't mean it's granted. It means that for the peer reviews to assess it. So any study, for example, these medications that we see, I mean, presented today, it doesn't mean that this is the end of it once it's published.
True.
It's
true.
for others to assess it, and maybe one is better than the other. Again, unless you do randomized clinical trial, so the evidence is graded, and there is evidence by experience, and there is evidence by randomized clinical trials, and
it's the last it's a randomized clinical trial. All the publications there. So it's randomized clinical trial. There is control. There is a randomized patient. So the things, this is the things I would like to be like toxicity. It's much better, the safety and the cost, and the evidence of it, it's there, and the mechanism is there. So I believe we need to have multi-center to get benefit for our patient. And now, it's unfortunately now, a lot of thalassemia, they are not involved in any center for treatment because of eligibility. And if we see the cases and have been pilot study first control, the second one, it's a randomized clinical trial, and 10 mechanism how the iron overload improved. So I believe it's for us, let our patient get benefit from this. And like if now we do for our patient, central line, PIC line, we put everything in our patient. This is not, it's very safe, and remove the stress oxidative damage from the organ as fast as possible.
all right, you can conclude.
So you mentioned that one of the excluded criteria for So what is the rationale behind?
Yeah, because the gene therapy, to prepare the patient for collecting his stem cells, they need aggressive blood transfusions or exchange transfusion for 2 months. So if you have a patient, and we have this scenario, a patient came to us, he's eligible for gene therapy, but the blood bank could not provide any blood. So you cannot do a stem cell collection for him, and also preparing him before giving bisulfan. It is essential to prepare him for 2 months with transfusion or exchange transfusion.
If the blood is available.
If blood is available, okay.
So it is not
Aluminization by itself is not exclusion.
Okay.
The case if you don't have blood.
Okay.
Because of the aluminization.
So just I would like to know what is the national strategy for gene therapy in the future. You did maybe the most number of cases in the kingdom, maybe, or even. in the region. So do we have a plan or strategic plan for the future about our target, the number that must be done? You know, we have high prevalence of sickle cell disease and thalassemia in our country.
Currently, it is center-based, the treatment. There was initially, maybe 2 years ago, some effort from MOH to create national recommendation guidelines. We had multiple meetings for that, but we did not see any outcome from these meetings. I agree with you, it should be at the level of MOH. They should have strategic plan with these expensive type of therapies, how to deal with it, how many patients need it. Some countries, they have good exercise, like in Bahrain. They screened all their sickle cell disease patients, and they come with a very clear algorithm to those clearly who need the gene therapy, and they are taking them according to this pathway. We don't have, unfortunately, we don't have that in our country.
Thank you. I would like to thank all the speakers. Excellent session, excellent discussion. I will close now, sorry. We have, because another activity at 7:30. You are all invited for a satellite symposium at 7:30. It is about 1.5 hour activity, followed by a gala dinner around nice weather outside, around the pool. So you are all invited on behalf of Dr. Ahmed Al-Askar. Thank you very much.